Yes.
YouTube videos मध्ये
So we are going to start the program within.
Nadia. എടാ നിനക്കപ്പോ അവരെടുത്തുനിന്ന് ഇത് അഡ്വാൻറ്റേജ്
So we are. So we wish.
ചോദിക്കാൻ പറയടാ
Guru silent.
ഞാൻ പ്രതീക്ഷ എന്ന് പറഞ്ഞു ഫ്രണ്ട് പക്ഷേ ഇത് അതും സർക്കാർ എൻ്റെ കൂടെ
Yes. We wish each one of the good morning, as well as good afternoon, as well as good evening to all the participants. Meanwhile, we ask you to all the participants to keep mute of audio while speaker is giving his or her talk. If you have any problem with uploading of your PPT, you can send to us through either email ID or through WhatsApp number. We can play behalf of you. Yes. Myself, I introduce again Mr. Bhubadatta, representing Innovant Conference, welcomes all distinguished guests, doctors, scientists, educators, colleagues, friends, ladies and gentlemen. It's a great honor for me to welcome for day 2 of the conference, that is Virtual Nursing Conference, which is going to be happen today, the September 25th. I would like to express my most sincere gratitude to your presence in this opening ceremony as a great way to initiate the scientific program. Again, we especially thanks to Mr. Renal as well as Ms. Shilpa who have him there but is responsible to have happen today. I would like to express thanks for participants, especially those who are joining this event from miles and sharing your valuable experience and ideas. With a good number of participants, I am sure this conference will be memorable, highly educational, not a missed event. As we successfully completed day 1 of the conference yesterday, today we are going to cover the topics like nursing management, surgical nursing, dental nursing, international nursing education, cardiovascular nursing, healthcare, nurse practices, new technology in nursing education, innovations in nursing education, types of nursing education, women healthcare nursing education, cancer, women healthcare, different topics we are having. We are having like gynecology and obstetrics, breast cancer therapies, nursing practices during COVID-19 pandemic, as well as not the least of this topic will be advanced nursing practices for COVID-19. Make sure to introduce everyone at the beginning. Ensure that you keep clean, appropriate background. Look into the camera when talking instead of looking yourself. Be aware of your audio and video settings. So today, we are going to start with Professor K.M. Jacob, Chief Physician from Marma Healthcare Center from Kerala, from India. He is going to start with opening ceremony.
Thank you all. I want to share my screen.
Possible, you can add, you can open your radios, video as well as.
Okay. Can you see my screen?
Yes, sir.
Yes, okay. Jacob Mattai from Kerala, India. Today I want to discuss with you the subject is does fever increase or decrease blood circulation? Let us examine the present state of fever. One medical book says our understanding of the motor basis of thermoregulation fever is still rudimentary. The role of fever in defense reaction is not clear. My first question is how can fever be treated with rudimentary knowledge? The fact that the patient does not know that the fever is being treated by rudimentary knowledge is the basis for the survival of the physician. A scientific approach is necessary to evaluate and treat fever. Finding the answers to following 10 questions can clearly show whether the temperature of fever increase or decrease the blood circulation. First set of 4 questions, then 10 questions. Does fever increase or decrease blood circulation? This is the first time many people have heard such a question. When it comes to treating back pain, neck pain, and knee pain, it is often heard that the cause of the pain is reduced blood flow. First point is decreased blood flow signs symptoms. As the disease progresses, blood flow decreases. Body tingling, body aches, and narrowing the blood vessels under the skin are the signs, symptoms, and signals of decreased blood flow. Signs, symptoms, and signals of decreased blood flow show before the onset of fever. Decreased blood flow can lead to death. It is well-known fact that as the disease progresses, blood flow decreases, and this can lead to death. When there is a decrease in blood flow, and and its signs, symptoms, and signals, the immune system do actions to increase blood flow to save lives. To this day, no one has heard that fever is caused by poor blood flow. Relationship of blood temperature, viscosity, and pressure. When the blood temperature are decreased from 36.5 to 22 degrees centigrade, the mean blood free flow time increased from 11.6 to 15.55 seconds. That is 26.13 percentage. When temperature increased from 36.5 to 39.5 degrees centigrade, the blood free flow time decreased from 11.95 to 10.58 seconds. That is 10.38. Erythrocytes free flow time also different. The plasma free flow time is also different. What is the purpose of temperature of fever? When this is made by the bacteria, fungi, venom, horosine, and horridrim, etc., becomes a threat to life or organs, blood circulation decreases. Temperature of fever will emerge to increase prevailing essential blood circulation, and it acts as a protective covering of the body to sustain the life. It is an adaptation. There is no way other than this to increase prevailing essential blood circulation for a sensible and discrete immune system to protect the life or organ. In all diseases which decrease essential blood circulation and temperature, fever will emerge to increase essential blood circulation and temperature. A brooding hen's body temperature increase like that during fever to increase essential blood circulation in the body. The brooding hen does not eat any food. Brooding hen's food is its heat, which help to convert fat into energy. When the hen is brooding, the temperature of hen does not exceed the limit because hen's immune system produces heat with a clear purpose. Once that purpose is accomplished, that increased heat will disappear or the production of that extra heat will stop. Similarly, our immune system created temperature below 42 degrees centigrade with a clear intention of saving the life or organs until the last moment. Once that is accomplished, our immune system will stop to overheating. Next point, the heat of fever increases blood flow. It has been proven around the world that all types of heat increase blood flow. The heat of fever increase the blood flow. Heat increase blood flow by expanding blood vessels. Increase in blood flow can help to relax a tight muscle, restore movement, and reduce pain. Fever increase blood flow, which means more lymphocytes flow through lymphoid tissues. If heat of fever increase the blood flow, reducing the heat reduces the blood flow. It will increase inflammation and infection, and finally, death will occur. According to physics, it is foolish that when fever temperature is reduced, shows the symptoms, signs, and signals of reduced blood flow are ignored and then treated to reduce the heat again. Fever is the fever is heat energy. To date, modern science has not studied what actions were carried out heat on fever. The cause of all complications, including death, is the treatment of fever without knowing why it is hot. Why is the temperature of fever not above 42 degrees Celsius? To know the answer to this question, you need to know the temperature of fever is 4. When our body is 42 degrees Celsius, our immune system knows that vitamins, proteins, and other elements will lose their proper form and perish. And sorry, need up to 42 degrees Celsius to save life and organs until the last minute. So our immune system creates temperatures below 42 degrees Celsius. What are the ingredients necessary to create decrease blood flow? Shrinking of blood vessels, inflammation, infection, low pressure, etc. will decrease blood flow. What are the ingredients necessary to increase blood flow? Heat increase blood flow by expanding blood vessels. Increased blood flow can help relax a tight muscle, restore movement, and reduce pain. Is there a fundamental difference between fever heat used in physiotherapy? No. All types of heat increase blood flow. A variety of heat inducing devices are used to increase blood flow to the lower back and neck knee pain. Physiotherapy often provides more heat than fever. Physiotherapy treatment temperature is between 52.5 degrees centigrade to 54.4 degree centigrade. New fever definition. If essential blood circulation increases to the organs, if essential blood circulation decreases to the organs, fever is a sensitive and discrete action of immune system to increase essential blood circulation as a self-defense mechanism of the body to sustain the life or organ. We can answer almost all questions about fever with this definition. The temperature of fever increase the proportion to increase in inflammation in our body and decrease in blood circulation. Inflammation is a condition which the temperature of fever increases as blood circulation decreases. Similarly, as the inflammation decreases and the blood circulation increases, the temperature of fever decreases. The heat energy used for which activities in fever and hyperthermia? Increased blood circulation to most important organs. In disease increased fever, the activity of most important organs increases and the activity of less important organs decreases. This is not due to the increase in temperature, it is due to decrease in essential blood circulation. This is like an inverter used to work most essential lights and machines in an emergency due to power failure. During fever, body increases activities of most essential organs like brain, heart, kidney, and liver. Uncontrolled temperature can occur in heat stroke. It is not below 42 degrees centigrade. Moreover, it was not created by a specific purpose. Okay, why not? Why do fever have symptoms, signs, signals, and actions? Fever is an action that has symptoms, signs, and signals and actions. Keeping the temperature below 42 degrees Celsius is just an act of fever. Another action of fever is the action of TNF alpha, a chemical that causes bitter taste and decreased appetite. Why does not everyone with a disease have a fever? Three reasons. Virus, bacteria, fungi, etc. does not induce fever in everyone because the cause of disease does not decrease essential blood circulation to organs. So this next point, the body does not need fever protection. Third point, the immune system does not have energy to produce the temperature of fever as in AIDS. How can we create fever and hyperthermia benefits within hours? In people with tonsillitis, children and elderly using icy water, we can create fever and hyperpyresia within few hours. With the continued use, we can cause death in them. Talaikotal is the best example. Talaikotal. Talaikotal is the traditional practice of genocide, killing of the elderly in or involuntary euthanasia by their own family members observed in some parts of southern districts of Tamil Nadu state of India. This is a process in which an extensive bath is given to an elderly person before the crack of dawn. He or she is given several glasses of cold tender coconut water and head massage with the cold water. By doing this, the temperature of body falls suddenly, causing high fever, which leads to the death of old age person within 1 or 2 days. Similarly, in COVID patients, using sponging with ice water, we can create a fever and hyperpyresia within a few hours. With the continued use, we can cause death in them. Some thought-provoking questions. This is a lengthy session, so I want to conclude shortly. How can we prove that the temperature of fever is to increase essential blood circulation? We can ask any type of question related to fever by assuming that the temperature of fever is to increase essential blood circulation. We will get a clear answer. If we avoid or evade from this definition, we will never get a proper answer to even a single question. Next point, if we do any type of treatment by assuming that the temperature of fever is to increase essential blood circulation, the body will accept at the same time, body will resist whatever treatment to decrease blood circulation. Third point, if we measure the heat energy used for which activities in fever, we will know the purpose of temperature of fever. It is astonishing that modern science has not been able to examine what actions with the heat energy of fever despite its advanced development. Now further evidence is required to prove the temperature of fever is to increase essential blood circulation. We can create the fever and cure it again. One of the criteria for a scientific method is to reproduce. We can make a fever with cold water and cure the fever with good heat. We can make him feverish again. Apart from this, what kind of evidence is needed to prove that the temperature of fever can increase blood circulation? Let me know new parameters to prove the purpose of temperature of fever. We can prove that the temperature of fever is to increase essential blood circulation with that parameters. Fever is a protector or destroyer? It is a protector. Delirious or fist formation disease fever. When disease increases, essential blood circulation energy level also decreases. The vertical height between heart and brain is more than 1 feet. When disease becomes severe, ability to pump blood to the brain decreases. Then blood flow to the brain decreases, and a delirious or fits are formed. As a result of this, brain cells are damaged, so the patients might be paralyzed or even may die. Fever and delirium. Fainting or delirious or damage to the brain cells is not due to the increased temperature of fever. It is due to decrease in blood circulation to the brain. Without knowing the purpose of fever and without examining what actions were taken with the heat of fever, it is said that fits or delirious would happen due to increase in temperature of fever. Temperature below 42 degrees never cause any harm to our body. During summer, in some parts of India, atmospheric temperature is more than 45 degrees. And a sun bath temperature, in a sauna temperature ranges from 160 to 200 degree Fahrenheit. In a steam bath, a person being 15 to 25 minutes. During fever, if you take a steam bath, fits never happens, blood circulation never decreases, skin never shrinks as in fever. Signs of curing fits. Regaining consciousness even before the temperature subsides. When I fainted a patient lie on the floor, the vertical height between heart and brain decreases. So blood circulation increases to the brain, and so fits is cured even before temperature subsides. Many people misunderstand that regained consciousness is due to reduction of temperature. Shivering is to increase blood circulation. If disease increases, blood circulation decreases. Shivering is not due to increase in fever, but due to increase of disease, decrease of energy, immunity power, strength, essential blood circulation, etc. Shivering helps to increase heat, then essential blood circulation will increase. Fever, shivering are the protective actions according to the aim and target of immune system. The disease of, the decrease of essential temperature to sustain life is the cause of shivering. In fever condition, how much essential temperature is decreased in the body, corresponding temperature is produced to generate counterbalance of the decreasing essential temperature. Animal behavior advantage of instinct. Buffaloes does not try to enter or lie in water, not drink it. Buffaloes manage body temperature by immersing their body in water and drink it. But when they are having fever, they do not try to enter the water, not drink it. Ways to eliminate fever by increasing blood circulation. Just listen to the messages from the body and act accordingly. Increasing essential blood circulation is a right treatment for fever. Blood circulation never increases without increasing temperature, which can never be cured without increasing essential blood circulation. To increase essential blood circulation, never allow body temperature to lose by atmosphere and apply extra heat from outside and inside to the body. It will help to immune system to fight against infection. Blanket, steam bath, hot sandbag, or thermal heat pad, hot pepper water, hot drinks can be used. Mechanism of application of heat. When temperature produced by the body due to fever and heat which we applied on the body combines it together, the essential blood circulation increases. Then immune system will stop to produce heat to increase essential blood circulation. And the body will get extra heat from outside and inside to the body. And the body will get extra heat from outside without any usage of its energy. Heat is the fast and efficient remedy to reduce inflammation and increase blood circulation. During fever, 99% of disease or patients shows inflammation. Apply heat from outside and inside to the body, blood circulation and inflammation related to fever, and its signals, symptoms, signs, and actions will decrease. Then essential blood circulation increase, inflammation decrease, digestion increase, body pain diminishes. Like and upset to the bottom. When we apply heat from the outside and inside to the body, all signals Symptoms of fever like and absent to the hotness according to the directions and commands of immune system. If fever is immune response against infection, our body like and absent to hotness. At the same time, our body dislike and hate temperature reducing methods. Fever is not a part of disease, it is a part of self-defense mechanism of the body, and it is an adaptation. A disease does not require fever, but at the same time, a fever requires a disease. Both disease and fever are different. We cannot include body destructing disease and body protecting fever in the same group. A lot of problems emerge not knowing the purpose of temperature of fever. Contrary fever treatments, various types of sponging, all are seen in this. Like that, you can see various types of fever definitions can be seen in various medical books. Contrary, another fever treatment is cool air. Another contrary treatment is blankets. Some advocates blankets, some others discourage blankets. Another drinking water. Some advocates drinking hot water, some cold water. Conservative fever treatment for fever, conservative treatments for fever and syphilis, roller sponging and paracetamol. Whatever happens to a brownie hen and its egg, if sponged with water, the same happens to a fever patient if temperature is decreased by sponging. The same thing happens in Day-2. The researchers found that the glutathione level were lower when single dose of paracetamol was used. This may increase the inflammation level. Removal of temperature of fever by sponging or paracetamol is not helpful for curing disease. It is believed that the doctor will save the patient in the treatment of fever, but the doctor becomes an executioner who kills a person. All conservative treatment for fever not only do not make a radical cure for the feverish condition, but also for the decrease of essential blood circulation and increase inflammation and leads the body to more dangers. If temperature is decreased by sponging or paracetamol, disease or cause of fever is never decreased. The basic elements necessary for a scientific treatment is not provided in fever treatment. It is proved that fever medicines are more dangerous than disease and fever treatments are more dangerous than medicines for fever. Importance of the finding of the purpose of temperature of fever is to increase blood circulation. Immediate relief from fever and body pain, life-saving discovery, a single magic answer to every fever-related questions. If medicines are prepared according to the purpose of temperature of fever, any country can guide the world in the cure for fever. Conclusion. When the disease becomes threat to life or organs, the temperature of fever is an increase. The temperature of fever is to increase essential blood circulation. Fits, delirious, or damage of brain cells are not caused when an increase in temperature of fever takes place. It is due to decrease in blood circulation to the brain. Apply extra heat from outside and inside to the body will increase blood circulation. We can make a fever with cold water and use the heat to increase blood flow and cure the fever. Pouring cold water can reduce the blood flow in the body and cause fever again. Conservative fever treatment should be revised according to the sensible and discrete action of immune system. There is only one way to reduce fever death. Prohibit Talay-Kuttal model conservative fever treatment. There is no other way than this. It is wonderful that a physician having years of experience in fever treatment cannot understand actual purpose of fever. I have developed 8,000 affirmative cross-checking questions. It proves that fever is to increase essential blood circulation. In the case of fever, double-blind study and placebo cannot be done properly because the patient will quickly recognize this when they experimenting with the heat instead of using cold as a way to reduce the temperature of fever. Please note the reference 9, 10, and 11. These are belong to the Talay-Kuttal. Thank you. Hear me patiently suffer. If you have any question, you can paste in chat box, or you can contact my WhatsApp number, or you can contact my personal email ID. Thank you. Hear me patiently suffer.
Yes, sir. Any questions to Dr. Jacob Matai? Sorry. Any questions? Just if you have, yes. Yes, thank you very much, sir, for joining this event as a speaker for the event. Thanks for sharing your tips
Okay,
with us.
okay, welcome.
Thank you
I
very much.
want to share my other papers link to this chat box.
Yes, you can share now itself, sir,
Okay, okay.
after the completion of your conference. Looking forward to meeting an extensor. Thanks for. Next, according to scientific program, Dr. Kali OP Megra from Greece supposed to join the event. As due to some technical problems, doctor will be joining after half an hour. So meanwhile, we asked Dr. Vandana Bhagat from Central of Rural Health, University of Tasmania from Australia will be joining the event and start presenting their talk.
Greetings of the day. Myself Vandana Bhagat and I'm doing PhD at the Centre for Rural Health, University of Tasmania in Australia. Under the supervision of Dr. Ha and Associate Professor Lane from the University of Tasmania and Professor Lane from the La Trobe University in Australia. Today, I'm going to share the findings of my project titled Australian Nursing Educators' Perspective on Education and Training to Promote Older People's Oral Health. So let's start with the background. The oral health is linked to overall health of a person. Poor oral health not only causes difficulties in eating, swallowing, and speaking, but is also associated with many chronic health problems like diabetes, heart diseases, pneumonia, and even certain cancers, leading to unplanned hospitalizations. Poor oral health affects people's everyday life by causing pain and suffering. This in return may affect the mood and behavior, especially for people with dementia who often find difficulty to self-report their pain and discomfort. Poor dental appearance and bad breath can lower self-esteem and exacerbate social isolation. Moreover, many older people develop severe complications from COVID-19 due to poor oral health. Oral health of older people in Australia is poor, especially in residential care. In 2019, the Australian Royal Commission into Aged Care Quality and Safety concluded that insufficient attention is being paid to oral health care, nutrition, and hydration needs of older people. The oral health of older people is of increasing concern for health and social policy makers worldwide. Talking about the challenges of aging population on oral healthcare services, as lots of changes occur in the body with increasing age, similarly many changes occur in the oral cavity, like changes in salivary glands, oral mucosa, and other tissue inside oral cavity, leading to complex oral health problems. At the same time, dynamic changes occurred in the oral healthcare needs of the older population in the 21st century due to preservation of natural teeth and complex prostheses such as placement of crowns, bridges, overdentures, and implants. Moreover, many older people are dependent on others to maintain their oral health due to impaired cognitive ability, reduced motor and sensory skills. But currently, there is a shortage of workforce skilled in oral health of older people. One of the highly respected nurses, Virginia Henderson, in the 19th century, said that the quality of nursing care can be judged by the condition of a person's mouth. But oral health is still a most neglected aspect of nursing care. As nurses are often present at point of care of older people in rural communities, hospitals, and residential care, therefore oral health trained nursing workforce will help in provision of a basic oral health services and timely referral for underserved older population. Oral health care in nursing entails understanding the factors affecting older people's oral health and oral health related quality of life, ensuring daily oral care practice, and being able to complete an oral health screening in collaboration with dental, medical, and other allied health professionals. Nursing students are the future health professionals, so educating them will help in collaborative patient-centered care by integrating oral healthcare services with other primary healthcare services. Findings of a systematic review on incorporating oral healthcare education in undergraduate nursing curricula, which we conducted, suggested that there is limited information on the extent of incorporation of oral healthcare of older people content in Australian nursing curricula. Therefore, this study interviewed academic faculty in the nursing schools of Australia regarding if and how nursing students are being educated and trained in oral health care of older people. Participants for this qualitative study were recruited by purposive sampling until reached data saturation. Semi-structured interviews were conducted with course coordinator, lecturers, directors, and researchers in the nursing schools delivering an accredited Bachelor's of Nursing program across 7 different regions of Australia. In total, 13 interviews were conducted. Now let's discuss the perspective of educators on nursing students' education and training to provide oral health care for older people. So the first theme is relative importance of oral health to nursing. All participants interviewed felt that oral health care is an essential part of holistic nursing. Nurses' role in oral health care is not limited to assist in oral hygiene only. Nurses should have ability to perform oral health assessments, provide oral health education, taking care of fluid and diet intake, evaluate the impact of medications on oral systemic health, and making timely appropriate referrals. Nurses can help in overcoming the accessibility issues to dental services by playing a leading role in preventive dentistry, by promoting oral health in the community and early identification of oral diseases. Though the importance of oral health care is widely recognized by nursing educators, many believe that it did not receive much attention in nursing education as needed. Theme 2. Current trends in oral health education and training. Most participants stated that oral health care is being taught in their curriculum, though in few cases oral health content was not included or was recent only. Different universities use different depth of content with no uniform objectives and use different approaches through which topic is being taught. One of the participants mentioned that they are adopting a co-design model involving nursing students to design and effectively incorporate oral healthcare content in nursing program at their university. There were mixed views in relation to satisfaction with content and amount of time spent on oral healthcare education in nursing programs. Most participants were not completely satisfied and showed interest in further developing an oral healthcare content for nursing program. Several gaps were identified by participants in the education and training of nursing students. Participants believe that there is a lack of focus on oral healthcare needs of vulnerable older age group, especially with dementia, and lack of focus on indigenous population. Moreover, in many programs, there is lack of establishing connection between oral and general health effectively. And there is not enough training in terms of oral health management by nurses. The location of nursing schools in regional or rural areas did not seem to be a barrier to oral healthcare education and training. Moreover, participants believed that students in the regional areas could have advantage of learning about the importance of oral healthcare of older people more effectively at the workplace than in urban areas. However, there can be frustration in remote areas to back up clients with advanced dental services when required due to lack of infrastructure. Theme 3. Oral healthcare of older people education in nursing. All participants believe that oral healthcare of older people is fundamental to nursing care. But currently, there is a lack of focus on oral healthcare needs of the older population in many universities. There were mixed views on making oral healthcare of older people component mandatory in nursing curriculum. Some participants thought that as the aging population is increasing rapidly in Australia, therefore it is very necessary to start educating and upskilling more nursing students to manage and care for older people. While other participants were skeptical about particular focus on oral health care of older people content in nursing curricula, as it means they have to cut off some other component or have to focus on all other vulnerable groups, which they believe is not possible in 3 years degree program. Most of the educators believe that oral health care could not be a standalone unit. It needs to be incorporated into what is already being taught and needs to be aligned, linking with systemic health and diseases. However, few educators believe that it needs to be a standalone unit. And if lecture is embedded into a number of other things, nurses will tend to forget to apply in practice. Team 4, the participants identified several internal barriers that would prevent oral health content from being successfully implemented in nursing programs. The recurring barriers determined to be were time and capacity in the curriculum, the lack of focus on the oral health care of older people in the accreditation standards of nursing education also seemed to be a barrier. Other barriers were identified included lack of educate awareness and education over the oral health care of older people content among nursing educators. Few staff members also highlighted lack of oral healthcare training resources available at nursing schools and also the hierarchical barriers that come across to incorporate oral healthcare of older people content. External barriers to oral health education and training in nursing programs. That was the theme 5. Participants believe that there is a lack of political attention to oral health care of older people. Currently, the Australian government have not allocated substantial funds to prioritize oral health care into overall healthcare system. And another key issue at the institutional and organizational level was the perceived isolation of the provision of dental services in Australia. Nurses working in medical or surgical ward or aged care home did not get opportunity to interact with dentists or oral health professionals. Participants also cited that nursing students, when going on work placement, often see low priority to oral healthcare provision by carers, which sets the poor role modeling stage for nursing students. Moreover, there is a lack of strong advocacy from dental professionals in promotion of preventive oral health care among primary healthcare providers. Some barriers identified by participants for little participation from dental professionals included lack of funding from government to dental experts. Another example provided by one of the participants was that a dental professional received little support from the nurse unit managers, ensuring regular oral health care after they take initiatives to improve oral health care of residents. Participants put forward various strategies to effectively train nursing graduates about older people's oral health care. Participants believe that if government put forward the more cohesive response declaring oral health care of older people as national priority, then it will receive attention to feed into curriculum of nursing schools, which will help to integrate oral health into greater healthcare system. Moreover, there should be clear accreditation guidelines to incorporate oral health care of older people content in nursing curriculum. They also recommended some interdisciplinary collaboration between dental and nursing schools, which start first with effective communication, and there should be someone from the dental school who could help the nursing schools in developing the oral health care of older people component and highlights its importance. Participants mentioned different strategies at the meso level. There is need to clearly define nurses' role in oral health care to catch their interest in this area, because often dental professionals forget to prioritize learning objectives for nurses, which hinders its feasibility in the long run at nursing schools and at practice. It is crucial to find oral health champions at nursing school who could help to bring attention to the importance of oral health and the impact it has on general health, and potentially it will increase the motivation on the topic to nursing students. There is need for continued support to nursing staff by dental professionals, and it should be led by a national body like Dental Australia in terms of developing resources and organizing CPD programs to train nursing professionals about oral health care of older people. Moreover, opportunities should be developed for nursing students to interact and understand the oral health care needs of older people. The curriculum should be framed in such a manner that qualities and quantities are both balanced and lined by nursing students so that they could be more excited in implementing the changing and accepting it. Students' views about the curriculum must be considered at appropriate level. Development of curriculum should be ongoing process. Do it one time and then reassess. Currently, there is no formal assessment of oral health skills for nursing students, so some kind of formal assessment will help nursing students that where they stand and what needs to be improved. Now, concluding findings to date, I would like to say that the inclusion of oral health care of older people component can be facilitated by number one, prioritizing oral health at national level. Number two, government providing sufficient funds to expand into professional education and training. Number three, providing clear oral health guidelines within learning domains for accreditation of nursing programs. And number four, effective oral health care policies at residential care and other health facilities. This all can be done with the advocacy by dental experts and finding champions at nursing school and residential care. Thank you so much everyone for listening my presentation today.
So this was the presentation from Dr. Vandana Bhagat from Australia. If you have any questions regarding this, just you can ask. Any questions? Yes, madam, you got a compliment from Dr. Catherine. Great information on oral health in nursing. In the United States, many people avoid dentists because of lack of insurance and cost. Engaging in insurances in oral as well as positive derivative with positive outcome for patients.
Yes, very true, Catherine. It's similar kind of situation worldwide. So that's much needed. Like we not only like separate dental professionals, but they should be incorporated into the greater healthcare stream. So that would be wonderful because for older people, especially like nurses are the one who are present at point of care. So it would be great if we can involve them and can help our older people.
Yes. Any questions? Any questions to Dr. Vandana Bhagat? Yes, thank you very much, madam, for participating in this event. Thank you very much for nice speech. This was a great video. Thanks for sharing your tips with us.
Thank you so much. Yeah, no.
After the completion of the conference, within 2 to 3 of the days, you will be getting participation certificate as well as electronic booklet officially through email ID.
That's great.
Yes. Thank you so much, ma'am. Next, we asked Dr. Louis Shou-Fang from Taichung Veterinary General Hospital from Taichung, Taiwan, Republic of China. The topic will be predictive relevance for biochemical indication to incontinence associated with dermatitis in critically ill patients.
Okay, good. Okay, can you hear my voice?
Yes, ma'am.
Okay, good morning, everybody. My name is Liu Shu-Huang. I am the nursing supervisor. I work in Taichung Veterinary General Hospital. This is a medical center, and this hospital is located Taichung, Taiwan, Republic of China. So today I will presentation my research. My research topic is predictive relevance of biochemical indicators to incontinence associated dermatitis in critical ill patients. The main introduction is incontinence associated dermatitis, we call IAD, could be caused by different factors such as skin aging and lotion subcutaneous glands, protecting functions, fecal or urinary incontinence with high sharing force and high friction rates, low albumin in blood, high BMI with diabetes, ICU patients, and the usage of the antibiotics, etc. So my research purpose is predicting relevance of biochemical indicators to IAD in critical ill patients, finding the correlation factors in biochemical examination to early providing clinical nursing activity to prevention IAD. So methodology and the theoretical orientation. This is co-sessional study design. So in convenience to take sample from the 590 adult patients who admissions more than 24 hours in SICU of medical center in Taiwan from January 1, 2019 to October 31, 2019. So variables in this research are IAD patients, physician health data, including pressure sore evaluation scores, fecal and urinary incontinence status, and antibiotic usage, and biochemical indicators, means albumin, total protein, and zinc. So my finding is the results show that the length of days in SICU and the albumin biochemical indicators possess statistical significance. They have the p-value. So prediction powers, every increase the length of days in SICU, the risk of IAD will increase by 1.07 times. Each point increase in albumin will reduce the risk of the IAD caused by 60%. So we will see that logistic regression analysis of the IAD prediction factors. We will see the figures. They have the variable is ICU length of days and the albumin. So we will see the odds ratios here, and then they have the 95% CI, and this is a p-value. So my conclusion and the significance is, if we were to predict patients suffered IAD via biochemical indicators, that's albumin, total protein, and zinc. So total protein and zinc indicators do not have the statistical significance relevance, where albumin biochemical results does possess statistical significance. Prediction power, therefore, early provide the measurement to prevent IAD, lowering the skin damage to ICU patients. So this is my report. Thank you, everybody. So if you want to contact me, they'll have my email here. LSF by this is my contact email. Thank you, everybody. Thank you.
Yes, this was the video presentation from, poster presentation from Dr. Shu Fang. Any questions to Dr. Shu Fang? Any questions? Just if you have any questions, you can text in chat box. We'll be asking behalf of you, even after the completion of the conference. Yes. According to this scientific program, Dr. Sarah Phillips from Wien Train Limited from UK will be joining the event and starting the presentation. If not, we ask Dr. Emdan Ramdan as well as Dr. Mohammed Nazir from Ubdala Health New Network from UAE to start the presentation. If you are ready with your PPT. Yes, Doctor. We asked Dr. Eman Ramdan as well as Dr. Mahmoud Adil Nazir from Mabdullah Health Network from Amna Healthcare Center from Dubai to start the presentation. I said this just we are having a 20 to 30 minute of our actual program. We have a lot of time, madam. Just you can take your own time.
أنت داخل هون على هذا، داخل على اللينك. شوي وين
هي صورتك طالعة. شكرا يا معروفين، احنا نتدرب
طب
لسه.
خلص نفتحهم احنا الاثنين، وهو هذا فيه الكومنت حيكون.
بس تبينيش عندهم.
احنا حنعمل شير سكرين. طيب انت طب ادخل افتح الانترنت،
فاتح الانترنت.
يعني ادخل على على الميتينج.
ايوه هذا.
ماشي طيب معناها
Yes, madam. We have a lot of time. You can take your own time.
yes thank you, we're just uploading the slide. Thank you.
Yes, no problem. We have just 20 minutes ahead of actual program, so you can manage the time session.
الكاميرا شغالة عندي أنا؟ لا صح؟ الكاميرا من عندك.
Hi everyone, you can see the slides.
Yes, it's going to open.
Okay.
Please apologize, madam. Actually, due to one speaker, due to her technical problem, she is unable to join the event. That's why we are 20 minutes ahead of actual program.
Definition: defined as any act, threat to physical violence, harassment, intimidation, or other disruptive behavior that occurs the word side and may cause physical or emotional harm. اوكي حاطه هنا انت شو اسمه هذا اذا فيلم.
استنى خليني. So is the slide showing or not yet?
Not yet.
طيب اعمل stop
Let's
sharing من عندك.
share again.
I think it's visible now, right?
Yes, you can start your presentation.
Okay. So it's a good morning in US and it's a good afternoon here from Abu Dhabi. And thank you for this opportunity speaking in the third virtual nursing and education conference. This is Iman Ramadan, former charge nurse for 11 years of nursing experience, where I found my passion in emergency department, and I spent the last 5 years doing case management, currently working the case manager at Amana Healthcare, one of the Mubadala Health Network companies in Abu Dhabi, UAE. And I have here my colleague Muhammad, that he will be joining me as well in the presentation. Muhammad, please.
Assalamu alaikum. I am Muhammad Nasser, Senior Case Manager in Amana Healthcare, among Mubadala companies, the biggest provider for healthcare in Abu Dhabi. I was working my experience around 14 years in 2 different countries with different specialty in nursing and case management. Iman, you can start.
Thank you, Muhammad. So, as with our nursing experience, nurses are the healthcare worker who are mostly at risk of considerable violence at workplace, and that's what we faced. And we noticed that is increasingly happening within our department. So it became a point of our study where we conducted this research. And we're going to take you in a journey to highlight the workplace violence as a phenomena, to review the environment of the emergency department, the nursing staff roles, and the reasons behind the workplace violence. We will also discuss the study done in a tertiary governmental hospital in UAE and highlight the reasons and recommendation to eliminate workplace violence. So, Mohammed?
Yes. Assalamu alaikum. Do you know, according to the World Health Organization report, in 2016, reported that 1.6 million people lost their life because of workplace violence every year. And International Nursing Council in 2014 started that said that 72% of nursing do not feel they are safe from possible assault at work. And in another study done among 1,889 staff, 89 staff had been exposed to workplace violence in across sectional survey. Survey was done. Yes. Let's go to definition of workplace violence via Emergency Nursing Association. They defined as any for the workplace is any act or threat of physical violence, harassment, intimidation, or other behavior that occurs the work site and may cause physical or emotional harm. Workplace violence affects the dignity of millions of people worldwide. It's a major source of inadequate discrimination and conflict at the workplace. Increasingly, it has become central human rights issues. Yeah. Now we have some terms. Let's see a few terms frequently used in association with the workplace violence include but not limited. Okay, we can say intimidation, bullying. This is some of violence can be happened from the patient to the staff, or from patient attendants to the health worker staff in the emergency. Offensive or threatening language. This can be developed to some threatening language between from the patient or the patient attendants. This can be developed to physical assault from the patient. And this is all this is 3 stage I saw in my life, or I faced this experience in my life. But alhamdulillah, I didn't see in my two different experience in the Jordan and the UAE, the homicide. Alhamdulillah, thankfully we didn't see this kind of homicide. But this is really happened in some different place. And let's go to real scenario was happened now. I will show you this video. Okay, you saw the video. It was clear.
Yes, sir. Go ahead.
Yeah. Okay. Now let's go to some real story was happened with some our colleague. Let's say now our colleague Maria, she said she grabbed my stethoscope and started to tighten it around my neck. And our friend, our colleague Jonathan said, a patient with AIDS, a patient with AIDS once pulled his IV and tried to splash his blood on me. And there is some other colleague also, Jamie, he said, that's too light a sentence for this guy. He really tried to kill me. What he did to me affected my family, my wife, and my youngest son. They are the one who was really affected by this. Now, also, this is, yani, this kind of violence, it's really is not a stop, and can be done with everybody, and can done and also happened with a lot of our colleagues in different places in the world. Like what you see in this slide, we have some colleagues from USA, from Canada, from South Africa, and from different country. They have this violence because this we interested with this subject. Now I will go to my colleague Iman that to tell us why this happened.
Thank you, Muhammad. So, studying this phenomena, we found that there are many reasons and different perspectives for this act to happen. So, if we take it from the patient perspective, looking into the prolonged waiting periods for patients seeking medical care, sometimes associated with the unpleasant waiting room environments. So, for example, especially in emergency department with an unpredictable number of patients, unlike any other healthcare setting in outpatient, for example, where you have organized timing and fixed appointment with the physician. In emergency, patients are allocated in a small waiting areas, even if the patient care is happening in a room with a minimal privacy using curtain, and that's due to medical reasons for observing the patient and keeping a close eye contact with the patient. So from the patient side, they think that these are one of the triggers that lead the patient to feel uncomfortable, and that's lead to being violent with his primary nurse, with the physician. Another reason is the increased prevalence of the drug and alcohol use in the society, and using the emergency department as a medical clearance for those patients. For example, all the patients with police cases, psychiatric issues, drug-related issues, they have to pass by emergency department to get their medical clearance, to do their test, to have some police reports. It all happens through emergency. And due to the lack of policies and procedure that organize that patient workflow, the nurses at emergency department became at high risk of interacting with those type of patients. Another reason is the lack of transparency of some healthcare professionals. For example, a simple blood test in ED will take at least an hour and a half. And if we will not be honest with the patient, explaining each procedure and how much is the time span for each one, that waiting will increase the anxiety level for the patient, where it triggers him to do any violent act. If we look into the other perspective from a nursing and a healthcare worker side, so a lack of staffing, shift supervision create a very stressful environment. Like imagine one nurse looking after 6 patients, running between the rooms. This will not ensure proper communication with the patient and other colleagues. Also shift which include coming or leaving at work at late night. Like just imagine yourself, it's at 3 a.m. in the morning and you still have 5 patients, and one wants a blood test and the other need to be taken for admission to the unit, and you are drained, you did not have enough sleep, or you didn't go for your break yet. So all of these triggers make the healthcare worker at risk for any violent act or behavior. Also, the poor security in the healthcare facilities, which is common in a nurse and patient perspective. Intervention, which include the close physical contact with patient. For, of course, primary nurses are the most vulnerable group because they are in a direct physical contact with the patient most of the time. Also, the lack of privacy in a healthcare facility, for example, ED, some perceive it as a violation of their personal space, and especially in this part of the world, which is part of the culture, the Arab and Islamic culture, that, like, for example, females, they need to have more private rooms and secured, and needs like some special precaution in communicating with the patient. So now let's go back to our research and study. Let's go to the methodological way. Like as a background, the literature review said that there is a limited number of interventional studies that provide a roadmap for effective management of this concern. Another study in 2016 defines the violence as any incident where staff are abused, threatened, assaulted in circumstances relating to their work, including explicit or implicit challenge to their safety and well-being of health. Also, there are few studies done in United Arab Emirates addressing the workplace violence in hospital in general, but not specifically for emergency department. So based on the high rate of incident report submitted by emergency department staff reporting the violence act and behavior, the study aims to explore the incident rate and investigate the root cause analysis behind each incident. So the aim of this study is to explore the incident rate in emergency department in one of the tertiary hospital in the UAE. Also, the study set a baseline for workplace violence staff perception, what is perceived as violence and what levels of it exist. Also, the study will be used as introduction for interventional study to address the workplace violence in UAE. So the research methodology was a retrospective review of all the incident reports related to workplace violence. And this is done through the electronic system that we have of reporting incident and communicating with our quality department for a root cause analysis for these reports. The incident report were taken from the reporting system used by the organization, and the incident statement were checked against the definition of workplace violence to exclude any incident that do not meet the criteria. For example, those who are related to patient-related incident. So the method that was used with our staff is a survey designed by the researcher to explore the staff perception first of workplace violence, the reporting mechanism, how do they report it, and the frequency, how often do they report it, and the training and support intervention post the incident. Basic statistical approach, including descriptive statistics, ratios, rate, standard deviation, benchmarking, and interferential statistic that were used to analyze the data collected from the two approaches and data collection. The results were collected and analyzed, discussed against the literature that we have done, and conclusion drawn out from it. So Muhammad, tell us some of the results that we found on that study.
Yeah, we will speak a little about the result. 81 incident report of violence in the emergency department were reviewed in that study. 14 from the 81, they are repeated offender identified during the study period. Now, results showed that most of the assault come from male patient at age from 31 to 45 years. This can give us high alert to find a way to protect the next future, to find some high alert for the patient could be do this violence for the staff. Report also indicated that the majority of offender are patients with mental or psychological disturbance or substance abuse. Iman, can you tell us about the finding of this study?
Yeah. So we found out that the majority of violence reported was physical and mostly was toward female staff were most affected. And if we look into that, comparing the why in specific female staff, that was considered because, for example, in our emergency department, we have almost 200 staff. 80% of them is females, so that explains the majority of the staff who were affected. The other point, talking about the staff perception, we found that this varies from one group to other. For example, those who are experienced nurses or senior nurses who are mostly aware of the policies and procedure, aware of their human right and setting limitation to patient, they report the Workplace Violence Act accordingly, and they know how to manage these incidents. And this is different from the, for example, novice staff, from the graduate nurse internship and trainees, whom they lack the experience, they lack the exposure to such patient. So they think that the violence is part of their job, or this is part of the challenge, and they just need to deal with it. The contribution factor to this variance is the absence of a policy to control this part of a practice in the hospital, which we will explain later in the recommendation, what changes happen in the policies and procedure related to that. So the study recommended to have a further interventional study to formulate the effective strategies for staff perception. And that was communicated to our research and training department to do research that involve other emergency department in the city and look into the policies and procedure for improvements. Also, a continuous training program should be conducted to all the staff. And here where we collaborated with the Behavioral Science Pavilion, the entity who works with a psychiatric patient, we communicated with their education and training leaders to provide the training program for our emergency nurses on how to deal with an aggressive patient, with a violent person. That will increase the confidence for the staff in dealing with such situations. Also, having a clear support system must be initiated to protect the staff from the violence. And here where we communicated with the senior leadership nursing to create that support system for the nurses, and especially the group that we talked about, the novice nurses, the trainee, to report these incident immediately. For example, in a different ways. For example, they have a morning huddle that they can share the incident that happened during the departmental meeting, and also through our patient safety net, where they can write the report to directly and anonymously to be sent for root cause analysis. The last thing is the community awareness on the effect of violence on the progress of the healthcare system in the country. And here where we took this study to be promoted within the community and collaborated with, for example, the Ministry of Labor and Abu Dhabi Occupational Safety and Health Center. And we will show it in the next slide. So the study concluded that the ED in this hospital is experiencing a high incident rate of workplace violence. Workplace violence is underreported due to the lack of a clear definition and policy within the hospital. Also, there was no intervention strategy to deal with the workplace violence in that organization. And the study contributed in increasing the workplace, the awareness about the workplace violence within the community of UAE. And here where we talked more about the study, and the community awareness started by talking about the phenomena, collaborating and involving with the regulatory bodies like the Ministry of Labor, Abu Dhabi Occupational Safety and Health Center. So in this aspect, the study was promoted in a well-known conferences and research committee within the UAE, which raised the flag to the healthcare leaders and policymakers to implement the change in policies, procedure, increase tools to raise the security of workplace environment, in addition to increase the training programs for nursing staff on how to handle such aggressive patient or attendant. So to sum up, violence and aggression towards hospital emergency staff nurses become a focus of studies and research and in area of concern. The healthcare workers must remember that a past history of a violence is the greatest predictor for future violence. So because there is an estimated 40% of admitted patients or in the hospital, they are substance abuse or psychiatric patient. So this can predict that this will not stop. So how can we stop? By prevention, by having a clear policies, by training our staff to be ready for such incident and to know their rights. So to protect the emergency patient, staff, family, and every member visits the ED is fundamental to ensure the safety of our healthcare provider delivering quality patient care. And at the end, we would like to highlight that workplace violence, it's not part of the job. It's just need to be reported. Thank you so much. This is our references. And thank you, Muhammad. And we would like to thank you again for giving us that opportunity to share our study.
Yes.
And also, we would like to thanks all of you, and we'll take this opportunity to thanks all the front line to defend all the community from the pandemic of Corona. And I hope shortly the Corona will be just in our memories. Thanks a lot.
Yes. Yes. Any questions to Dr. Hamdan Ramdan as well as Dr. Nazir? Any questions? Just you can raise your hand. We'll be asking behalf of you if you have any questions. Yes, just a hand raise. Just you can see compliments from Dr. Soumya. Actually, extremely interesting presentation from Dr. Fatima, as well as Dr. from Catherine. Just you have a question, madam. Just you can read from the chat box.
So yeah, we have a comment from Dia. It's important topic, need more focusing to protect nursing. Thanks Dia for your comment. And yes, after this study, we a lot of change happened involving the nursing senior leadership to protect our staff. By providing training, by changing the policies, by also they have signs in the emergency department stating that our staff is valuable. So any act or threat or act of a violent action will not be tolerated. This training also involved the security staff within the hospital. Also, safety measures were implemented. For example, within the badge holder of each staff nurse, they will have like alarm in case, especially for those staff who works closely with the psychiatric patient or a drug-dependent patient. So yes, a lot can be done to improve the practice and to have a safer environment for the team.
Also in emergency, they worked on the setting for the psychiatric patient. They will come in the emergency in the ED. They changed the setting to decrease this kind of violence.
Yes. Any questions? Any further questions to Dr. Iman Ramdan as well as Dr. Nazir? I would like to inform Dr. Iman is joining our events since last 2 years, both as well as physical as well as virtual events. Thank you very much, madam. Hope you are the one person who is encouraging this kind of scientific events during the COVID-19.
Yes, thank you so much. Thank you for having us in this scientific celebration for us. We consider it because sharing knowledge is very helpful for everyone, and having this much of different countries, nationalities, participants from everywhere to exchange the knowledge, and this is what we are looking for.
Yes, you have got one more question from, just you can read from chat box, madam, from Dr. Hamad.
So introducing a clear reporting guilt-free policies was wound touching. Yes, thank you, Mr. Ahmed, for that comment, because I felt like this is a personal experience as well, like starting my career as a nurse and having or dealing with such patient who shout or yell at me. I was having that perception of that this is part of the job and I just have to tolerate it, while in fact this affect the psychological part of each nurse and each one of us, and it affect me directly until I get educated and knowing that this is not part of my job. This need to be communicated and reported and needed to be stopped. Yes, we appreciate that, and we know that they are patient, they are in pain, but at the same time, they have to respect their care providers. Thank you.
Yes, thank you very much, madam, for participating in this event. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for excellent presentation.
Thank you so much.
Yes, thank you sharing your tips with us. Looking forward to meet again next time.
Inshallah.
Thank you. Inshallah, next year.
Yes. Next, we ask Dr. Sarah Phillips from Vein Train Limited from United Kingdom. The topic will be taking the simulation lab of the students for practical vein training using a ultra low fidelity individual simulator.
Thank you very much. Can I do a sound check? Can you tell me that you can hear?
Yes, you can start sharing your PPT.
Excellent, excellent. 1 second. In sound, could you just do a thumbs up for me? Checking sound. Is that okay? You can hear?
Yes.
Yes, thanks. Okay. Right, I'll share the screen. Thank you very much indeed. It's not allowing me to share, so hold on. I'm just trying to get the sharing up. Could I just see you and just to see a thumbs up, please? And I can see you can see it, okay?
Yes, it's going to.
Thank you. Thank you very much indeed. Sorry about that. There's always a moment, isn't there, with tech. I'm Sarah. I'm from Nottingham in the UK. I'm at the university campus, got a private business. But I'm here to share with you some, we kind of just jumped in March 2020. The UK shut and it was very fast. I'd already had an innovation that I was trying. Since 2012, we did our first online virtual vein training, which is putting a needle into a vein. I'm an author in these skills and I've done national work for 20 years and headed up projects in London at Guy's and St Thomas's, Chelsea and Westminster, and all those places. So what I want to do in the next few minutes is go over sort of the next 10 minutes, go over what it is, what we did with it suddenly, and how the kind of world came to us. And I've got some feedback, some videos, if it'll work, hopefully. It's been working well this week with other conferences. So I've got some videos to share with you as well, directly from the users of the system, which is quite interesting, and some stats. So I'll just move swiftly on now. And do wave at me if it fails, if you can't see me. So basically, the world sort of came to us. It's a low cost at scale solution, and it's built to locally adapt this vein training system. And here it is here, but you'll see some pictures of it. It's a very small simulator for the most commonly performed skill in healthcare, and it goes out really small flat packs. So we sort of jumped in. We had 407 delegates. All our classrooms closed in the UK, and we actually won Hillingdon Hospital. It shut down their A&E department because 89 staff suddenly had to go off sick because they were in contact with COVID. So that then made everyone rethink about training and what we would do with training. So that certainly helped companies like me who were trying to deliver virtually anyway. So we had in March, September, 407 delegates, 47 came live online. We've had a lot more since then, actually, but I'll use these stats today and some graphs to show you. We had about 3 to 8 delegates on each session. We did train the trainer, and it felt like a normal classroom. We've now simultaneously recruited we had 4 master's level people, one doing a master's in ed tech, building quickly an e-learning platform. We didn't have the full e-learning platform before. We just had the video. The vein has videos attached to it, 6 videos, and then it complemented local training. So we quickly built that, and then we were at the same time delivering the live online. And our first course in March was somebody from Dubai, South Africa, I'd been trying to see for 18 months, someone from Ireland and someone from Croydon in the UK. So it was quite interesting to see that sudden change. We have got a problem with these skills in the UK, in the world. This is a short video. So moving on now. we won a showcase in Qatar. So it's a bit odd, a cardboard box effectively, but it can produce in millions. We do 3 million a week. So it won a showcase because it was seen as an innovation that could affect healthcare globally. So Lord Darcy, there's Lord Crisp and the chap there from, that was Wish 2018. So that was really helpful. And I thought, oh, here we go. People are going to trust this now. And I've written a book and done all these things. But that wasn't really to be the case.
Global collaboration.
And so what we're trying to do with the system is, and what I've been watching people use veins and use needles for 20 years, and they struggle with it, to be honest. They struggle with the psychomotor control of the needle, and that's one of the main things this device does. So it teaches them how to sort of control that device. So it goes out flat, if you see, in a box with all the equipment in on the far right, and that does IV drugs as well. The booklet and the e-learning and the vein are also to pop up, and the booklet there is 20 years old and got 85,000 in use, and that's a not-for-profit thing that I did with Lee Stowart here at the Marsden Manual. That goes to the clinical area. So it's the whole package. It was, how do we get from the classroom to the clinical area? And it flat packs out and it goes out like this. So you can see someone took that yesterday, the one on the first. So that's going out to a private company who wants me to do a little bit live and then straight on the e-learning, just a welcome. And then we do live monthly on the sessions as well. So it goes out when everything's shut in the UK. We weren't even sure if couriers would go. Nolan in South Africa looked up at the sky and said, Sarah, there ain't no flights here. Your veins are not coming. But in 4 days they arrived. So whilst humans couldn't travel, these flat packs could travel. This is a bit of what it looks like. So there's 6 videos on the vein. You can see a bit of snippet of what it looks like. This is the shortened version.
Check equipment.
Okay, so we use those anyway in class, but we're using them live online now and in the learning platform. And this is the scores that were coming back. So the numbers are quite small because this is just a survey while we were busy working and delivering. So it was really positive to see these results coming up. 96% of patients were 96% of people were happy with that. And then we do 2 levels. We do a masterclass. So there's the initial one and then there's the masterclass version. So I'm just doing a time check there next to me. And the masterclass goes into a little bit more detail of why we're looking for flashback and what that would do. So that's just there.
Very visible. That has to be visible. We don't want that bevel to be on the underside. That bevel has to be.
And these are the things that when you've been teaching for 20 years, you repeat the same things a lot of the time. So in the videos, we've put those things in, and in the e-learning, we've done all sorts of things, moving around and things with it. So the videos were coming back really positively, scoring of 8 to 10. So out of 10, 94% were saying they're really helpful. So we're pleased with that because we've invested quite a lot on them. I think this is an insight into the e-learning, into the live, which we never know what's going to happen with live. And the feedback thankfully came back really well. And if you have a look, you can see the needle movements and how people are using the camera and the screen to really help. And it really came into its own, the vein, once we had it in front of a camera. They like it. They like having their own vein. But they're just a bit, well, what's this strange looking thing? This isn't going to help me get into big veins, but it certainly does. And there's a dressing going on upside down over there. So what people thought so this is 40 of this. So before they came on the study day, they thought, well, I can't imagine doing practical skills like this. And then after they came, they went, actually, it was good and it did work. So that was quite interesting. And remember, we didn't know what individuals, we knew contracts like NHS Direct, we just did them, but they were used to online training.
We just stick the needle in. So I really enjoy this one. I really liked it. I think it's brilliant. I thought it was not going to work, and it does work. I love it. And also the fact that you can put fake blood in it, so to make it more real. So, yeah,
not expensive. So, you know,
I
we're
love it.
tight, aren't we, in healthcare? We don't like spending our money.
And you can see on the side there, there's a picture of that somebody had come on the course, and they sent me a text, and I was in a course the next day that wasn't going so well. We'd had a struggle with the tech, had to move to the university because I had power cuts at home. So I decided to come here and get the big wires and the reliable electric. But so it was really nice to get that message saying that she was actually the very next day in with patients, and she'd done 11 bloods and they were all good after our training, and she'd never done bloods before. So that was really heartwarming. What's this? So people then said, yeah, I would do live again. So 88% were a score of 8, and out of 1 to 10, 8 and over. So that was positive. There was lots to learn. It wasn't all positive.
There is something else. I really want to thank you. I don't know how you managed, but to make everything very real and very comfortable. I don't know how it was for my colleagues, but for myself it was very, very comfortable. And I don't know how you managed, but it was very.
So basically, it wasn't so easy to get it that way. We had to get decent cameras, we had to get studio. I didn't have any staff with me. I had to be able to do it myself because we couldn't work in the same room together. We didn't have vaccines and it wasn't appropriate. So I had to build something that worked. And that does mean that trainers can do it themselves now because we've worked out how to teach them to do that. And the scores always come back. So what people want to do on courses, they want to come and they want to be competent the next day. So they often come back a bit, oh, I've not had enough practice, but this scored highly, 8 to 10. And it's because I think they've got so much, and it feels like one-to-one on screen. They feel like rather than crowded in a room, they're sort of, we've got a 69% failure rate on these skills globally, which I don't think I've mentioned, but look at some of the local pictures that I think are more powerful in a way. This is a paramedic's daughter locally just last year, and it was just some bloods taken. And that's what we're trying to solve. We're trying to solve these.
If you cannot insert a needle correctly, then I don't think you should be even on the training course full stop. I don't think you can jump things. I think you'd have to start from the beginning to understand what you're doing with the veins. You don't cause any damage, then you can go forward to other things. But I've been quite shocked of being on certain training courses and realising the knowledge that people don't know that they actually should know. So I definitely feel that this course needs to be
So people felt that was quite fortunate. I wasn't sure. I was thinking, hopefully people after writing a book and doing this 20 years, that I was doing most of the training. My staff had trained up a little bit. Paulette's done some, but they need support from me because they were finding the tech stressful. I tend to just jump into things, but other people find that less so.
But now that I've been on some remote training, I'll be saying that, you know, it is really valuable.
And the other thing is they'll trust you. So you can say to them, come on, let's try it. And if you just
And that was the key thing, was the trust. So what we've built into the system is there's people can print. That was part of the reason it won Wish in Qatar, was they can print, they can own that vein. So there's co-branding and their own QR. So I want the trainers to take this back. I want them to have their things on it as well as ours. So there's this central point and what have you. But I didn't want them to be frightened either if they had to keep doing online. Most of them want to teach in classrooms, but I want them to be able to do a bit more online because it works so well with it. So yes, we had the equipment and they liked the Zoom, and that was coming out quite highly as well. And there was surprise. It was good that we managed to get that quality up there. Like I say, we did have a few trip ups with it. And this is what we're trying to do with it. If you look here, you can see them learning on it. And we teach that. And this is the e-learning, this one.
There's a little new thing.
Last few minutes.
If you're done, you are in the comfort zone, that you're in your house, you can access whenever you want, and it's still there, because on the face-to-face training, after that training, you don't have any more training until next year. But with this,
whereas if I'm tickling the wing here and I've held in that cap there, I've got full access.
So what we wanted to do was we wanted to be able to, get that e-learning to be from the vein. So it wasn't just PowerPoint slides, everything kind of came from the vein. And that's what we built over the year with the 4 staff. And it means they can have it in their pocket. Now the vein has videos with it, which is, this is a cannula, this is how you put it in. And there's 6 videos with that. And that just stays with them. So they go to the ward and they're like, oh, I missed that. How did that happen? They can go back, or they get some amazing technique from somebody, but actually they then get problems with it because they've been taught some bad stuff as well. So they go back to our vein and make sure they're not wearing gloves and things like that. And it was about bringing that classroom together. So the last couple of slides for the last 2 minutes here, I've just got a couple more here. So they like the convenience. This has come out massively. I mean, obviously our first course was great. Had somebody I was trying to meet for 18 months that I met in Qatar from South Africa, Gloria. She was amazing. And she was unable to just come, okay, then I'll come because we've got the veins out to her. And then Dubai, and then, you know, Croydon and various places. And suddenly the world sort of started coming to us, and they just like that. And then at the end of the day, they just switched this off. It's been really good for working parents. So whilst they still have the child looked after, it's quite nice seeing the dogs and the parents, children coming up, they still have those looked after. They don't have all this crazy kind of logistics for 3 days to try and leave that important parental role. This is the phone version here, and how we try and bring it a bit more lively with video content, and we've got audio in that as well, so they can just listen in to the heart. We use some nice videos to bring, and then we relate this to this here. So this is a technique from a clinician themselves. We want more of this.
Doing this, you're not getting a full understanding of it. Yeah, I can feel the bump. I want to know more than the bump. I want to know the direction. I want to know the complications around it. I want to know.
So we kept building this, and so it would be all right on the phone, and with the software company we use is excellent. And we do live sessions with this as well. So we make it interesting, we make it available, and mostly people will do things on the laptop so they can get this great big picture here, but then they can dip in and out and do what we call micro sessions, like going behind the curtain. So this is, somebody showed me this years ago in A&E in Chelsea and Westminster, and I was like, oh yeah.
So you push this off here. Now, if you pull back too far, look what happens. Can't get your cannula in. You with me? So what you want to do is you've got in, you've pulled your needle back, because look, I can put my finger in there and it's not going to hurt. So it doesn't hurt at all, that.
So we're trying to really share with them, you know, that's what we want to, I think we've come to the end of the session now. So what we're trying to do is use that device, use the cameras, get behind the curtains of the things that are just treasures in healthcare, when we can learn experientially with patients. But actually, does a patient really need to experience somebody not really knowing how to use the equipment, or oof, it's kind of, I've lost it a bit and I've sort of gone through, or worse, I've transfixed and I've caught the back of the vein. So, you know, years ago I had somebody who, you know, they said after 50 goes, I was walking past a registrar in Chelsea A&E, and I was the assistant at the time, and he said, once you've done 50, to about 15 med students, once you've done 50, you'll know what you're doing, it'll be fine. And that was the training, and it was shocking. So obviously I changed that at Chelsea and Westminster. So to sum up really, I think what I'd say is that it's been a tough journey because there was lots of challenges and the environment was tricky. We knew it worked because we did it at NHS Direct, so it wasn't a full jump into the dark, but we had to pull people to it, and that's still the case now in a way. But it was just fascinating learning, and eventually, like that lady said, you know, I got really comfortable with it, and now I share that. But I think the overwhelming thing is that the cameras are really helping us with this flat pack trainer, and it's really helped. And I still want classrooms to come back, but I want classrooms to be masterclass. So skills labs become a bit more about that masterclass. And then the long term, I want some more of expertise sharing, so that we're sharing these sort of expertise with sharing expertise with each other, but then there's an anchor point of the vein. So I think that's it. If anyone's got any questions, I think I'm on time. I'm trying to be on time. Hello.
Yannick.
Thank you very much indeed.
Shikun. Yes. Any questions? Yes. Any questions to Dr. Sarah Phillips? Just if you have any questions, you can ask through chat box. We will be asking behalf of you. If you have any technical problem from your side, just you can raise your hand also if you have the questions. Yes, madam, you can. Yes. Yes. We really appreciate you, everything that we do. It was a great video, madam.
Thank you very much. Thank you very much for your time. Thanks for everyone's time.
Yes, thank you very much for participating in this event. On behalf of Organized Community Members of Nursing Education 2021, we want to thank you for your presentation. So we would like to inform that we will go with as one of the exhibitor for this upcoming 2022 conference with your name under the Wayne Train Limited from UK.
Thank you. And I'm not a doctor. I've never, I've got a master's, not a doctorate. So
yeah, sorry.
That's okay.
yes.
Thank you very much.
Yes, looking forward to meet again next time.
Thank you.
Yes. Next we ask Dr. Paul Crowd from University of Nottingham from UK to start the presentation.
Hello, everyone.
Yes, sir.
Okay. Are you ready for me to start? Hi, can you confirm that you're ready for me to start?
Yes, you can start sharing your slides, sir.
I'm not showing slides today.
So you want to go with the general topic?
I'm just going to talk.
Yes, you can start. You can go ahead.
Okay. Morning, everyone. And my name is Professor Paul Crawford at the University of Nottingham. And I'm going to do a talk this morning, a short talk without slides. Sarah gave you a wonderful presentation there with lots of slides. So I'm just going to talk direct to camera about Florence Nightingale and nursing education, drawing on our book, Florence Nightingale at Home, which came out last year to celebrate the bicentenary of arguably the world's greatest nurse. I'm grateful to my fabulous research team who joined me in investigating the concepts and realities of home in the life and work of Nightingale, with funding from the Arts Humanities Research Council in the UK, supported by many partners. Now, many of us will have been experiencing home in new and challenging ways through the COVID-19 pandemic. And for some, this experience has been positive and even creative, but for many others, it's been physically, psychologically, and socially painful, if not tragic. Underlined by social distancing, coronavirus has disrupted what home is for us, can be for us, and the boundaries between home and work, home and society. Home is where we start and often complete our life journeys. It's where we enfold into our families when sick or needy. Home is the big story, and in our book, Florence Nightingale at Home, we try to bring readers into the ideas and realities of the homely and at times unhomely world of our great nursing leader. We also consider how home related to Nightingale's development of nurse training. Finally, today, I hope to leave you with a few provocations about contemporary nurse training and the theme of home and homeliness. Now, although she was born in Florence, Italy, Nightingale's early life began at Lea Hurst in Derbyshire in the UK, at what became her family's idyllic summer residence. But in effect, she had many homes, notably the impressive Embley Park in Hampshire, but also London residences, including the Burlington Hotel and South Street. You could say she was very experienced in the whole business of homes and households, something which lies at the heart of her work as a nursing pioneer and social reformer, advancing a robust nursing family and healthy homes at a time when public health was in its infancy. In our book, we attempt to close the gap between a monochrome Nightingale, a rather distant national figure or icon, and offer a more intimate view through the lens of her domestic, emotional, cultural, and spiritual life. We aim to pump blood into her, give her blood pressure, if you will, situating her in her time at her home, or rather, we should say, homes. Now, the social foundation for Florence Nightingale's life of influence began at home with her wealthy family. Her father inherited a fortune from the rapidly growing industry along the Derwent Valley near Matlock in Derbyshire. In this context, she learned very early that home was a key site for people's health. Beyond her country house life, she witnessed at close quarters the poverty of families near her homes, choosing to visit the sick and helping where she could. She came to view the home as the seat of health, the place where the health of any nation begins and ends. As an early social reformer, she developed a commitment to improving the lives of the poor in their homes, to advance public health. In the 1830s, her early visiting of the homes of others less fortunate than herself underpinned her determination to improve the conditions of where people lived. She knew that better hygiene and ventilation could improve outcomes at times of contagion, a theme that has been apparent in all kinds of ways in the coronavirus pandemic. Her developing recognition of the home as key to people's health inspired her work in sanitation, improving the care of people in institutions such as workhouses, the social care of the time, and alongside philanthropists such as William Rathbone, community services to improve health at home by the introduction of district nursing and health visiting. Nightingale wrote, "When I go into a cottage, I long to stop there all day, to wash the children, relieve the mother, stay by the sick one. And behold, there are 100 other families unhappy within half a mile." Florence Nightingale developed a strong sense that homes had to be carefully managed and administered to achieve health. Her concern to make homes healthy and the skills to do so unfolded into an ambitious trajectory to reform trainings for nursing, other allied work, and public health initiatives. As we've battled coronavirus, so in her time, Nightingale faced various outbreaks of contagion from flu to cholera. Indeed, age 16, Nightingale experienced her calling to service during an influenza outbreak in Hampshire. Like us, currently, she lived under the palpable threat of infection. Mortality was an intimate, if unwanted, reality. She knew and drove changes to combat the unseen, dirty dangers lurking in our homes, hospitals, and elsewhere. She worked to drive death from people's thresholds, from the doors of their homes. Now, Nightingale's experience of life at home, like for many people, was not always happy. she railed against the preferred role of women in the home. She resented domestic sterility, amusing and entertaining males rather than developing her own path and ambition. She struggled with the idea of decorating the world of men and of marrying for security. Although her father had ensured an unusually deep and extensive education for her, Nightingale did not want to sit around and fit in. She wanted to break out and do her own thing, be active in the world. Basically, to work. Although the Victorians celebrated the notion of home sweet home, with the woman at the fire, etc., home for Nightingale came to feel increasingly sour and psychologically confining. It became a prison marked by idleness and lost aspiration. Nightingale had ambition beyond ornament and battled her family to work as a nurse. Given the poor morale and the whole reputation of nursing at the time, her family were opposed to this idea, but eventually she got her way. In a very strong sense, work became Nightingale's home, where she found her identity. Indeed, her temporary residence at the Burlington Hotel in London came to be known as the Little War Office or the Little India Office, the latter referring to her efforts to advance sanitation in India. Working from home and work as home were to mark her future. Nightingale developed a strong sense that homely comforts were important to human health and recovery. During her time at Harley Street, she gave great attention to homely aspects, such as the supply of good quality bedding, furniture, and food. She also encouraged the patients to feel more at home by coming out of their rooms, spending time in the communal area, and asking visitors to read to them. With the Crimean War in 1854, Nightingale got her chance to extend her homely experiences of care to wounded soldiers at Scutari Hospital in nearby Turkey. She used the administrative skills gained in helping to manage large households to good effect, bringing as much homely comfort as the logistics of the time allowed. Home comforts for men at the front, such as pocket handkerchiefs, shirts, stockings, mitts, blankets, were collected and sent to the Crimea. She even wrote letters of condolence and comfort to the families back home about their loved ones who died under her watch. Now, although Florence Nightingale is best remembered for the dramatic phase of her life during the Crimean War, from which she gained huge popularity on the back of newspaper reports of her efforts, much of her influential work actually came after the war years and on her return to England. She mingled concepts of home and nursing in this work. Unfortunately, her time looking after soldiers during the Crimean War came at a heavy price. Although undiagnosed at the time, whilst there she contracted brucellosis, most likely from unpasteurized milk. And for much of the rest of her life, the big part of her life, she suffered extensive bouts of pain and fatigue. Indeed, she achieved her greatest work from home and literally from her bed. There are several images of Nightingale lying on her chaise longue or tucked up in bed, famously in the Bozeke image of her at South Street in 1906. Ultimately, Nightingale built on the long history of caring done by women at home down the centuries. This overlap between home and nursing is clear. In her book, Notes on Nursing in 1859, which is all about the ways to keep homes healthy. As she emphasized in 1861, more sickness, poverty, mortality, and crime is due to the state of our poor men's dwellings than to any other cause. I would rather devote money to remedying this than to any institution. Florence Nightingale was also a deeply spiritual person who came to view home as a key site for religious devotion. She viewed human care as a spiritual mission. Accordingly, wherever she lived, she looked to create what she called households of faith. She pursued spiritual enlightenment and religious devotion for herself and for those around her. As an invalid for much of her life after the Crimean War, she became a self-appointed religious leader, a kind of Virgin Mother. Indeed, she took very seriously the influence that she could have as a kind of mother to the children of others, not least godchildren, and her nurses. She wrote in a draft sermon, "There can be no doubt for all history, all society shows it us, that there is a profound truth in the idea of the Virgin Mother, since it's not people's own fathers and mothers who influence them most, almost generally for good." So this religious backdrop to Nightingale's care and work and her representation is important, but should not surprise us. For centuries, religious orders have been key institutions in providing hospitality to visitors and strangers in need. Brought up in a Christian home, Florence Nightingale went on to learn how to nurse from her time in religious houses, such as at Kaiserswerth in Germany. In working to provide better facilities for nurse training, Nightingale aimed to replicate the mother house structure that she found there, where an alternative, spiritually grounded family could flourish. As you see in the photograph of Nightingale at Claydon House, a very famous one that you can Google, she was keen to be mother-in-chief to her nurses. And in such images, she appears at the center like a religious leader, an informal mother superior, if you will, of her own quasi-religious order, her own alternative family. Now, her determination for the motherly and the homely extended to her efforts for nurses to have secure living environments, not simply as moral and upright spaces, but also increasingly comfortable places too, offering homely features such as sitting rooms and flowers in rooms that encouraged a sense of well-being and self-respect among their occupants. As much as Nightingale has invaded the homes of millions of people as commercial product, photographs, statuettes, etc., most recently as a Barbie doll, the importance she placed on homely, compassionate care has inspired generations of nurses. While keen to drive the science of care and use statistics to chart improvements, Nightingale also knew that judicious homely care was important. The comforts of home could help human recovery. Importantly, Nightingale reminds us just how influential nurses can be through their writing lives, lobbying and advocating for change. Now, perhaps new nurse visionaries will continue to consider how to sustain a sense of community or family among nurses in contemporary threat environments, with target setting all the pressures that they find themselves in. The value of homely environments for health and recovery, and placing more emphasis on this. And political and social reforming action even if, as in the case of Nightingale, this is done not at the bedside, but remotely from their own beds. Please check out our website, florencenightingale.org, for all kinds of information relating to our project, including a virtual tour of her home in Derbyshire and the digital version of our exhibition, Florence Nightingale Comes Home. I'd like to wish all of you the very best during this difficult time. I hope that your reflections on the work of Florence Nightingale from this conference and from this talk, and perhaps your further reading, will inspire new visions of what nursing can be. I hope that our nursing care is not simply effective, but also as homely as possible. I also hope that during any current or future lockdowns, however described, your homes become sanctuaries, not prisons, sweet and not sour places. Thank you for listening.
Yes, sir. Yes. Any questions? Any questions to Dr. Paul Crawford?
If you have questions,
As one of the keynote speakers for this conference, just it's a general topic you have given. So, any questions? Just you can raise your hand. We'll be asking behalf of you, even after the completion of the conference. So you can read from chat box, or you'll be getting compliments from chat box. Any questions? Yes. Yes. Thank you very much, sir, for joining us as one of the keynote speakers for this event. Thanks for sharing tips with us, and thank you for message for frontliners for COVID-19 20. Our community is better because of your part. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for excellent presentation. Looking forward to you next time. Next, we ask Dr. Sabhavat Shakuntala Devi from College of Nursing, PT B.D. Sharma, PG IMS from Rohtak from India, to join the event and start presentation. Yes, madam, it's visible to us. You can start your presenting.
That's why I'm present here in front of you.
Yes,
And
madam.
thank you whole team for organize a wonderful virtual nursing conference in this situation, sir. Thank you, sir. Myself, Sakuntala. I am from India, College of Nursing, Pandit B.D. Sharma, University of Health Sciences, Rohtak, Haryana. I have 33 experience in nursing profession, sir. Out of 33, I have 20 year experience in clinical side, in OT, all type of assist in the OT case. And then, sir, I have out of rest of 13 year experience I have in collegiate program. Thank you, sir. And my research topic is, statement of my research topic is study to assess the knowledge of nursing students toward COVID-19 during the outbreak in Haryana at College of Nursing, Pandit B.D. Sharma, PGIMS, Rohtak. And statement of this study, sir, objective, I have to make objectives. One is to assess the knowledge of nursing students toward COVID-19 during the outbreak in Haryana at College of Nursing. And so second objective is to assess the effectiveness of plant teaching program on knowledge level of nursing students toward COVID-19 during the outbreak in Haryana. And introduction in this study, sir. As per WHO published the COVID-19 guidelines and protocols which were adopted by the Ministry of Health of different countries. Coronavirus disease 2019 is defined as illness caused by a novel coronavirus, now called severe acute respiratory syndrome coronavirus, which was first identified amid an outbreak of respiratory illness cases in Wuhan City, Hubei province, China. On January 30th, 2020, the WHO declared the COVID-19 outbreak a global health emergency. On March 11, 2020, in India, declared COVID-19 a global pandemic disease. Continue of the introduction. Now, it is very clear that COVID-19 is creating very disaster effects globally with India. People are getting panic, emotionally unsecure, depressed, and in a stage of confusion, unaware about facilities provided by the government. Regarding reliable news sources, symptoms of COVID-19 and its prevention with the cure. However, whether student nurses poses adequate knowledge relations to COVID-19 remain unexplored, being component of nursing curriculum. Preventive measures are no longer new to nursing students, but experience a pandemic is new to everyone. Thus, the knowledge of nursing students may be affected. And need of this study, student nurses form an essential part of the workforce dealing with the COVID-19 pandemic. They are frontline healthcare provider in any institution. During the clinical posting, the nursing students facing so many problems regarding the disease of COVID-19 pandemic. That is, what is corona and how to spread, how to assess the patients, and how to make nursing diagnose, how to maintain interpersonal relationship, how to give the psychotherapy during this crisis situation. Myths about disease, wear of personal protective equipment for a long time, and how to maintain the social distancing during care given of the patient. Nursing students are feared besides workload, dealing with critically ill patients and emotionally overloaded relatives is a highly challenging job for nursing students working in the COVID positive department. So researchers select this topic to assess the level of knowledge of nursing students regarding COVID-19 disease to identify the level of knowledge score in order to assess the readiness of nurses for upcoming challenging and given the better care for welfare of the patients. Methodology in this research topic, the evaluate approach is used in this topic because I have plan teaching program give to the students. Research design, descriptive study and setting COVID-19 positive ward at Pandit B.D. Sharma PGIMS Rohtak. Population of this study in the present study, population comprises of nursing students posted in corona positive ward. Sampling technique, of course, purpose is non-probability sampling. Size 80 nursing students, BSc nursing, post-basic BSc nursing, MSc nursing, and include NPCC student also. Tool, plan teaching program for evaluate the level of knowledge regarding COVID-19. A structured knowledge questionnaire was prepared to collect the data to achieve the objective of the study through WhatsApp, email, and other social media platforms. Variable of this study, I have two variables, independent and dependent variables. In independent variables, plan teaching programs, and dependent variable is knowledge of the nursing students toward COVID-19. Inclusion criteria, the inclusion criteria includes nursing students who provide nursing care for confirmed positive corona patients. Volunteer who participate in the study, ethical review, researcher was taken the approval in written form by the Principal College of Nursing. All participants signed informed consents and study subjects were allowed to withdraw at any time. Data collection. The researcher remained neutral in collecting the data and established good relationship with the participants. I used techniques such as unconditional acceptance, active listening, clarification to promote the authenticity of the data and to avoid bias. On the first day, pre-test was conducted to assess the knowledge of nursing students on COVID-19 using a structured question regarding knowledge of coronavirus. Second day, plant teaching program was administered through Zoom Meet, lecture cum discussion method. On the seventh day, post-test was conducted using the same knowledge questionnaire to assess the knowledge on COVID-19. Data was analyzed using descriptive and inferential statistics. Scoring. With one correct response, score 1 was given, and for wrong answer, 0 scoring was given. Respondent was requested to tick mark against the correct response, and total score allotted for this only 30 questionnaire. Level of knowledge, I have selected 3 levels: inadequate, moderate, and adequate knowledge. Scoring, I have 0 to 10 in inadequate knowledge, 11 to 20, I have selected moderate knowledge, and 21 and to 30 adequate knowledge as per scoring. Frequency and percentage distribution of subject variables of nursing students. Variables is as according to age, maximum of the students having 20 to 20 years, that is number is 47, and more than 20 years, that is minor 5 in number, and percentage is 6.3. Courses, or we can say standard, BSc nursing 43 in number and percentage 53.75. Post basic BSc nursing students in number 20, percentage 25. MSc nursing 12 only and percentage is 15. NPCC students I have include in study only 5, because in my college only 7 students at present in course of NPCC, and percentage is 6.25. Residents, maximum of majority of the students number in 72, that is hosteler, and percentage is 90. Out of 90, 10% day scholar students. Occupation of fathers. Majority of the fathers, that is number in 31 and percent is 38.75, and government servant and laborer both are 10 in number and percentage is 12.5. Occupation of mother, government servants 11 in number and percentage 13.75, and majority of in this sample housewife, that is 31 and percentage is 38.75. Religion, out of 80 samples, 78, that is majority of Hindus 97.5, and other like Muslim only 2, that is 2.5%. Monthly income of family in a month, majority of the sample have more than 30,000 rupees per month, that is number is 40 and percent is 50%. Information, getting from attending any seminar in these subjects, the students attend no any seminar, workshop, conference regarding corona positive, and from college and Department of Health only 7 in number, that is 8.53%. Maximum or majority of the students visit the online, or we can say YouTube, that is 63 in number, and that is 78.75%. Pre-test and post-test knowledge level scoring of students number in 80, level of knowledge as per inadequate, moderate, adequate knowledge. In pre-test frequency, that is 51 in under inadequate knowledge in pre-test, and 10% adequate knowledge, that is 12.50%. According to post-test, inadequate knowledge, that is 0, or percentage will be 0, and maximum majority of the students getting the scoring in number frequency 65, that is 81.25% in adequate knowledge. Effective of structured teaching program in terms of knowledge score. The findings show that mean post-test knowledge score was found to be significantly higher than the mean pre-test knowledge score. Discussion. So that total 80 students are participated for this study by its own interest. Subject chosen majority of that is, I explained already, that is 2022, that is 58.8% age group, and whereas 6.3% belong to more than 25 years. In that, 53.75 participants are belong to basic BSc nursing students, and post-basic BSc nursing 25%, MSc 15%, and NPCC belong only 6.25%. As per result, majority of Hindu students in study, majority of the students were living in hostel, that is 90%, and 10% were day scholar. As per participants, father occupations government servant 12.5%, private servant, and business 38.75%. According to study, majority of the mother 13.75% were government servant, and followed by 38.7% were for households. The majority 50% were in monthly income is, that is more than 30,000 rupees, whereas 12.5% family income of between 10,000 to 20,000 rupees monthly. Result also depict that no one student attend any seminar, conference, participation, leisure time active in visiting to social networking site, that is 78.75%, and out of that 12.5% other type of activity like watching the TV. Recommendation of the study. Based on the finding of the study can be replicated on larger sample to validate the finding of the study. Similar study can be carried out to assess the knowledge, practice, and attitude regarding COVID-19 disease among other health workers. The study can be done in different settings and different states of India as the knowledge may vary. Similar study can be carried out to compare another stream of students like MBBS, BDS, BPT, and pharmacological students. Thank you, sir.
Yes. Yes. Any questions? Any questions to Dr. Shakuntala Devi? Just if you have any questions, you can raise your hand. We'll be asking behalf of you, even after the completion of the conference.
Sir, thank you, sir.
Yes.
Thank you.
Thank you very much, madam, for joining as a speaker for this event. Thanks for sharing your tips with us. Looking forward to meet again next time in physical event.
Welcome.
You can, yes, you can get from chat box from Dr. Catherine. Thank you for this research, very informative. Yes. Next, we ask Dr. Kaiharu Miya from Mie University from Japan.
everyone, and thank you to everyone for having me here. My name is Chiharu Miyata. My research field is nursing administration. Today I'd like to talk about nursing of geriatric facility in Japan. So in Japan, year by year the society is becoming older. We are having a severe aging society. So the needs of geriatric facility are increasing along with the needs of the quality in it. The standards and the requirements of these facilities are also changing. But this is happening too quickly. The workers are not being able to keep up. Therefore, the reality is ruthless. Patient, family, and community expect nurses to demonstrate certain professional attributes while delivering nursing care, but the residents in these facilities are not quite satisfied. So I thought I wanted to fix this. There are two specialists of geriatric nursing in Japan. Generally, these specialists contribute to improve the quality of geriatric nursing. However, most of them are taken away to work in a general hospital. So the nursing quality in geriatric facility are still at low level. In terms of professional in nurses, social, cultural, scientific, and technological factors have influenced the development of nursing profession. In Japan, some researcher studies relate to profession of nursing, and Kikuchi and Harade invented the professional autonomy scale. It measured professional autonomy by 5 factors: cognition, performance, concrete judgment, abstract judgment, and independent judgment. This is the concept of my study. My ultimate goal is to put in place a system for them where they can gain more professionalism and able to more dedicated. Providing professional nursing care has been reported to result in improved patient satisfaction and positive health outcomes. Increased level of professionalism have also been associated with the outcomes of improved nursing performance and personal autonomy, ability to think critically, ability to reflect on practice, and empowerment. Therefore, this could improve the quality in care. In order to do that is by reconsidering professionality and gain it in these workers. So we reveal professional autonomy of nurses. So the aim of my study is to uncover the characteristics of professional autonomy of nurses in GHS and the factors related to their autonomy. Method study design is a quantitative cross-sectional design. The study was conducted in 20 GHFS in Japan. We use a questionnaire. The questionnaire consists of 3 parts: the background information, related factor with reference to previous research, job satisfaction, intent to continue work in GHS, collaboration with care worker, provide care in a collaboration with care worker. The measurement of professional autonomy, we use the professional autonomy scale. All static analyses were performed using SPSS. Demographic comparison were analyzed using Manhattan-U test, and multi-field comparison were performed using multi-factor analysis of variance, followed by the Bonferroni correction. Result: characteristics of participants. The 27% is female. Professional autonomy scale. Independent judgment is the lowest score. Association with the professional autonomy was found in age, work experience, license, job satisfaction, intention to continue work in a facility, collaboration with care worker, and care in a collaboration with care worker. So we discussed these results. So abstract judgment was significantly lower than the other items, especially the lower fracted items. I can make a decision on nothing by utilizing the latest information, such as a result of nothing research, had the lowest score. This is because the result is the same trend as in a previous study focused on nursing in a hospital. Also, in a geriatric facility, residents of GHSF have some difficulty or disability in expressing their psychological state due to the effect of mental and physical severity and dementia. Therefore, it is difficult for nurses to assess the psychological states of each resident with respect to such a characteristic of their residents. And nurses who are satisfied with their using work or who are confident and enthusiastic about their work are more satisfied with their awareness of the situation, nursing judgment, and nursing practice. Nurses with high autonomy are more aware of the needs for the nursing and the nursing care staff to cooperate and collaborate to provide care, and efforts being able to do so. In relation to professional autonomy and the willingness to continue work, highly autonomous nurses are strongly aware of the role of importance of nurses in an institution and are proactive and productive in their nursing work. This the reason of these results. The increase in self-esteem gained through the rule of the only medical profession, and it may make nurses want to continue working in a GHSF. For nursing activities, giving the opportunity to engage is indispensable formation of the autonomy of nurses, and job satisfaction is considered to be an important factor in enhancing the autonomy of nurses. So let me conclude. These results indicate that number one, the professional autonomy of nurses in the GHSFS has a low abstract judgment ability. This result is the same trend as in a previous study focused on nurses in a hospital. Number two, nurses who are satisfied with their job have higher professional autonomy, and nurses with higher autonomy tend to want to continue working in the facilities. Number three, nurses with a high degree of professional autonomy felt that they were working better with care workers, and there was a tendency for them to provide care in a collaboration with care workers. Number four, in order to enhance the professional autonomy of GHSFS nurses, it is necessary to create a system that enables nurses to strengthen their abstract judgment ability and their ability to understand the psychological state of the elderly and create a care plan based on it. Thank you very much.
Yes. This was the video presentation from Dr. Chiharu Miyata. Any questions, Dr. Chiharu? If you have any questions, you can ask through chat box. We'll be asking behalf of you. Yes. Yes, thank you very much, madam, for joining this event as a speaker for this event. Looking forward to meet again next time. Next, we ask Dr. Shaimahar Abdul Mohsin from Al Azhar University from Egypt.
Presentation appear, is it okay?
Yes, madam.
Okay. Hello everyone. Today I will present part of my project entitled Applying e-learning tools for interactive teaching in health professional education post-COVID-19. My name is Shaimaa Ramadan. I'm a lecturer of anatomy and embryology, Faculty of Medicine for Girls, Al Azhar University. This is our agenda for today. We will talk about background, objective, methods, results, and the impact of COVID-19 pandemic on higher education sector and conclusion. Let me first ask, how would the COVID-19 pandemic the future of the teaching and learning? Answering that question requires that we first acknowledge some difficult truths. The COVID-19 possesses challenges to education, how some universities have transitioned from in-person to virtual instruction, and how they have managed this crisis, adaptation, challenge, and opportunity. As the coronavirus pandemic has spread across the globe, nearly every country had to react. Therefore, today the world finds that 99% of all students officially in education are affected. These students are served as a part of global experiment with a wide variety of modalities being tried for the continued provision of their education. E-learning is a method of learning delivered on distribution or mobile over communication technology platform and conducted using information technologies, e-tools and e-services, e-resources, all of this for what? For learning purposes. E-learning hasn't been sufficiently exploited in the past, particularly in developing countries. However, the crisis of the COVID-19 pandemic has forced the entire world to rely on it for education. The use of e-learning tools for active teaching during the COVID-19 pandemic has greatly improved the quality of healthcare through specialized graduation that target the need of the community. However, there is a paucity of data in low resource sitting on the possibility of online learning platform to support medical education. E-learning can have great benefits in solving public health problems and promoting global public health scholarship through online and e-learning. There is no region in the country or the world that has a monopoly on public health knowledge, as new ideas are generated around the world every day. Our aim is to estimate the health professional education staff and students' perception, evaluate their experiences, recognize their barriers, the challenges of e-learning during COVID-19 pandemic, and investigate factors influencing the acceptance and use of e-learning as a tool teaching within higher education and training both staff and students to use these tools. Interventional study was performed for both students and staff who was supposed to deal with the different e-learning tools. This study was conducted to evaluate the virtual classroom experience after training of the staff and students on different e-learning tools, interaction between both students and the staff, advantage and disadvantage of e-learning among health professional education, increase their focus on problem solving and how to engage students, have fun in the process. The need for this study is supported firstly by strategic plan to detect which e-learning tools we need and how could we start the training development program. Secondly, training need assessment surveys was performed for both students and staff, followed by analysis of this survey, and accordingly, main lines of training were detected. Our results indicate that about 96% rated the e-learning activity as high effective with active teaching. 100% wanted to know more and more about e-learning tools. E-learning is a timely topic, and the international perspective is useful, specifically in the light of the COVID-19 pandemic. E-learning has become a mandatory component of all educational institutions around the world. Due to the pandemic crisis of COVID-19, this deeply situated has flipped out the offline teaching process. E-learning provides an effective teaching also methods that bring out the best in learners. The main core of education is to learn. Learning is the process of acquiring knowledge or skills through study experience or being taught. And so, any freak accident that happens in the world will always leave its impact on education. And so, the pandemic of COVID-19 has its footprint on education. The outbreak of this dangerous virus across the globe has forced educational institutions to shut down to control the spread of this virus. This happening made the teaching professional think of alternative methods of teaching during this lockdown, and thus it paves the way toward the web-based learning or e-learning or online learning. In today's scenario, the learning has stepped into the digital world in which teaching professionals and students are virtually connected. E-learning is quite simple to understand and implement. The use of desktop, laptop, or smartphone and the internet form a major component of this learning methodology. E-learning provides rapid growth and proved to be the best in all sectors, especially in education during this lockdown. Due to the COVID-19 outbreak, universities closed and locked down. Most staff and students are enforced to move online education. The faculty members have begun to get online training on how to use e-learning and distance learning tools to deliver online teaching to their students. At the same time, faculty and staff members are learning how to use online learning platforms. They are using only delivery through face-to-face teaching. However, the shift to online mode has raised many queries on the quality of education. Thus, unexpected shift from face-to-face learning to online learning, there are some difficulties faced by students and staff. Moreover, most of higher education institutions have significant issues with technological infrastructure, especially in rural areas. Thus, the standard of online education may be a critical issue that need essential focus. Therefore, top management of the universities must be provided with recommendation for developing an understanding of the implication of e-services quality, information quality, system use, and user satisfaction concerning e-learning successes. The impact of using e-learning during the COVID-19 in health professional education institution. COVID-19 pandemic motivates educators to make use of new technologies to enhance teaching, learning, and overall education performance. Moreover, COVID-19 pandemic has presented a need for greater integration of technology as a platform and the environment to educate students. This has been met with the great challenge in terms of the best practice and the empirical research to guide instructors. The distance learning tools implemented in response to education crisis caused by the COVID-19 pandemic have revealed the potential of new technologies, especially those using e-learning and information and communication technologies in education. Impact of COVID-19 pandemic in health professional education sector and the need for e-learning tools are modern teaching methodologies developed through this crisis have a great influence in terms of cooperation and collaboration in sharing experiences related to the best practice in teaching and learning globally. New learning and teaching approaches that utilize information and communication technology and digital technologies have enhanced students' skill in producing digital artifact, critically questioning online material, and use ethical digital practice. The information available also indicates that overall the online training provided during the COVID-19 has positive developmental and learning experience for those who attend the courses. While most participants indicate that they were already comfortable in using the digital technologies within their teaching during the coronavirus crisis, the result indicates that the online training on the use of information and communication technology and e-learning tools and platform helped them to realize further opportunity to integrate into student focus and collaborative learning techniques. It is clear that the more creative problem-based work in the e-learning environment allowed for greater engagement with the content and the idea, resulting in great acknowledged transfer and transformation. The application of flipped methodology was proven to have a positive impact on the students' learning process during the lockdown due to coronavirus, especially for graduate students, where the use of problem-based learning couldn't be that effective during the lockdown due to the nature of online-based learning. Where flipped methodology were used in online learning during the COVID-19 pandemic, this appeared to have enhanced teaching and learning because it allowed extra breaks and the discussion from the students and staff as well. E-learning is not the result of current situation crisis due to the outbreak of coronavirus in most countries around the world. Its transformation into pandemic prevented the continuation of educational process in the traditional face-to-face form in all educational institutions at all levels. Consequently, many universities education institutions adopted the e-learning system either completely or partially to raise the efficiency and effectiveness of the educational process and advance it towards achieving its goal during COVID-19 pandemic crisis. The students see the utilization of e-learning methodology during the lockdown has some benefit, and whereas other performing to have face-to-face classes. The course of e-content and material are available 24 hours per week for students via official platform. Conclusion. Advances in technology use are alternative and rapid approach for undergraduate, graduate, and healthcare providers. Thus, it could represent that the use of e-learning in active teaching can represent an ideal solution to sustain learning process in exceptional and emergency situations such as COVID-19 pandemic. With technical and infrastructure challenge and in understanding of the technological, financial, and institutional barrier for staff and the student is critical for applying e-learning tools for interactive teaching. With changing time comes the need for changing method of instructions and more active learning. The crisis that encountered the educational sector due to the outbreak of coronavirus has pushed e-learning toward the forefront, so it become an irreplaceable option. Thank you so much.
Yes. Any questions? Any questions to Dr. Shaima Abdul Mohsin? Just if you have any questions, even after the completion of the conference, you can mail us. We'll be asking behalf of you. Yes, thank you very much, madam, for joining this event as a
Thank you to giving me the chance to be with you. Thank
Yes.
you.
Yes. Thanks for sharing it with us. Looking forward to meet again next time in physical event if everything goes well in 2022. Yes, you can get from the chat box. Thank you for excellent presentation, very comprehensive and clear from Sarah Phillips, as well as Dr. Catherine is going to give a compliment. Thank you for the positive impact perspective for e-learning in nursing education. Yes. Next we ask Dr. Gunnar Gluco Kuntu from Brazil. The topic will be teaching in the Bachelor of Nursing from an emergency remote teaching model and Brazilian experience. I think Dr. Gunnar is not in the Zoom meeting. Meanwhile, we ask with alternate speaker Dr. Fabiano Rosa Honda Maru from University Paulista from Brazil. The topic will be knowledge of elementary school teachers and first aid in children. It will be a poster presentation.
Participate in the Congress with nurses from all over the world to get to know a little of the nursing practice in various places. I will present this work performed together with a nursing undergraduate student with elementary school teachers in the school in a city of São Paulo, Brazil, about the knowledge regarding first aid in childhood. It's important to remember that school is a place where children spend most of their time. Just it must be a safe place for accidents to be avoided, and they happen. They must be attended to promptly. Thus, the objective of the work itself identify the knowledge of preschool and elementary school teachers regarding first aid involved children to a questionnaire to teachers from preschool to elementary school to identify the teachers able to recognize and apply first aid in the school environment and to develop a brochure that addresses the main topics on first aid according to the answers presented by the teachers. This is non-experimental, descriptive, and explorative field research with a quantitative approach. A questionnaire with closed questions was prepared and sent to a specific population to be investigated, and the model used for this data collection called Snowball. That is, snowball sampling consists to identify the target group on the research to be interviewed with to use it to forward to other possible interviews. Just simply nothing more. The network where one research subject refers another one that has the same required profile will return refers a third and or so. It was found that, contrary to other studies, the participants in the question have considerable knowledge on the subject. 70% of the questions had correct answers, between 8 and 100%. Some percent states that they attend lectures every year, as well courses, online classes, workshops, and 41% of the participants states they have never participated in the kind of achieved related to first aid. We believe that favorable percentage of satisfactory answers in view of the existence of the training program for these teachers in the municipality in the question. We conclude then that it's a great importance of necessity the insertion of the first aid course in the curricular grid in higher education science schools, and children recreation space needs to have teachers prepared to attend all the students, ensuring that they developed in a safe environment. It's also notable how much nurses can contribute to the development of these teachers through health education, which can be easily accessible to these teachers through the school health program. Thank you for your attention.
This was the presentation by Dr. Fabiano Rosa. If you have any questions regarding this topic, just you can ask us. Any questions regarding this topic to Dr. Fabiana? So, next keynote speaker of the day 2, we asked Dr. Mary Esther Buster from Georgia Southern University from USA. The topic will be wins and losses through lens of COVID-19. Moving forward. Yes, madam, if you are ready with your PPT, you can start sharing. So we'll do one thing. I think just we are 40 minutes ahead of actual program. We are for 40 minutes ahead of our actual program. We'll take 10 minutes break and we can recover the actual scientific program of the conference. So just we'll take 10 minutes break. Yes. So next will be Dr. I think everyone has joined you. Yes, sir. We are going to start the program again after completion of our small break. So we have more 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. More 15 talks we have. According to scientific program, Dr. Nashant, Dr. Mary Esther Bester, as well as Dr. Frida, Dr. Rajni will be going to start the program. So meanwhile, we'll ask Dr. Rajni Chaudhary from Grand Canonian Institute from USA as one of the keynote speaker for this conference. We're going to start the presentation.
Hello everyone. My research project was on education on fall risk prevention strategies. My background, I work as the AD and faculty at Dallas College in Dallas, Texas in USA. I have total of 32 years experience in nursing practice or educator, 15 years in India and 17 years in USA. I have worked 5 years in ICU in USA, and from last 12 years I am working as a faculty. Being a health professional, we all know that fall can become severe and costly. It also is a second leading cause of death worldwide. Most of the fall prevention strategies are available for age group 65 and above. The middle group has not been addressed much related to fall risk factors and fall prevention strategies. There is need to pay appropriate concern on middle age group death rate and identify health prevention strategies for this age group. I will also like to add here that most of the chronic diseases involves the middle age group people. For example, diabetes, hypertension, alcohol or drug abuse, mental health illness and other chronic disorders. The comorbidities and medication is the main reason of fall in this age group, as these may cause postural instability and imbalance. The identified need for my research project, the middle age group may overestimate their ability to function and find themselves at an increased risk of falling due to their physiological or mental conditions. The incidence of fall is not only a problem in old age group but also for the middle age group. The incidence of fall increases with age. As I mentioned earlier, most of the strategies today are for the older age group above 65 years old. The health education on fall prevention started early in middle age will prevent falls in the future. This project was done in the middle age group. The purpose of this quantitative pre-test, post-test project was to determine if or to what degree the implementation of the Fall Risk Assessment Questionnaire (FRAQ), used in the conjunction with the Stopping Elderly Accident, Death and Injuries study tools used as an educational intervention on falling would increase the knowledge of fall risk prevention strategies and fall rates for participants between the age of 50 to 64 years at a health clinic in urban Texas over 4 weeks. This quality improvement project uses HBM health belief model to increase people's knowledge related to fall risk and fall prevention strategies. According to health belief model, the health-seeking behavior is influenced by threat of health problems and associated value of action taken to prevent this threat. Knowing about modifiable risk factor will increase the belief that many of the risk factors related to falls can be avoided if precautions are taken. Quantitative methodology with one group pre and post test design was used. By using this methodology, the data was collected numerically and in unbiased manner. Statistical analysis provide more objectivity by using this method. Data collection. The total number of participants were 30. The mean age of participant was 58 years, ranging from 50 to 64, with 14 females and 16 males. The specifics on methodology. The FRAQ was validated in a range of patient and practice settings, and it plays a vital role in identifying specific differences in knowledge of risk factors. The kappa coefficient demonstrated excellent and substantial reliability for FRAQ. The values for intra-rater and inter-rater reliability were 0.89 and 0.76 respectively. The study toolkit is a theory-driven, evidence-based tool and addresses the issue of individuals' behavior change along with modifiable risk factor. Data collected as per IRB consideration: planned schedule, voluntarily participation, informed consent, right to withdraw any time, no coercion, participants get enough time for questioning. Methods of data collection: random collection, read and understand English, right and confidentiality was protected, informed consent. The results and analysis. Table 1 represents the demographic information. The pre-test and post-test scores from Table 1 were entered into a SPSS, a variable 1 and as a variable 2. Table 2 represents the environmental, behavioral, medical conditions and drug-related categories of FRAQ answers, which are indicated by using different colors of green, blue, yellow and pink. 30% reported as an excellent health, 43.3% reported as very good health, and 60% reported as no fall in the past. No change in perception, not at risk for fall. This is all in contrast to medical risk factors present in the population. 36.7% suffering with blood pressure, 23.3% with diabetes, 10% with cataract, and 10% with arthritis. About half of the participants reported using some medication identified as a risk factor for falling including treatments for blood pressure, heart disease, and pain. One of the factors which influence this above perception is perceived severity. According to the health belief model, people may not perceive their illnesses severe enough to be into the risk. Excuse me. Figure 1 displays the bar graph representing the normal distribution of knowledge gain. The results further suggest that gain in knowledge were more prominent with environmental and behavioral factors as compared to medications and diseases that are risk for falling. The people scored higher in behavioral and environmental categories. The behavioral category showed little change in the post-test but showed higher in the pre-test, which can be explained by health belief model. The health-seeking behavior of an individual is influenced by the perception of threat related to the health problems and the value associated with the actions to reduce the threat. Conclusion: a paired t-test showed a significant difference between pre-test and post-test scores. About half of the population reported as enjoying good health. More than half of the population reported no fall in the past. One third to one-fourth of the population exhibited risk factors like high blood pressure, diabetes, cataracts, and arthritis. The fall rate was 33% before intervention and 0% 30 days after intervention, measured by FRAC. The post-test showed higher scores on environmental and behavioral categories. The result of the data analysis supports the conclusion that the population in the age group of 50 to 65 years, which is a middle age group, may benefit from a more structured education on the risk factors of falling. Implication of my research project: the knowledge improvement related to fall prevention strategies will prevent falls in the future in the middle age group as well as in the older age group. There are not many strategies available for the middle age group related to fall prevention. Using fall prevention strategies in the middle age group will prevent falls in the future by increasing knowledge related to fall prevention. Prevention efforts should begin from assessing an individual for risk of falls. There are two approaches to identify fall risk programs. The first is the fall prevention method should be individualized. The second, the program must include environmental factors, the culture interventions, care process interventions, and technological interventions. My recommendations: to find out the differences between males and females related to education on fall prevention and use of strategies for fall prevention. Find out the falling rate on population receiving fall prevention education with a gap of more than 6 months. Are people using fall prevention strategies after receiving education on fall risk and fall prevention? More research projects can be done to analyze the long-term efforts of fall prevention programs in healthcare system. The healthcare provider who prescribe medicines can take responsibility for assessing, reviewing, and educating on fall risk increasing drugs. These are the references. This is my contact information. If you have any question, please text me or reach me to my email rashnichaudhary@yahoo.com. And thank you everyone for your time. This is my contact information.
Yes. From Dr. Rajni Chaudhary, topic on education on false risk prevention strategies. Any questions regarding this topic to Dr. Rajani Chaudhary? Any questions? Yes, we asked Dr. next. Thank you very much, madam, for participating in this event as a video presenter, as well as one of the keynote speaker for this conference. Looking forward to meet you again next time. As well as on behalf of organization members of Nursing Education 2021, we want thank you for your presentation. Next, we ask Dr. According to scientific program, next we ask Dr. Frida Nodebo from UCL University of College from Denmark. If you are ready with your PPT, you can start sharing, madam. If you are ready with your PowerPoint presentation, you can start sharing. The topic will be the developing sexuality of childhood. We also invite Dr. Mary Estelbester from Georgia Southern University from USA as one of the keynote speaker for this conference. If you are also ready with your PowerPoint presentation, you can start sharing. Also Dr. Nashant, the University of Texas Permian Basin from USA. Actually, yes, madam. We asked Dr. Mary Estelbester from Georgia Southern University from USA as keynote speaker for this conference. We would like to inform Dr. Mary Bester is joining this scientific events since last 2 years and encouraging these scientific events during pandemic COVID-19. The title of the topic will be Wins and Losses Through Lens of COVID-19 Moving Forward. Yes, madam.
Good.
Yes, it's fine, madam.
Good morning, and thank you to be with you for the second year. And allow me to share my story with you. Is the sound okay?
Yes, it's fine, madam. It's fantastic.
Good. I want to share my story with you, and I know my story is not different than many other people's story, but maybe there are some new sons I can bring to you. So I'm going to talk a little bit about how normal and abnormal blend, the impact it had on our student success, how we're adapting to normalcy, and then going to conclude with what do we need to take into account about our new or about students as we move forward. Sorry, apologies for that one. So the first one I want to say is, I think at times the abnormal started looking normal. This looks more like a boat than a house, but it started looking normal for us. And then suddenly, as we move through the COVID, normal start looking abnormal. And this is a slide that I selected to share with you to show you we also learned a lot. Here I had a group that were working in the class with group work, and then at the same time I had breakout rooms going on. So what I tried to do was trying to still create that feeling for students of we are part of a learning community. We also had situations where we could celebrate. You notice our two students with their mask on, we could celebrate all their life successes that we normally did. And to the left is actually a student of mine sitting doing schoolwork in the middle of the airport. So we realized actually how adaptable we are. And then we returned to classes, face-to-face classes during summer and now during fall. So there were a lot of things that we had to learn along the way. So what did COVID, what effect did it have on our students? And I just highlighting two things, the NCLEX rates and the readiness for practice once graduating. These data I pulled from the NCSBN site. And the first slide, you notice that we see a drop in, that was in 2019, actually pre-COVID. I couldn't find any reason why they explained that drop. And then a drop again in the last quarter of 2020. What I want you to notice is that initially, if I look at the trend line, there is a downward trend, but it's not really so significant over time. Then what I did is I pulled the 220 till 221 data that is available. And now look at this picture, that we see a very strong downward trends on the NCLEX results. This data represents all US new grads who did the NCLEX exam and passed for the first time. So it definitely declined. So many schools say, yes, we see a decline. Some schools say, no, there's no decline. But this slide speaks for itself. What about the impact on clinical experience? The NCSBN in their Spring 21 newsletter state, 62.7% say that their clinical experience during COVID time were totally discontinued or online clinicals. And that's significant, because that tells us that the new grads coming into the workplace come in the workplace with limited real life experience. And yes, we try to do our best when we do simulation, and I am actually very positive about simulation. But this is something that the new grads actually mention and say, yes, it is good, but it also leaves us feeling not as competent. So what's the perspective of the nurses working in the field with these students? They say there's a lack of clinical judgment skills. 66% say the nurse graduate that we see now post-COVID are less prepared to enter practice than those graduating 5 to 10 years ago. And according to them, they are too heavily reliant on technology and they can't apply their knowledge in practice. So the nurses in the field say, okay, you have done a wonderful job in getting the hours done, but the students are not as competent. Furthermore, and that's the fact of the reliance on the technology that I want to highlight there. So what's the students' viewpoint? 76% of the students said that the integrating this technology that we use, that it really helped them to prepare better. So that's actually quite a high number of students that appreciate all our hard work in trying to equip them for their future nursing careers. Only 20% say that they have adequate knowledge when they enter the clinical practice. So I think it's once they start working that they really feel that they not necessarily have the necessary knowledge and skills. So in that same newsletter I referred earlier to, about what happened about the job searching. The job market was challenging. And those of us who work in nursing school with students exiting know that in the past, students would 1 month into the semester say, oh, I've got a job here, I'm a new grad residency there. And what we see, it's not necessarily the same anymore. And job searches were difficult after graduation. Until today, it continued to be difficult. Now, there are different reasons. We also know that especially during COVID, some of the hospitals stopped some of their recruitment efforts. They didn't necessarily put positions out for new grads. So that has been changing for a while. But for the student, this is really a big concern. So now we have moved from normal, abnormal, abnormal, normal. We see that the nurses themselves don't feel so prepared. We see that the practice settings say, no, nurses are not any more prepared, and our students are finding it more difficult to secure a position after graduation and successfully passing the NCLEX, which seems to be a decreasing rate of success. So now we are back to normalcy. We have got like face-to-face classes at the university where I am. We are the typical classes that face-to-face, we face-to-face. And suddenly what we find interesting, that some students actually say it's very difficult to adapt to face-to-face classes. Now, remember last year when we asked them the question, they said it's very difficult to adapt to online learning. Now they tell us it's very difficult to go back to face-to-face learning. Not surprisingly, they miss the flexibility of online learning. And what was significant for me when I started talking with the students was they feel that from a clinical perspective, they feel a little bit left behind. And what we definitely see that there's actually less engagement in class. So I must admit, I was a little surprised with this. I was coming into the fall semester with, oh, my students are going to be excited to be back in class. They want to be back in class. I was really excited about that. Interesting that some of them are really anxious to be back to the proctored class testing. Some of them are anxious about we back to the traditional assessment methods, because during COVID, the much more leniency or flexibility regarding assessment methods, not necessarily the typical computerized testing, but to try and find other innovative ways of assessing their knowledge and skills. And then I was horrified to learn that some just want to return to the PowerPoint lecture days. And all they're asking is, just give us the PowerPoints. We don't really like all these group work and fancy stuff that you guys have learned about. Okay. So things are like, I forgot to how it feels to sit in a class for 4 hours. I don't feel well. Can I stay home? Can you send me your Zoom link? What's important to learn for the test? Why can we only learn the PowerPoints? We just got all the stuff from other students. Why is this test different than other semesters? Some of them appreciated us. They said, oh, the ebook, using ebooks really helped them because we add some notes, we can highlight it. Some loved the idea of using Flipgrid, that they make their own little videos that they can share it with others. And then a lot of them find it very helpful that we make like test review discussions. So now that we know what was happening during COVID, what's happening now that we return to the fall semester, let's look at what can we do? What lessons can we take further with us? And this is just a little model that I said that from a student perspective, it's why must I learn this? What must I learn? How must I learn it? How and when is testing done? And where do I find help? So this is what the things that I'm going to look quickly at. First of all, we must try to connect the dots. Yes, it's ultimately the student to connect the dots, but we can help them. A student who can see why they are learning certain stuff and how it relates to their future careers are much more much more engaged. Are they going to learn it? If a student just get a lot of information and they don't know where it fits in the bigger picture, they're not going to learn it. Navigation. We assume that because we're working with Gen Z students, that they know about social media. They want to get assistance. They want to know, how do I go through the gradebook? How do I use this learning management system, whether you use Blackboard, WebCT, D2L, whatever you use. We need to help them to get really into looking at their own learning styles, time management, and how to ask questions. We need to try and change that, just give me the PowerPoint type of thinking. And then the digital technology. We did a great job last year as all the educators to get used to it. So we just need to really embrace it. And when we're back in class, don't forget about those. These are just some of the things that I did, is giving them a really week-to-week idea of how the program is looking. Detailed learning outcomes so that they know when they're going to study exactly what are required from them. Where do they need to put their focus? Ebook, and here I did not, yeah. Different types of assessment. We're back to spending a lot of time on assessment at the end, on summative assessment. But there's also opportunities to increase our formative assessment, like Google Forms. That one with the eyes is a person that was a Google Doc, a self-activity. Flipgrid videos, I let them make, give their comment. It was about the insulin administration and what went wrong. Introducing themselves here at the bottom of my screen, where they also could meet each other, even if it was has been a face-to-face class, but they come into the class with an understanding of knowing each other better. And then here I've got my ebook. Some of you may use Perusal. This is the ebook that's provided by the publisher that we use for this particular course. So it's important that both formative and summative learning, but also self-assessment. Let your students be able to identify if they're on track. Tell them what to expect. How long are the questions? What type of questions? I think we sometimes spend so much time to put this secrecy around testing. We don't necessarily always review. And there are different opinions, and that's a discussion for another day. But why all this secrecy around testing? Students know what they can expect from testing later on. Okay, so these are just a new thing I started doing by actually asking students to tell me or give me potential questions. They've got a very clear guideline, you know, the difficulty level, what been expected. And then for each test, I include about 10% of those questions randomly. And then I do a test analysis. And one of the interesting things that I found is that actually students did not do better on the questions that were selected by themselves. Assistance. Yes, students get formal assistance at the institution, but they also need us. What is important for these new learners is they want to feel a connection with the faculty. They want to feel a connection with other students. That's easier for them because they can use group me text, etc. And the other day, I had a student that actually came to me and she formally introduced herself to me and to say, oh, I've texted you or and emailed you about this or that, that is me. They want to meet us. We can also do other things to try and get this connectivity going. One of my difficulties was to do group work before. And then it was interesting that the changes during COVID helped me to find other ways. And one of the things that I did is I started doing it as a shared group discussion. So what you will notice is that I did put instructions for each class group and for each breakup room, specific questions that they had to do. And then students had that as a final document. So this was like quite exciting to what extent they really look at it. The difference between feeling that flipped learning of learning the knowledge themselves, and they find it helpful. Students still like to see you individualized appointments, whether it's person or online. I use my Google Calendar for that so that they still have got control in selecting when they want to meet. And these are just my references. I would gladly share it with anybody. And I'm coming to an end, but as I say, all stories have an end or a beginning, or must I say, and a beginning. And there's my contact detail. Any questions?
Yes. Any questions? Any questions to Dr. Mary Estelle? Just if you have any questions, you can ask through chat box. We'll be asking on behalf of you. Any questions? Yes. Thank you very much, madam, for sharing your topics with us. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for instant presentation. Thank you so much for joining as a keynote speaker for this event and encouraging this kind of scientific events during this pandemic COVID-19.
Thank you.
Yes. You have got a comments from chat box from from Sarah regarding live learning. Did you notice an increased connection? Yes.
If I understand the question correctly, I actually didn't notice an increased connection. It is getting better. We are heading into week 8, but actually it is not the same level of engagement that I find comparing it to pre-COVID.
Yes. Compliments from Dr. Gabriel. Thank you. Dr. Deepa Jose, thank you so much. From Dr. Soumya, great job. Yes, thank you so much, madam, once again.
Thank you.
Yes, have a nice day. Next we ask one of the keynote speaker for this conference, Dr. Nashant Abdul Heza from University of Texas Permian Basin from USA. The topic will be the importance of cultural competence in nursing. Yes, sir, you can start sharing yours.
Good morning.
Yes, sir. Good morning, sir. How are you, sir?
Good. How about you this morning? Okay, so the importance of this presentation is the title of this presentation is Importance of Cultural Competence in Nursing and Practice. So this is a quantitative study. The background of the study is, as you know, there's a surge of multiculturalism in the United States, causing a demographic shift. In 2012, the U.S. Census Bureau indicated that roughly 13% are of foreign-born countries, 33% of the population speak other languages beside English. Hispanics and Asians are the fastest growing population in the US, and it is projected that ethnic minorities will comprise the majority of the population. However, health and healthcare disparities among racial and ethnic minorities remain elusive and grave. And furthermore, there's a paucity of minority nurses in practice, with a racial mismatch between nurses and patients. HRSA in 2016 reported that almost 83% of working nursing are Caucasian white nurses, rendering care to increasingly culturally diversified patients. So my problem statement, that lack of cultural competence among healthcare professionals such as nurses and healthcare system can actually perpetuate health and healthcare disparities among minorities. And minorities also are disproportionately burdened by chronic illness, disability, and reduced access to health services. Furthermore, there's increased morbidity and mortality rates among racial and ethnic minorities. In 2013, the CDC morbidity and mortality weekly report indicated that Blacks were 50% more likely to die from heart disease or stroke than whites. Infant mortality rates for Blacks were more than double the rate of the whites. And the prevalence of diabetes among Hispanics and Blacks was way higher than whites. So the purpose of this study, this cross-sectional quasi-experimental study, was to evaluate the effectiveness of transcultural educational intervention on nurses, direct care nurses, cultural competence working in acute healthcare settings. Furthermore, the study examined if the demographic variables of participants such as age, birthplace, gender, race, level of education, years of nursing experience, and any previous training and cultural competence were actually predictors of cultural competence. I had 5 research questions for this study. The first one was, Will there be a significant increase in nurses' cultural awareness after completing the educational intervention? Will there be a significant increase in nurses' cultural knowledge after completing the transcultural intervention? And will there be a significant increase in nurses' cultural desire after completing the transcultural educational intervention? My fourth question was, will be there a significant increase in nurses' total cultural competence scores after completing the educational intervention? And finally, examining the demographic variables, my research question was, will be there a significant relationship between participant demographic variables such as age, birthplace, their gender, their race, level of education, their years of nursing experience, of any previous training in cultural competence, and their total cultural competence gain scores. I tested the theoretical framework that I tested, and the tool that I used was Campina Bakori's 1991 theoretical framework, and it's called the Process of Cultural Competence in the Delivery of Healthcare Services. This theoretical framework views cultural competence as an ongoing process in which the healthcare provider continuously strives to achieve the ability to work within the cultural context of the client, and the client can be either the individual, the family, or the community. This theoretical framework has 5 constructs: cultural awareness, cultural knowledge, cultural skills, cultural encounter, and cultural desire. My conceptual framework and the relationship of my study to the theoretical framework is that my educational intervention will target the cultural knowledge, which is the cognitive learning domains of my participants, cultural awareness, which is the effective learning domains of participants, and cultural desire, which is the effective learning domains of participants. My review of the literature yielded 3 sections: cultural competence in nursing, interdisciplinary cultural competence, and previous applications of Campina Bakori's theoretical framework. And synthesis of the literature, the cultural competence in nursing section concluded that nursing research accentuated the significance of rendering culturally competent nursing care in an attempt to reduce health disparity among culturally diverse patients. Both qualitative and quantitative researchers underscored the impact of cultural competence education has in improving students' cultural competence, both in the undergraduate and the graduate nursing programs. Cultural competence education has a desired impact of improving nurses' cultural awareness, attitudes, knowledge, skills, and self-efficacy. Furthermore, the bulk of research concentrated primarily on cultural competency in nursing education and nursing academia, with a little focus paid to its effectiveness in clinical practice. So this study addressed such a gap by estimating the significance of cultural competence education on frontline nurses working in acute healthcare settings. Now, interdisciplinary cultural competence concluded that the professional stress also the need to understand diverse cultures and its dynamics. Its intricacies and what goes into building the culture. The provider should be aware of their own cultural belief, biases, and shortcomings to avoid cultural imposition. Other disciplines are commensurable with the nursing profession regarding the importance of offering cultural competence education to their staff. Previous applications of Campina Bakori's theoretical framework and research, different disciplines in healthcare have also used her theoretical framework and her instrument, the IAPCCR. Previous applications of her conception of her theoretical framework in nursing have mostly focused, as I said before, on nursing students in academia. Few scholars have used this paradigm to address the cultural needs of frontline nurses, and her theoretical framework has been successfully applied and used in other disciplines also, not just nursing, both in quantitative and qualitative research. So my methodology, of course, is quantitative research. which has its epistemology in objectivism and theoretical perspective and post-positivism. Quantitative research is characterized by numerical and statistical outcomes that we can deduct from the sample and try to generalize it to the parent population. This study was cross-sectional, so we collected the data captured in a single point of time, and it was quasi-experimental pre-test, post-test without control group design. So I had one group, no control, and to show the effect of independent variable, which is my educational intervention, on nurses' cultural competence, which is my dependent variable. So the settings and the sampling, the setting took place at a large urban metropolitan hospitals located in Central Florida. I used G-power analysis 3.1 to estimate my sample size using alpha level of 0.05 and a beta level of 0.8 and a medium effect size of 0.5. My one sample t-test, I needed 27 participants, and for multiple regression, I needed 49 participants. My inclusion were simple, that the participant needed to be able to comprehend, write, and read English, and they're actively employed in the specified healthcare settings, and they have at least 1 year of clinical experience, and they are willing to participate entirely in the intervention. My access and recruitment, I was able to obtain a university institutional IRB approval and hospital IRB approval, and also I obtained hospital administrators approval, and I posted flyers to let the nurses know about the incoming educational intervention, and I was able to obtain a permission to use an in-house email to all nurses with a cover letter attached to my email. Ethical consideration, I had an assistant, a researcher assistant, and so my assistant had to sign a third-party confidential agreement, and I also gave an orientation, and the cover letters that we gave to participants indicated that protected their human subject rights, like completion of the survey implies your consent, and anonymity will be protected, and your participation is voluntarily, and you can withdraw at any time without any questioning or penalty. So my intervention called cultural competency problem solving, which is in a video format. So it's a didactic lecture format. There was no skills, hand-on skills, so I did not target the psychomotor learning domain. I developed a demographic tool to obtain the demographic variables and composed of 11 questions. And I used Campina Pacodes instruments, the IAP CCR, which has 25 questions. Each questions had each construct had 5 questions. And the tool scored the participants' profession will be 91 to 100, competent from 75 to 90, aware from 51 to 74, and incompetent 25 to 50. And data storage will be securely electronically secured in a flash drive on an external hard drive, and all data will be destroyed after years by shredding of data collection. So for data cleaning and analysis, all questionnaires were examined for full completion. Any questionnaires that were more than 30% missing data, that had more than 30% missing data, were automatically disqualified from participating. All completed data were entered into SPSS. And for data cleaning, a frequency distribution using a box plot was performed. And then we ran a descriptive and inferential statistics on both the answers. So the frequency distributions of demographic data for birthplace, I had a sample of 44 participants. Found that the majority of participants were born actually in the United States with 52.3, and 47.4 were born outside of the United States. A majority specifies that English was their primary language at 72%, and the majority specified that English was their preferred language that they would like to use. Frequency distribution of demographic data for level of education and any previous cultural training, gender, employment status, and race. So the majority of the participants, 63.6% had a bachelor degree, 20% had a associate degree, 13% had master, and I had one participant who had a doctorate degree in nursing. The majority, 56.8%, indicated that did actually receive a cultural training previously. The gender, 84.1% were female compared to 15.9% were male. So that a mirror reflection of the current demographic in the nursing workforce in the US. And the majority were, all of the participants were full-times. And the racial breakdown was 38.6% were whites, 25% were Asians, and 22.7% were Blacks, and 9.1% Hispanics. Now, looking at the mean and the standard deviation for the age and experience, the average age was 39.55 years with a standard deviation of 10.4 and a range from 23 to 63 in age. Their experience, an average of 9.24 of nursing experience with a standard deviation of 7.08, and the average in the experience from the early novice of 1 to the expert of 32 years. Now, my pre-testing, when we ran the tool before the intervention, amazingly, 73%, this is a self-reported survey, but 73% thought that they are culturally aware, 25% thought they are competent, and 2% thought that they are proficient. None of them indicated that they are culturally incompetent, though. So data was explored for reliability. I needed to reverse code some of the questionnaires to reflect the true value, and then all the pre-testing and post-testing questionnaire were combined, and I using Cronbach Alpha to test for reliability. So looking at the constructs of Campina-Bakuri theoretical framework, I found that the cultural awareness had a Cronbach Alpha of 0.088, so was significantly unreliable. Cultural knowledge, initially using 5 questionnaire, had 0.665, so I had like a medium reliability. But by eliminating one of the questions that had like a negative connotation, the reliability improved to 0.861. Cultural desire had a 0.814, and total cultural competence was 0.799, so was reliable. My hypothesis testing, my first hypothesis was that direct care nurses' average cultural awareness gain scores as measured by the IAPCCR are greater than 0. So any improvement of more than 0 indicate a statistical significance. So the awareness, unfortunately, was unreliable with a Cronbach of 0.088, and hence I could not use this for hypothesis testing, this construct. My second hypothesis, direct care nurses' average cultural knowledge gain scores as measured by the instrument are greater than 0. And using a one sample, a one-tail test was conducted on the revised cultural knowledge to evaluate whether the mean was significantly greater than 0, and the sample mean knowledge gain score had a mean of 0.049 greater than 0, and the t-value was 4.96, a large t-value, and my p-level was less than 0.001, very statistically significant. My effect size was a large effect size using Cohen's D of 0.75. So this research hypothesis was accepted and the null was rejected. My third hypothesis, which is direct care nurses' average cultural desire gain scores as measured by the IAPCCR are greater than 0. Again, using a one sample or one TLT test was conducted on the desire gain scores to evaluate whether the mean was greater than 0. And the sample mean was 0.16 greater than 0 with a standard deviation of 0.37 and a t-value of 2.94. My p-level was 0.003, so was statistically significant, and the effect size was a medium effect size. So the research hypothesis for the cultural desire was actually accepted, and the null hypothesis was rejected. My fourth research questions. Direct care nurses average total cultural competence gain scores as measured by the IAPCCR greater than 0. Again, a one sample, one TLT test was conducted on the revised total cultural gain scores, and we found that the mean was 0.31 greater than 0, and the t-value of 5.01. My p-level was less than 0.001, very statistically significant, and a Cohen's d of 0.76, indicating a large effect size. So the research hypothesis for this question was accepted and the null was rejected. Now, my last research question that focused on demographics, that participant cultural competence gain scores are significantly predicted by age, gender, ethnicity, birthplace, previous exposure to cultural competence, training, level of education, and years of experience. The linear combination predictor for this research question was not statistically significant. Had an F value of 0.59, larger than alpha level of 0.005, and my P level was high. And my coefficient of determination was R square of 0.1. So tell me only 11% of the variance in the cultural competence can be explained by differences in the independent variable. Unfortunately, this hypothesis was not used, so we failed to reject the null hypothesis. The sample multiple regression coefficient was very weak of 0.33. So the significance of this research to nursing in general, the current demographics in the US still shows a substantial racial shift. Yet there are paradoxical inequalities in achieving health and accessing healthcare. This study sought to contribute to the body of nursing knowledge by evaluating the change of cultural competence among frontline nurses using a didactic transcultural educational offering. And the findings of this study have vital implication in nursing education, nursing practice, nursing research, and health and public policies. So implications for nursing education, nurses typically gain cultural knowledge, desire, and overall cultural competence using a didactic teaching pedagogies. Nursing educators can embrace such intervention into their core curriculum. And a good demonstration of fostering cultural competence is to really holistically target the 3 learning domains: cognitive, affective, and psychomotor. Leaders of nursing schools are encouraged to develop and implement strategies to recruit and retain minority nurses students. In practice, educating nurses on culture has shown to boost their cultural knowledge, desire, and overall total cultural competence. Educating nurses in cultural burial faced by racial minority groups might improve their cultural sensitivities. And nurses collectively need to advocate with their healthcare organization locally or globally for support and funding of initiatives intended to enable them to deliver culturally congruent nursing care. In nursing research, there is still a need to include frontline nurses in the body of transcultural nursing inquiries. There's a need to explore other dimensions of cultural competence, including the 3 learning domains. The study could not correlate demographic variables for participants, so this opens the door for further research using meta-analysis approaches. In health and public policy, the implications were that policymakers must include initiatives in their agenda to guarantee that frontline nurses have access to culturally relevant education. Such initiatives might have positive consequences on reducing health disparities among racial groups. Policymakers must also implement strategies to recruit, train, and retain racial minorities in nursing and in healthcare and other healthcare professions. So the strengths of this study did improve nurses' cultural knowledge, desire, and total cultural competence. There were significant crucial implications to be attentive to the benefits of such offerings to bedside nurses. The demographic makeup of the sample was similar to the parent population, so results are cautiously generalizable, and the instrument that was used had a high reported validity, and reliability. And my limitation of the study, I had limitation on my external validity, and that's due to sampling, lack of randomization, using a small sample, using a homogeneous sample, and lack of control. Also, my methodological approach using a cross-sectional versus longitudinal method, and using self-reported survey questionnaires, which has inherent biases in these tools, and inability to utilize participant demographic variables in my last research questions, and inability to investigate other constructs of Campina's Cody's theoretical framework. So my recommendations for future study using a longitudinal approach and to look at the effect of such intervention, maybe at like 3 months, 6 months, and in 1 year, using a mixed method approaches, using a meta-analysis and meta-regression studies, and replicate the studies in different regions of the United States using a larger and more heterogeneous sample. This concludes my presentation for today.
Yes. Yes, sir. This was the presentation from Dr. Nishant. Any questions to Dr. Nishant? Any questions? If you have any questions, you can text in chat box. We'll be asking behalf of you, even after the completion of the conference. Yes, sir. You can read from chat box from Dr. Catherine. Thank you for your presentation on the cultural competence in nursing. This is an essential topic in nursing and in challenging our healthcare program to incorporate cultural competence in all touch points of the education. Yes. Thank you very much, sir, for
Thank you.
Yes, for joining as keynote speaker for this conference. Since last 2 years, you are joining our organization as a eminent speaker for this virtual nursing education. Thank you for message for Frontlines COVID-19. Our committee is better because of your part of it. We really appreciate everything you have done. It was a great presentation. Looking forward to meet again next time.
Appreciate it. Thanks.
Yes. Thank you very much, sir. Have a nice day. Next, we ask Dr. Frida Nordebo Nirab from UCL University College from Denmark. The topic will be developing.
Thank you.
Yes, the topic will be the developing sexuality of childhood.
Thank you for inviting me, and welcome to this presentation about children's sexual development. I've had an interest in children's sexuality for many years. In fact, since I was in my 20s, working in a prison for 10 years. I hope that the theme will be of great interest to nurses, doctors, and others who meet children in their work. Already, when working in the prison, I got the idea that the way we encountered children's sexuality has an impact on their sexuality as adults. I met several inmates who could not handle their sexuality in one way or another, and I heard their stories about childhood experiences. At this point, it was mostly limited to very poorly functioning families, but in recent decades, things have changed, and today the majority of people in Denmark are on the left side of this illustration. Later on, I became an associate professor at the Faculty of Education and Social Science, And here the students reported more and more examples of children being distracted, prevented, or scolded when they tried to find space for play with sexual content. For example, as here, it's from an observation report in a nursery. It was told that the educator stopped the swing when a boy laughing told that it was tickling in his penis. The boy was told not to say such. I would like to point out here the difference between sexuality of children and adults. Children just have the physical part of sexuality. For example, they may feel that it's nice to touch their genitals. And some are also able to stimulate themselves to orgasm from a very early age. But children do not have the superstructure in the form of an emotional layer, which means that adults can be sexually aroused only by the power of thought. As such reports and stories grew in number, I wanted to gain more knowledge and had some help to design 2 studies as described here, which were carried out with the help from the students. The first study, each student in an entire year group had to examine and call a random nursery in Denmark. We had several results, most of all that 141 out of 159 institutions in one way or another had a practice of distraction or prohibition. Some institutions were quite firm and told parents of children involved will be contacted and informed. Our policy is very strict. The children are bluntly told that they mustn't. Such a statement agrees well enough with the fact that in other contexts, I also hear about parents who feel embarrassed about their child's behavior in relation to sexuality. Now we knew that there was a widespread practice of discrediting children's sexuality. But does it matter? To find out, we had the second study. With the second study, we had no statistically significant correlation between the way we encountered children's play with sexual content and their sexuality as adults. But we had some other results. Data pointed in the direction of development of depression and lack of social sexual skills. It also said that women in particular seemed to be affected. Most of all, we had this result. Data pointed in the direction that a lack of recognition of childhood sexuality might have consequences in the form of sexual problems later in life. Yes, what does it mean when children are interrupted, scolded, or even in one way or another punished? One male student gave a good picture of what he thought it had done to him that his parents had interrupted and scolded him when they found him trying masturbating. He described that he since that felt tormented by unpleasant feelings if he tried to masturbate, and that he today have problems with sexual intercourse. I was really surprised at how far-reaching he described his sexual problems. He described that he withdrew from social life as he felt it's too difficult to participate in what he named boy talk. as the subject often is about girls, boyfriends, and sex. I have noticed that he is pretty much always in groups with women on the education projects, and I see him as a pleasant, well-liked, and popular guy. But yet he described himself with tendencies to depression, stress, and unwillingness to ordinary things in life. He feels it's all due to a lack of acceptance of the sexual curiosity in his childhood. Something similar I experienced among the inmates in the prison, but most of them also had a lot of other stories about care failure. It was also surprising to me that many of the women had problems achieving orgasm, and even more surprising that some of them were able to orgasm alone, were able to orgasm when together with a boyfriend, but not alone. Through interviews, I found out that the world is bigger than what I experienced in my childhood. In my understanding, you first gain familiarity with your own body and sexuality, and later on, you enjoy it with a partner. But during my interviews with the students, some explained that they felt completely wrong about stimulating themselves, and some had never done it. Some of them even used terms like disgusting. But together with a partner, they were able to have an orgasm if the partner did the stimulation. At the same time, several told me that they wanted to be able to. Now we had a knowledge that our culture strongly disapproves children's sexual development, and a greater suspicion that it affects the adult's sexuality when we disapprove children's play with sexual content. In addition to the knowledge I had gained from the two studies, I also did literature searches. In my literature search, I found different perspectives that all support the idea that children should be met with an open and appreciative approach to their sexual activities. I have written about it in different papers. The one in top is a peer-reviewed and scientific-based article in Danish, and another one in German. In English, a children's book will be published shortly in October. You can pre-order it at the publisher. In this book, there's a postscript that briefly describes children's sexual development. But I promise I'll have some more in-depth descriptions published in English before long. Now and here, I want to elaborate on the neurological perspective. It's about the brain and its development in relation to sexual development. I'll talk about how sexual development is closely linked to the experiences the child encounters, and how these experiences integrate with the innate sensory-based sexuality, or you could say experiences. Sensory-based experiences refer to the fact that the child, for example, may feel that it's nice to touch the genitals. It must be linked to the emotions that arise in interaction with the environment. For example, if the child is recognized or if the child is scolded. Now, I'll try to explain what happens in the nervous system when the two types of input are connected. Now, I don't know if you know a lot about this, but I'll at least try briefly to tell what neurological development is. The nervous system is experience expectant. The nervous system needs stimulation. For example, a lack of stimulation with light and sounds can have fatal consequences for vision and hearing. But how is it that the brain can store past experiences? We know a lot about it through MRI scans, photograph. For example, you can search for the active areas of the brain coupled with specific experiences, which areas are active, for example, if we are afraid or if we do mathematics. The brain stores experiences through the principle of myelination of the nerve fibers that are used, which means that electrical impulses can run quickly. Areas that are myelinated are easy to use. For example, if we practice and become good at playing the piano, then it becomes automated actions, and the areas involved are well myelinated. Just to illustrate how the nervous system develops, you can see how the fear regulation system can grow due to myelination. And here, because a child have been neglected, often feels nervous and therefore often use this area to check if something is dangerous. The child's behavior, which here is due to lack of security, shapes the brain. I said earlier, a lack of stimulation with light and sounds can have fatal consequences for vision and hearing. And we also know that certain stimulation of patterned light and complex sounds have to take place during the first month of life. You call it sensitive periods. Where there are sensitive periods in relation to sexual development, I can't give a clear answer, but we know a lot about early emotional development. And we know that physical sexuality of the child must be integrated with an emotional layer. In terms of emotional development, children use the impression they get from their surroundings to navigate the world. The child asks in a way if a specific activity is dangerous. For example, if the parents show insecurity during the thunderstorm, the child will also easily experience insecurity during thunderstorms. Feelings and understandings are passed on from one generation to the next. And it's not only mom and dad, it's also the educators and the doctors, and nurses, everybody who have a relationship with the child. Some theorists call the attitudes that we pass on for dispositions. They influence our reaction tendencies and applies also to what we experience with sexual content. At least in some cases, we give our children ideas and deep-rooted understandings that we pass on to them largely without noticing it. Some dispositions are helpful, others are destructive. We know that dispositions like children should not touch their genitals. We know it's a destructive disposition. Occasionally, I get contacted by adults who ask what to put up in relation to their child's sexual behavior. Daycare centers do not want this type of behavior, and parents feel frustrated, and some express that they are embarrassed about their child's behavior. Maybe it's the same for nurses, that they don't know how to handle it when a child displays joy when touching its genitals. When changing diapers on the child will often show pleasure in touching own genitals. A study has shown that when mothers change their child, most of them look away, or we distract the child, or we rush to give a diaper on if the child touches its genitals. The picture here is from a children's book that I wrote, Elba's Little ABC for Sex Education. The girl, who have turned around and pulled up her dress, asks her dad, "Dad, won't you rub my vulva? I think that would be lovely." Using such a picture and the conversation between the girl and her dad, I hope to be able to give the adults who is reading the book for their children a good opportunity to consider their dispositions and how to respond to the child. To summarize, through experiences with sexual content in childhood, the child's physical-based sexuality changes in the adult's sexuality, to the adult's sexuality, which is characterized by an emotional layer. This means that the adult can be sexually aroused only by the power of thought. Historical and culturally, we have a situation where almost all of us are characterized by disposition which say that children should not be sexually active. I think the situation is worrying as we handicap our children, especially our girls, as boys, due to the physique, more easily get to know their genitals. They can easily touch and study their genitals. And in addition, it is also culturally more accepted than if girls study their vulva. About 100 years ago, Freud pointed out the connection he believed he could trace between reactions to childhood sexual experiences and the later adult sexuality and mental illnesses such as neurosis. Experiences do not just come by, they leave neurological traces. We must carefully consider what dispositions we want to pass on to our children. We have so much knowledge, so we ought to do better, and we have to talk about it. Thank you so very much for listening. Take care of yourself and our children. They are entitled to a good upbringing. But if I have the time, I would like to have a little extra number. I have 2 slides more. Is it okay?
Yes, you can go ahead.
Okay, fine. I ask how early and how do arousal patterns emerge? And how do we develop a sexual desire aimed at, for example, certain types of people? And we know that experiences organize and shape the nervous system, especially by repetitions. But recent research says that single experiences with marked emotional content also shape the nervous system. So we have to remember this. And here I have my notes. And I have the book you can pre-order at NIFA Books, the publisher.
Yes. Yes, any questions? Any questions to Dr. Frida? The topic of developing sexuality of childhood.
I'm not able to see the chat. Maybe there's somebody there.
No, it's your slide, madam. It's your PPT on the screen.
Okay.
It's your PPT. Yes.
So I say thank you for having me. Hope you enjoy the rest of the time here.
Yes.
Thank you.
Thank you for the presentation from Dr. Catherine. Yes, thank you so much, madam, for joining as a speaker for this event. It's a unique topic that you have delivered now. Thanks for you and sharing your tips with us. Looking forward to meet again next time. Next, we ask Dr. Muhammad Shaban from Health Point Hospital from UAE. The title of the talk will be Emotional Intelligence. Yes, sir, you can go ahead.
Okay, Bismillah ar-Rahman ar-Rahim. Good morning or good evening or good afternoon, wherever that you are hearing me. My name is Muhammad and I will be sharing with you today the presentation of emotional intelligence. We do believe, ladies and gentlemen, that emotional, it is something that everyone in the humanity, they have it, regardless if it is above level or lower level. But finally, it is a common shared things in the humanity. Regarding the intelligent, we know that this is like we born with this kind of this intelligent, and it is like can be slightly up, but it is not that much, but usually it is fixed. What it is emotional intelligence, something that it is coming with a modern knowledge. It is more socially than the other things. But can you believe this, guys? More socially, how much the impact that it can be having in our field if we are using properly. This is what we will see right now. Can everyone see my presentation? Can you see it?
Yes, sir. Yes, sir.
Yeah. Okay. So we're starting with emotional intelligence. I will just. Okay. Good. So everything have an objective. So we objective to identify emotional intelligence, know the difference between emotional intelligence and emotional competent, and learn how to use assertive communication to express your need and feeling appropriately. For sure, one of the important things right now, I will share it with you, ladies and gentlemen. It is about how we will using this one during the pandemic. So like, I believe this is one of the most required right now, because I do believe that during the pandemic, or many people, they have emotional running high, particularly whenever that they will see the cases, whenever that they will get a positive, or somebody like a relative or close to them that they got positive. So definition of the intellectual intelligence, the ability of understanding you, the need and the feeling of the onset and other people, managing their own feeling, responding to the other in an appropriate way, the capacity for the recognition of your own feeling and those of the others, for motivation ourselves and the managing emotional well in ourselves and in the other relations. So emotional intelligent and emotional quotient. So the emotional intelligent, also called an EI, and often measured as the emotional intelligent quotient. So describe an ability, capacity, and or the skills assess and the managing the emotional of own self, of others, and of groups. A form of social intelligence that involve in the ability to monitor one on of the other's feelings and emotions, to discriminate among them, and to use this information to guide one thinking and action. Now, why is emotional quotient? It is important. It is the pattern of how the people biasing and their thinking lead them to think or one thing or choice is a better than the others, and will adhere the clarity of this differentiating with this biasing and exercise clear and sound judgment. Now, we do thinking about what it is the emotional intelligent and the intelligent and the personality. It is a mix. So if we will use it properly, we can get the best form of the people, manners, behaviors, and the communication, I can say. So the intelligent quotient, there is intelligent quotient that no changes and stable over lifetime. I read 2 articles and they say it can be minor, like improving, but like it will be on the same level. So like if you are IQ like in the minimum or lower or like in moderate, you will be little bit improving based on the practice and based on the scenarios that you will have, but you will stay in this group. So the emotional, the other one, it is emotional intelligent, it is a flexible, able to change, and the personality doesn't change and stable over the lifetime. Now, let's see why it is important, why we believe this is an important. So you can see that 90% of the top performance have high emotional quotient. Now, I do believe that, guys, we can in our field we can see a lot of people. They are really smart. They are having a good ideas and they have like very skillful, but their communication and their emotional intelligence, they don't using this one in a proper way. Okay, while the others who have a high emotional intelligence, they are more appear than them. So why? Because they are using to making the people closer to them or magneting to them. Okay, and 58% of your job performance, also because I do believe as well that this one, it is controlled by the appraisal and the performance, and they save 29,000 people with a high emotional equivalent annually than their own low emotional quotient counterparts. So they can earn more than the others. So what is the advantage of strong emotional intelligence? Deeper personal relationship, greater adaptability, increasing personal insight, a greater influence over the others, fewer impulsive decisions, reducing stress, and improved social skills. Now, can anyone tell me how this one will be start? Like, what is the 4 important component? Actually, they are 4. If you know it, if you know at this one, like you have some ideas about the emotional intelligence, so like you can making my explanation for the following point, it is more easier. So do you have any ideas about them? Let's see there on the comments. Do you have anyone like have any ideas about the communication or like about the emotional quotient or emotional intelligent? Okay, now, so we can see, I can see right now that the component are the awareness of own emotions and the ability to expressing one's emotional appropriately, the capacity to channel emotional into the pursuit of the worthwhile objective, and this is the composition. So we have two important parts, the personal and the social. The personal, you can divide it by what I see and what I do. So at first, we need to self-aware. We need to have self-awareness about what we have. Are, for example, did I am encountering as a short-tempered person? Did I am considered as a like a funny person? Did I encounter to have a silly comments? Usually, do I have to be serious all of the time? I need to identify myself before anything. Then I need to self-manage myself. How I will self-manage? I need to know that this behaviors, it is acceptable for the community or the field where I am in or no. Or for example, like if there is a condolence or if there is any anyone, I will go to sharing like my empathy with her, like with somebody who have passed away, her father or mother or any relative, and I want to share my empathy with her. So like I will not go there smiling and laughing. This one, it is totally unaccepted. Even I am my personality is funny person, but I need also to control myself. I need to see this one, it is not acceptable in this time. So the social component, so the social awareness, I need to know what it is the others they love, what the other they think. You know, guys, this is like depending between each one personality and each group like direction. Some of them you need to be like having some humors. Some of them you need to be serious. We are many times we are directed by the atmosphere, so we cannot be all of the time as a comedy show on the work. So because this kindly finally this one not acceptable based on the field that we are working, and all of the time also I cannot be tough and rude because finally all of us we are professional. So you need to have a self-aware social awareness, and finally manage yourself and manage your relation based on the general atmosphere that you have. Okay, so we're starting with a self awareness. So the ability to accurate perceive your own emotion, stay aware of your emotion as keep them, so them happen, and keep on the top of how you tend to responding to specific situation of the people. So the Thomas Callier, the greatest of the fourth, it's to be conscious of none. Then how I will know? I need to know to see yourself for who you are and what's your own emotion, and track and backtrack your emotion in a difficult conversation or a meeting, for example. And this one, I believe many of us, whenever that we have a meeting or whenever that we having like chatting with the people that in different level in our career, you management, it is the ability to use awareness of your emotional to stay flexible and positively directed by your behavior, managing your emotional reaction to all situation and people. The third one, sorry. So like all of us, we know what the emotional red flag and breakdown, like angry, like door slamming, email letter bomb, and like withdraw and isolation, holding grudge and getting event, like all of us, we believe this one. So the social awareness, it is ability to accurately pick up on emotion in their own people, understand what it is really going on, and understand what it is other people thinking and feeling, even if they don't feel it is the same way. Then, so we back to the empathy part. So the empathy is the ability to see the world from the another's point of view and to identify and understanding another situation, feeling and motivates. So improving social awareness, spend extra time observing, asking and listening. And this is, I do believe with this one, we need to increase it regardless our age, regardless our educational level. We need to look and listen and try to capture and try to learn and try to having notes all of the time from those who you think that it is really can make a change. Maintaining eye contact, give a speaker your full attention, play back and summarize, try on their shoes, suspended on your judgment, read body language, and this one is important. And finally, relationship management, ability to use the awareness of your emotion and the emotions of the other to manage interaction successfully, ensure a clear communication and effective handling of the conflict. Now, so I will come back with you for the important slides. So what skills do employers want? Good communication, for sure, all of us, we need it because without a communication, and do believe guys, like how many times that we having those incidents because of there is no a proper communication. I do believe it is happening frequently. So proper communication, it is very important and crucial in our business. Resilience, have adapting and creative responsive to step back and the obstacles. Personal management, self-controlling and self-confidence, motivated and team player and conflict management. Now, what does the emotional intelligence to do with the employees? It is increasing their trust, making them more motivated people, changing them to be employees and a situation to adaptable and innovative. Teamwork, it will be enhancing their teamwork and execution. Individual are both focused on and accountable. Now, sign of high emotional intelligence. So handle the criticism without denial, blame, and excuses. Let's see what they are. Open-minded. Open-minded, I will listen. I will be able to having a new ideas. I will be able to accepting the changes. I will be able to see the things from the other's point of view. I will see the others in a new ideas, not in a one template all of their life. So I need to have an open mind. Another thing, I need to be a good listener, guys. You know, a good listener really will be solve a lot of our conflicts if we have really a good listening skills. Good listening skills, at least it will keep the others empty from any bad feeling or against things whenever that we are discussed. So like it will making the others like others and ourselves mind clearly. So don't sugarcoat of the trust and apologize when wrong. And this is, I do believe, this is the simplest thing, and this is what reflecting to be this person. He is a brave person. And sign of low IQ, EI. So like no self-awareness, no empathy, and obviously the own emotion and emotional of the others. So sign of them again. Have you heard about Paul in a China shop? Paul in a China shop. Do you have heard this one before? You know, if you put a Paul in a China shop, like it will be destroying everything. Like it will keep running. So like the Spanish one, like whenever this sport, the popular sport there. So like if you put this Paul in the China shop, it will destroy everything. So like if I don't have an emotional intelligence, well, I will be like this Paul and like destroying everything. So like they make it our friends, our relationship, our environment like a shiny shop, and our anger and like short temper and like wrong behaviors, they make it like a bull. Then lashes out. So like you find this person all of the time, he's trying to be absent and appearing or attacking person. He can be as well. Okay. Find others as to blame or most of the issues to their own or their team. And this is one of the things. Yes. Yes, all the slang in the US. I do agree. Okay. Do you know what find others are blamed for most of those issues or they're on their own team? Do you know what they call in the psychologist? If we come into the psychology way, did anyone hear of you about something they call a projection? Projection. I will write it there. So like have you heard about this one? This term, projection, self-projection. Do you know it? Okay. So the projection, it is whenever that you have like a problem, you try to throw it on the others. For example, if you are always late on the meetings, okay, you will throw this one on the other responsibility. You are the one always late in the meeting. You are the one who is like delay all of our agenda. You are even this one, it is in you, but you try to throw it on the others. If, for example, you are having a jealous, okay, you are always say that your friend they have a jealous. For that reason, we are not a progress. Okay, for example, you are hating. Okay, you will throw the failed of the team and because they are hate you. So this is kind of projection to the throwing what it is inside me on the others. So I will be clear from any responsibility or I will be clear from any blaming. Okay. And okay, the dangers of a nice personality doesn't mean that emotional intelligence to be like this, like nice personality. We say that you need to understand the community, but not always to be a nice. So have you ever met a nice person, but this pills have gone off? So charisma draws into the pull, not always in desire, and empathy can be faked, so can other emotions. Okay, and again, guys, like we say the important thing, be yourself. You need to be yourself. This is an important thing. You need to be yourself. You need to be the one that whenever that you are go having the same confidence, but like try to accepting and understanding the community around you. Okay, some gender difference, male and female, more willing to compromise social connected for the independence, for the gentleman, not as good as a woman in this, less adapt than women's overall, more psychological, overwhelmed by marital conflict. While for the ladies, greater needs for connectedness and have a wider range of emotion, better at reading emotions, better at developing social strategies overall, perhaps more engaged in a marital conflict. So 9 strategies for promoting emotions, taking the time for mindful, recognize and naming emotion, understanding the causes of feeling, differentiate between the emotions and to need to take an action, okay, preventing depressive through learning optimism, managing anger through learned behavior and distraction technique, listen for the lessons of feelings, using gut feelings in a decision making, developing listening skill. Okay, so can emotional quotient increase? Yes, can be increased with the practice. Your brain is a hardwired, so to give the emotions to upper hand, and I will say for you how to skills to increase. So they are 5: rapidly reducing stress, emotional awareness, non-verbal communication, use a humor to play a deal with challenges, and resolve conflict positively. Now, we are still on the pandemic. Okay, thanks God, the cases number it is less, but we still with the pandemic. Okay, so we need to see how this emotional intelligence working through in the pandemic. So why during pandemic, the coronavirus pandemic, it is proving that the greatest test of the emotional intelligence, it is a generation. As the axiom goes, when the time of the performance has come, the time of preparation has passed. Okay, so we will see right now from perspective of the employees, how they are evaluating their leaders. So 74% of the employees want their manager to demonstrate a leadership style focused on their empathy and supportive attitude, while 70%, another group, they found that 70% of workers say feelings that they have is right, support available and for the mental well-being, and for 54 in the other group find the manager needs supportive in navigating these new expectations. Now, working flexibility, they found that the people before they having less flexibility than coronavirus time. During the pandemic, more flexibility to working from home, to working even abroad. We hear a lot of people, they have been stuck in their country while the pandemic was started. Okay, so they having more flexibility, and the working still going on. They keep on the meeting, daily meeting, and like emails and chatting, WhatsApp, many channels, okay, to keep the working flow going on. Okay, now for the educators, what they can do, they can lead by example. They can educate nursing manager and the staff nurse about the emotional intelligence and this to the tool or that they can use. And this is one of the important things that I did during the pandemic. I keep behind the director of nursing and the other group during this time, and we have been going very smoothly with our nurses because many of them, they feel tired, exhausted, and emotional high. So like we control this one, thanks to God, and develop the list of with the stuff that of clinical leadership characterized to the that they would like to focus on the building of the others. Okay, and this is we selected a few nurses who have been like really doing a great job during the pandemic, encouraging the staff to remain aware of their emotional well-being. Okay, 5 tips for the leaders during the pandemic: balance your thinking and feeling brain. Okay, we need to having as much as we can supporting the other team, plus we need also to supporting ourselves and be mindful also for the environment and the needs of the work, and creating a psychological safety. And this one, what it is different between something they call psychological danger and psychological safety. And welcome dissent, it is how we need to have the diversity, and like how we can building the constructive between construction on our behavior, on our team building with in the daily living practice in our work field. And stop ridicule, no ridicule, like ladies and gentlemen. Why? Because this one can breaking the personality, breaking the relationship. As I mentioned earlier, during the pandemic, it is at all abnormal situation. So like we need to having this one. If silly mistakes happening, we don't need to having all of the time have a silly comments about those things. Let it pass. Let's focus on the things. All of us are human and all of us make mistakes. So we need to focus on something better than ridiculous. And we need to be nice and accept a mistake. As I mentioned earlier, like every day it is a chance for us to learn. We keep learning from now until like the end. And the one who will say that I know everything, make sure that he don't know anything that it is required to be a leader. Any questions, please? Thank you so much. And this is my speech.
Yes, sir. Any questions? So you can read from chat box from Dr. Catherine. This is a profound topic, especially during this unsettled time in the world. We do need to keep working on this. So are you audible my voice? Hello.
Hello?
Yes, sir. You can read the comments from chat box.
Yes, sir. This profound topic, especially during this unsettled time, is the war. We do need to keep working on this. Thank you. Yeah, I do agree with you, Catherine. Catherine, this is one of the important things, and I believe that any managers or any leaders or any director of nursing or anyone who have like a position, he need to think this one. He need to discuss with the other managers to maintain this one. And Catherine, to supporting what you say, during the pandemic, we see a lot of the good things. Like we see how the people they are acting with each other. Like there is some gathering, there is some gifts distributed. We highlighted the frontliners, heroes. We are always talking with them about what the good thing they did. So I do believe, from my perspective, that these things have been highlighted in a good way. Okay, and we cannot deny the greatest effort that the others they did during this, and which it is great. Really, it's great. We can't. From my side, I will give you an example. I did this one with the like we distributed more thankful letter, okay, appreciation letter. We sent this one during the morning time or the regular hours, and night shift and weekends. Okay, from my side, I have nursing newsletter. I share it with the group and and highlighted this one with the executive team, with the management executive team. And thanks to God, they have been received an appreciation letter and awards from them. We keep it our door open all the time for whoever want having to sharing their emotion. And some of them, by the way, they come to us. Like I do believe 4 or 5 of them, they have either like a personal things, or either they have like someone having like her husband, he have a corona, he was intubated, so we consider this one, we are supportive here in the much that it is like financially and like emotionally and like even adjusting her duty rota. And the others also, like the high risk people who like we send them to be like away, or to be like on telemedicine, or to be on the working from home. So those things, I do believe that we much working on that as a team. So like as a team, I do believe, alhamdulillah, that all of the work have been going smoothly, and this one have been working in a good way and a good manner for everyone. Yeah.
Yes, sir. Any further questions? Any further questions to Dr.
But again, some people we need to understand that doesn't mean that I have emotional intelligence to be a lenient. Keep in your mind, it doesn't mean to be a lenient. Like I need to show a supportive kindness, love, respect, and like teamwork. But at the same time, the patient, it is our priority. The work field and the smoothness and the work must be continue, okay, and without any biasing. And this is what I do believe the meaning of experience here. It is playing this significant role that I will using not my judgment, I will using my critical thinking, my emotional intelligence to adapt this with the current circumstances.
Yes. Yes. Thank you very much, sir.
Thank you so much. It is my pleasure to meet all of you. Thank you so much for this great conversation. I do believe, alhamdulillah, that inshallah our nursing education, it is going higher and higher all of the world, not only the working people who's working in the hospital. All of the world right now identify the significant role of the nursing education, not only for hospital, for all of the world, to having really facing strongly and successfully by the God's grace of this pandemic.
Yes, sir.
Thank you so much.
We would like to inform to all the participants, Dr. Shaban is joining our scientific event since last 2 years. Yes, thank you very much, sir, for sharing your tips with us. Looking forward to meet again next time.
Inshallah. Thank you so much, and like we have inshallah next time.
Yes, definitely, sir. Have a nice day, sir. Bye.
Thank you.
Yes. Next, we ask Dr. Giuseppina Seppini from Forensic Analyst. Yes, Guruji, Director of Fiumenti Regional Office of the Forum Flex Association from Italy. The topic of the title will be Prisoners in their own home, violence against women during COVID-19 pandemic lockdown.
Hello, thank you so much. I'm going to share my screen, but there is also the screen of the doctor for the last presentation.
I will stop my sharing.
Thank you so much.
Thank you.
Yes, sir.
Okay. Can you see my screen?
Yes, sir. It's going to start, ma'am.
Okay. Okay. Thank you so much. Here, I hear some noise. Okay, perfect. Okay, can you hear me?
Yes, we can hear your voice.
Okay. Okay. Thank you so much. Thank you so much to organizer. Good morning, good afternoon, good evening, everyone. I'm going to talk to you about a particular problem that is all the time. I'm talking about a particular problem. I'm talking about violence against women and girls. But what's about violence against women and girls? What does it mean? Well,
excuse me, madam. We are unable to see your PPT on the screen. It's not yet started opening.
Okay. You don't see my screen?
Yes, it's okay. It's fine.
Okay. Okay.
It's fine.
Perfect. Okay. Yes. What does it mean? What's about violence against women and girls? Well, World Health Organization and United Nations gave a definition. Intimate partner violence. World Health Organization define intimate partner violence as a behavior by intimate partner that causes by a women physical, sexual, or psychological harm, and United Nations define gender-based violence, any act that results in physical, sexual, or mental harm, including threats of such acts, coercion, or deprivation of liberty, either occurring in public life and also in private life. But an important thing is that in 2018 analysis of prevalence data from 2000 and 2018 across 161 countries about violence against women and girls, conducted by World Health Organization together United Nations, found that about 30% of women have been subjected to violence by intimate partner and also non-intimate partner. But another important thing is that a quarter of women from 15 to 49 years who have been in relation have been subjected to a physical or sexual violence. Another important thing is that in the last year, the 38% of the murders of women were committed by intimate partners. But what happened in 2020? Well, in 2020, sometimes we know what happened. Happened something that profoundly marked lives, we know, and sometimes happened until now we had only imagined in a film, and instead it happened in real life. A pandemic has revolutionized the existence of people in all the world, in entire planet, and after virus isolation, life change ever. What happened? Some steps. On January, World Health Organization declares a state of global emergency. On February, the name of the new disease caused by the coronavirus, the names chosen by the World Health Organization is COVID-19. On March, declared the pandemic. Some measures to safeguard the population begins. Well, the measures put in place to contain the dissemination of coronavirus in fact increase the experience of violence for women. In accordance with the report of the United Nations, lockdowns during the COVID-19 pandemic increased of the women to abusive partners, and the situation of the humanitarian crisis and displacement may exacerbate violence, such as by intimate partners and also non-partner violence. In accordance also with the report, but also with the literature in this field, that violence against women and girls is increasing during COVID-19 pandemic. During the pandemic and its social and economic impact have increases the risk of violence. The measures to address the pandemic that affects livelihoods and also access to services increase the risk of and these measures these measures these measures the life of the women. House often becomes a place of abuse and of abuse much more than before. Why much more than before? Because the confinement increased the episodes of violence, because the domestic violence, the cycle of domestic violence has the particular structural elements. In fact, the partners, the perpetrators, a particular control strategy with women, with the victims. In fact, he wants always have a particular control by the women. Her with the family, with her friends, the lockdown, the quarantine, both necessary to reduce the spread of the pandemic, have in fact contribute to increasing the isolation of the victim, of the women, their difficulties in support and networks. The emergency obviously has amplified difficulties in women activating territorial services for the emergency of the need, difficulty in the in coordinating between specialized and general services, difficulty in finding hospital instructors, and also to which are added to the organizational and also difficulties of working remotely. But what is important? Well, it's important to provide many strategies, to develop many strategies to combat the phenomenon of violence against women. It becomes of utmost importance to guarantee the continuity of support services, for example, with new communication approach, social media, awareness campaigns, new ways of reporting violence, psychological support system, education programs, escape playing laws, regulation, and last but not least, new technology to support healthcare system. Forced confinement, cohabitation worsened pre-existing situation of violence, drastically, unfortunately, reducing the possibility for women to ask for help. It's so important to improve the new technology to support the victim to violence, women and girls too. Violence against women and girls remains a serious human rights violation and an important health concern during this pandemic, but not also. It was still remains a priority to be addressed, and it deals with a new, a different, new approach to be fight. It is so important that different professionals work together to fight together with address this problem. Thank you so much for your attention.
Any questions? Any questions to Dr. Josepina? Yes, madam. You can get a. You can see from chat box from Dr. Aisha. Wonderful presentation. You can see from compliments from chat box as well as questions from chat box.
Okay.
You can see.
Just a moment. Okay.
From chat box. See.
Okay.
Yes, thank you very much, madam, for joining as a speaker for this event. Thanks for sharing your tips with us on behalf of World Nursing Conference on virtually that was going to be held. Our committee members are happy. We want to thank you for this presentation.
Thank you so much.
Thank you so much for speaking up in this meeting and providing unique perspective. Thanks for sharing your tips with us. Looking forward to meet you again next time. Next, we ask Dr. Lena Rustova from School of Health Sciences from Seattle Pacific University from USA. The title of the talk will be Nightingale Exploring the Impact of Nurse and Nursing Students and Professors of Attending a Musical and Florence Nightingale.
A musical regarding life and passion of Miss Florence Nightingale. With the support of several nursing schools and organizations, the musical toured the studies exploring the impact of nurses, nursing students, and Greetings, everyone. This presentation report on the phenomenological studies exploring the impact of nurses, nursing students, and professors who view a performance called Nightingale, a musical regarding life and passion of Miss Florence Nightingale. With the support of several nursing schools and organizations, the musical toured the Seattle area in winter of 2020. Please allow us to introduce ourselves. My name is Dr. Lena Kristova. I'm a nursing professor at Seattle Pacific University. I teach an undergraduate and graduate nursing program, and I have passion for exploring different forms of art for personal well-being. I also serve on the board of directors for a nonprofit organization called HEARTS, Health Enriched by Arts.
And I am Dr. Connie Amundsen, a practicing chiropractor in Seattle and a doctoral student in the Department of Scandinavian Studies at the University of Washington, where my dissertation project explores representations of aging in Norwegian drama. I am particularly interested in theater as a tool for health promotion. I too serve on the board of directors of HEARTS.
To begin, Florence Nightingale was born 200 years ago. The World Health Organization declared the year of 2020-21 as the International Year of the Nurse and Midwife in celebration of Florence, her contribution to the field of nursing and nursing discipline. In defiance of the norms of Florence's upper-class background, she became a nurse and immediately demonstrated her leadership styles. During the Crimean War, she went to the front line to determine why many soldiers were dying. Through her pioneering use of medical statistics, she was able to uncover that the primary cause of death among soldiers was not their wounds themselves, but the infections resulting from unsanitary conditions. Nightingale is recognized as a founder of modern nursing, where the nurse functions as a leader, caregiver, and a patient advocate. Florence considered the future and she wrote, "What we have made of it, whether all these things are the same then as now, or worse or better, depends, of course, upon what we're doing now and upon what we're not doing now."
Nightingale the Musical was written and produced by local artist Pamela Gerke and received additional support from Hearts. The idea behind the production was to entertain, teach, and heal local communities, as well as to recognize and promote nurses and the nursing discipline. Unfortunately, the shutdown in response to the COVID-19 pandemic meant that the tour was cut in half.
There is a broad range of literature that suggests that artistic activities improve people's life and enhance health, quality of life, and function. For example, throughout gathering, music, and dance. Our goal was to explore and evaluate the impact of viewing Nightingale, the musical, on nurses, nursing students, and professors.
Using a phenomenological approach, our team conducted a qualitative study of nurses and nursing students and professors who had attended the musical. We conducted 10 interviews. In addition, we did a 10-question online demographic survey to which 38 attendees, a total of 161, responded.
All participants were volunteers from the audience, and they signed informed consent. The questionnaire of 15 talking points were developed by the authors of the studies. The interviews were conducted within 2 weeks of viewing the musical, and 4 teams emerged from the content analysis.
Before we move to the findings of the study, here is a brief summary of the demographics of our audiences, which corresponded with the typical Seattle area theater audience. The audience members' ages spanned from 18 to 66 and older, with most in the 46 to 65-year-old group. Gender broke down to 83% female, 14% male, and 3% non-binary. Most respondents placed themselves in either the middle class or upper middle class, and 12% were students. Most of our respondents had college degrees, ranging from a 2-year degree to the highest percentage having graduate degrees. The majority of respondents attended live theater or musicals quite frequently, with only 11% reporting almost never or never.
4 main themes emerged from our study. Theme number 1, reasons and influences for choosing nursing as a profession. Many participants shared thoughts on how they got into nursing. Family advice and influence, personal experience as a patient, job security, a desire to have meaningful work centered around caring and relationship. Theme number 2, managing the intensity of being a nurse. Participants shared thoughts on the intensity of the day-to-day reality of being a nurse, which included striving to be heard by other medical professionals in a team, realizing the power inherent in nurses' broader perspective when working as a team, coping with burnouts and heavy workloads. Theme number 3, nurses' role as leaders and advocates. Participants spoke about nurses' role as leaders and advocates in both individual and community issues, influencing the wider culture in achieving health equity and promoting a holistic approach for well-being, which goes beyond the individual to include the environment and social determinants of health. Theme number 4, gratitude, calling, and opportunity to serve. Participants shared thoughts on gratitude for the opportunity to serve, learn, and grow. Others spoke about nursing being a calling and a way to share the love of God. We're going to quote extensively from our interviews, thereby allowing nurses to have their own voices. During the musical, one participant shared that it reminded her about fulfilling our great purpose here on earth. Another participant shared, it just made me proud, I suppose. It reflects how I feel about my job. It is relevant because I went in my job to make a difference. And I think most nurses go into their job as a service. It is a way to make a difference. And I think this is what Nightingale showed. It just made me proud.
Consistent with the theme of managing the intensity of nursing, one participant shared how a nurse is seen by wounded soldiers. Having worked with veterans, I could relate to the things she was doing in the Crimean War. That person who comes and helps you is totally seen as the savior. I think the nursing professional takes a lot of that on, and I think it was originally signed up for, including cleaning beds and cleaning rooms and maintaining things. Yet, as this respondent pointed out, nurses feel obligated to rise to the occasion lest their primary concern, the well-being of the including cleaning beds and cleaning rooms and maintaining things. Yet, as this respondent pointed out, nurses feel obligated to rise to the occasion lest their primary concern, the well-being of the patient, is overlooked. When you're really new, you might not pick up on the changes that are happening to a patient to see the downward spiral, but you're going to learn quickly.
In alignment with the team nurses' role as leaders and advocates, learning more about Nightingale advocacy for patients gave one participant the opportunity to reflect on what it takes to speak up and what, in the end, motivates her to do her job. After seeing the musical, she reflected on why she stays in the direct patient care, choosing to be a patient advocate. She has turned down multiple offers to become nurse administrator, but she wondered whether by doing so, she had left Florence down. I want to stay at the bedside, she said. That's where my passion is. And I think to myself, would that be okay with Florence? Would she not? Greetings, everyone. This presentation report on the phenomenological studies exploring the impact of nurses, nursing students, and professors who view a performance called Nightingale, a musical regarding life and passion of Miss Florence Nightingale. With the support of several nursing schools and organizations, the musical toured the Seattle area in winter of 2020. Please allow us to introduce ourselves. My name is Dr. Lina Kristova. I'm a nursing professor at Seattle Pacific University. I teach an undergraduate and graduate nursing program, and I have passion for exploring different forms of art for personal well-being. I also serve on the board of directors for a nonprofit organization called HEARTS, Health Enriched by Arts.
And I am Dr. Connie Amundsen, a practicing chiropractor in Seattle and a doctoral student in the Department of Scandinavian Studies at the University of Washington, where my dissertation project explores representations of aging in Norwegian drama. I am particularly interested in theater as a tool for health promotion. I too serve on the board of directors of HEARTS.
To begin, Florence Nightingale was born 200 years ago. The World Health Organization declared the year of 2020-21 as the International Year of the Nurse and Midwife in celebration of Florence, her contribution to the field of nursing and nursing discipline. In defiance of the norms of Florence's upper-class background, she became a nurse and immediately demonstrated her leadership styles. During the Crimean War, she went to the front line to determine why many soldiers were dying. Through her pioneering use of medical statistics, she was able to uncover that the primary cause of death among soldiers was not their wounds themselves, but the infections resulting from unsanitary conditions. Nightingale is recognized as a founder of modern nursing, where the nurse functions as a leader, caregiver, and a patient advocate. Florence considered the future and she wrote, "What we have made of it, whether all these things are the same then as now, or worse or better, depends, of course, upon what we're doing now and upon what we're not doing now."
Nightingale the Musical was written and produced by local artist Pamela Gerke and received additional support from Hearts. The idea behind the production was to entertain, teach, and heal local communities, as well as to recognize and promote nurses and the nursing discipline. Unfortunately, the shutdown in response to the COVID-19 pandemic meant that the tour was cut in half.
There is a broad range of literature that suggests that artistic activities improve people's life and enhance health, quality of life, and function. For example, crowd gathering, music, and dance. Our goal was to explore and evaluate the impact of viewing Nightingale, the musical, on nurses, nursing students, and professors.
Using a phenomenological approach, our team conducted a qualitative study of nurses and nursing students and professors who had attended the musical. We conducted 10 interviews. In addition, we did a 10-question online demographic survey to which 38 attendees, a total of 161, responded.
All participants were volunteers from the audience, and they signed informed consent. The questionnaire of 15 talking points were developed by the authors of the studies. The interviews were conducted within 2 weeks of viewing the musical, and 4 teams emerged from the content analysis.
Before we move to the findings of the study, here is a brief summary of the demographics of our audiences, which corresponded with the typical Seattle area theater audience. The audience members' ages span from 18 to 66 and older, with most in the 46 to 65-year-old group. Gender broke down to 83% female, 14% male, and 3% non-binary. Most respondents placed themselves in either the middle class or upper middle class, and 12% were students. Most of our respondents had college degrees, ranging from a 2-year degree to the highest percentage having graduate degrees. The majority of respondents attended live theater or musicals quite frequently, with only 11% reporting almost never or never.
4 main themes emerged from our study. Theme number 1, reasons and influences for choosing nursing as a profession. Many participants shared thoughts on how they got into nursing. Family advice and influence, personal experience as a patient, job security, a desire to have meaningful work centered around caring and relationship. Theme number 2, managing the intensity of being a nurse. Participants shared thoughts on the intensity of the day-to-day reality of being a nurse, which included striving to be heard by other medical professionals in a team, realizing the power inherent in nurses' broader perspective when working as a team, coping with burnouts and heavy workloads. Theme number 3, nurses' role as leaders and advocates. Participants spoke about nurses' role as leaders and advocates in both individual and community issues, influencing the wider culture in achieving health equity and promoting a holistic approach for well-being, which goes beyond the individual to include the environment and social determinants of health. Team number 4, gratitude, calling, and opportunity to serve. Participants shared thoughts on gratitude for the opportunity to serve, learn, and grow. Others spoke about nursing being a calling and a way to share the love of God. We're going to quote extensively from our interviews, thereby allowing nurses to have their own voices. During the musical, one participant shared that it reminded her about fulfilling our great purpose here on earth. Another participant shared, it just made me proud, I suppose. It reflects how I feel about my job. It is relevant because I went in my job to make a difference. And I think most nurses go into their job as a service. It is a way to make a difference. And I think this is what Nightingale showed. It just made me proud.
Consistent with the theme of managing the intensity of nursing, one participant shared how a nurse is seen by wounded soldiers. Having worked with veterans, I could relate to the things she was doing in the Crimean War. That person who comes and helps you is totally seen as the savior. I think the nursing professional takes a lot of that on, and I think it was beautiful in the show. But it also caused a little snicker among the nurses who were actually in attendance. My former classmates and I all kind of just looked at each other and acknowledged, yeah, it's fun to think about the idea of the angel nurse, but at the end of the day, we were wiping butts and we were dealing with blood and snot and mucus and vomit. It's funny that society thinks that's what an angel is. Another response we often heard from nurses was about the tremendous amount of work that nurses are expected to do because they are in the nexus among other clinicians, family members, administrators, and of course the patient. For example, the nurse is the coordinator of care, and so they're communicating with doctors, physicians' assistants, nurse practitioners, unit secretaries, and then bosses and management and family members. Nurses are being asked to do so many more jobs than they originally signed up for, including cleaning beds and cleaning rooms and maintaining things. Yet, as this respondent pointed out, nurses feel obligated to rise to the occasion lest their primary concern, the well-being of the patient, is overlooked. When you're really new, you might not pick up on the changes that are happening to a patient to see the downward spiral, but you're going to learn quickly.
In alignment with the team nurses' role as leaders and advocates, learning more about Nightingale advocacy for patients gave one participant the opportunity to reflect on what it takes to speak up and what, in the end, motivates her to do her job. After seeing the musical, she reflected on why she stays in a direct patient care, choosing to be a patient advocate. She has turned down multiple offers to become nurse administrator, but she wondered whether by doing so, she had let Florence down. I want to stay at the bedside, she said. That's where my passion is. And I think to myself, would that be okay with Florence? Would she not have I let her down, but have I let myself down? Should I be going further? But I don't have the passion of doing anything else. I have the passion for being at the bedside. And I think that's what she did as well. What nursing has done to me is giving me my own voice, giving me my own path, and it's been amazing. Another participant shared that she reflected on healthcare and what would do if she had a magic wand. She viewed the future of needing a holistic approach and criticizing the current healthcare system. I would change the paradigm of healthcare for a profit to healthcare for human services, the service of humankind. And it's not just mankind, it's healing for the planet, for all of life, for humanity. And we all only a part of much greater picture. And this involves everything. It involves how we treat the earth.
Because the musical was presented at the very beginning of the pandemic, it caused one nurse to reflect on a recent experience. Seeing the musical kind of solidifies that when you have something to say in a meeting, you need to put your hand up and say something. I was actually in a meeting today and it was about coronavirus. And I said, so let's play devil's advocate. Say we've got somebody who is positive. What am I going to do with them then? Am I going to send them back to their dorm? Are they okay to go back to their apartment or their fraternity? What do we do? The others hadn't thought about that. They're not walking in the patient's shoes. And I think that that's what certainly Florence, watching the play, where she was clearly so torn up watching those soldiers and the way they were dying and the way they were being mistreated. And I think the day that you lose that as a nurse is the day you've got to get out of nursing.
Many participants share their journey in growth as leaders and people's advocates. Whether or not this nurse is aware of being part of the larger movement of using the creative arts as a tool for health promotion, she has allowed her own creativity to lead her on a path which honors her nursing background and takes it in a novel direction. I'm now moving to expressive arts, she said, which allow people the opportunity through arts, their own self-created art, to identify problems themselves and to find a way through themselves. I create a safe container now, but I do not have to actually give them the plan. They'll come up with their own plan out of the process of doing their own art and connecting with their own creative source.
Many things about medicine and nursing have changed over the years, but some aspects have stayed the same. Here is one example of how nurses reflected on that. It is the same story in a different time period, dealing with the status of medicine now versus the status of medicine in the 1800s, but we are still humans. We're still dealing with evolution. We're still dealing with the cry of humanity and the needs of humanity. And we are those people who come in response to that longing and that cry that we are able to hear, and we respond to it.
Another nurse wondered what Florence would do in her situation. Seeing the musical made me ask, what would Florence do? Because today, we're still fighting with the same fight. The hospital should not harm the sick, and we're still struggling with rationing and quality care, and even basic hand washing. I mean, there's so many things that we have changed, but the basic needs remain the same. So it was nice to have that reminder. What would Florence do?
Nightingale the musical made a huge impact on nurses and nursing students who watched the performance. Their comments were very revealing. One participant shared that it was a very healing experience for me. Another said, it felt empowering. A third reported that it felt nice to have this acknowledgement. And finally, nursing has given me my own voice.
Addressing the future implication, we concluded the following. Florence Nightingale remained a significant and influential figure in the history of nursing. Art forms can be used to promote the value of nursing. Art forms can be used to demonstrate appreciation to all nurses and healthcare providers. Art can be used as a form of healing to relieve the burden of the profession, thereby contributing to the well-being and sustainability of the healthcare workforce. To address the implication for nursing education, our limited study suggests a direction for future study to explore art as a pedagogical tool in nursing profession. Musical can be utilized as teaching and learning tool in a nursing curriculum. Different forms of arts can be used to inspire and recruit the new generation of nurses. In order to offer the benefits of seeing the musical to a wider audience, during the past year, a video version of the musical was created. Our intent is that we will provide free online access to this film version. In addition, A study guide with questions to drive meaningful discussions and reflections after viewing the musical being provided on the health website.
In conclusion, we would like to thank all the artists who brought Nightingale the musical together and out to the public to enjoy, learn, and reflect on. We would like to dedicate this presentation to the heroes of the COVID-19 pandemic, especially the nurses. Over the years, nurses have contributed to some of the world's most important public health achievements. Nurses have enlisted and pitched in during any and all major crises, including natural disasters and, for that matter, epidemics and pandemics. What is noticeable about nurses is their selflessness in their contributions and the care they give. And that selflessness is embodied in Florence Nightingale, the founder of modern nursing, whose life story remains relevant and inspiring for so many nurses and nursing students around the globe. And it needs to be told. Thank you.
And now we can take any questions that the audience may have for us.
Any questions?
I would like to point out, if anyone is interested in accessing the film version of the musical, which is free to anyone on YouTube, you may find the link at the Hearts website, which is heartshealtharts, all one word, .org. I'll say that again, heartshealtharts.org. So it's a beautiful, moving piece, and I just hope everyone has a chance to see it. We're so happy about that transition.
Yes, this was the link where I...
Oh, yeah, okay. Let's see, can I post? Chat? Where do I post? Maybe Lena, you can do that.
I can post that in the chat. In addition, also on the website, we have discussion questions that we created to supplement the conversation around Nightingale, the role of the nursing, the changes that are happening, the future of nursing, and how history influenced healthcare and nursing. So nursing educators, teachers, advocates for nursing can use this set of questions to drive discussions around the world. Thank you.
Yes, any questions? Yeah, any questions to Dr. Lenova as well as? Yes, thank you very much, madam, for joining as speaker for this event. Thanks for your sharing tips with us. I have shared your that video presentation to the audience. They can be seen through website also.
Thank you.
Yes, thank you very much for speaking up in this meeting and providing hero's perspective. Thanks for sharing tips with us. Looking forward.
Our pleasure. Thank you.
Yes. Yes. Next we ask. Next we'll go with Dr. Rachel Mahas from Wayne State University from USA. The topic will be assessment of guidelines adherence in PAP test screening in those aged 21 to 65, analysis of 2020 health information national trend survey.
Hi everyone, welcome to my presentation on assessment of guideline adherence to Pap test screening, analysis of the 2020 Health Information National Trend Survey. My name is Dr. Rachel Nahas and I am an assistant professor at Wayne State University as well as the MPH program director. The ACS estimates that around 13,000 women will be diagnosed with cervical cancer and approximately 4,000 women will die from the disease in 2021. The USPSTF, their national recommendations for a Pap test are every 3 years in a woman aged 21 through 65 years. An analysis of the behavioral risk factor surveillance system, 2000 through 2010 data showed that the incidence rate of cervical cancer was 18.6 per 100,000 women. Recent research has also found that Pap test screening in women aged 21 through 29 years drastically dropped from 62.8% in 2005 to 47.3% in 2016. Now, these staggering Pap test screening statistics are especially concerning to public health as the Healthy People 2030 CO9 objective targets an 84.3% cervical cancer screening rate. Data from this study were obtained from the 2020 National Cancer Institute's Health Information National Trends Survey. A total of 4 mailings were sent out as a part of Cycle 5, with data collection beginning in February of 2020 and concluded on June of 2020. Adult women who were 21 through 65 years of age were included in this analysis. Statistical analysis included bivariate correlations and stepwise multiple logistic regression. Through bivariate examination of the HINTS 5 Cycle 4, and with the consideration of health behavior theories, the following sections in the survey were included. Demographics, looking for health information, your healthcare, medical research, your overall health, cancer screening and awareness, and beliefs about cancer. Of the 3,890 individual respondents to the HINTS 5 Cycle 4, 1,521 women were included in the study. Results showed that 33% of U.S. women are not adhering to U.S. PSTF recommendations. In this bar chart, you can observe that the percent non-adherence versus adherence to USPSTF Pap test recommendations by race ethnicity. Consistent with other research, African Americans at 78.7% are meeting recommendations at a higher rate than non-Hispanic white individuals. And here we can see that Hispanic individuals are at the highest percentage of not meeting the USPSTF guidelines. By educational level, those who had 12 years or completed high school as well as didn't complete high school were around 37% did not meet USPSTF. Of the 1,521 women who were included in this study, correlates to adhering to USPSTF Pap test screening guidelines included having employer health insurance, better self-reported general health, having a higher self-efficacy, not being diagnosed with high blood pressure, indicated not being deaf or having serious hearing difficulties. Results from the stepwise multiple logistic regression are presented in this table, showing predictors of adherence to USPSTF recommendations. Individuals who had a regular healthcare provider were 1.3 times more likely to adhere to USPSTF Pap test screening guidelines. Those who heard about human papillomavirus were 2 times more likely to adhere to USPSTF Pap test screening guidelines. Trust in information about cancer from charities. Those individuals were around 1 time more likely to adhere to USPSTF Pap test screening guidelines. And those who were diagnosed with high blood pressure were about 1 time less likely to adhere to USPSTF Pap test screening guidelines. It's important to note that predictors can explain 10% of variance when predicting U.S. women's non-adherence or adherence to USPSTF Pap test screening recommendations. Findings from this study showed that individuals are not meeting Healthy People 2030 target of 84.3% cervical cancer screening rate. Additionally, health factors such as reading one's general health, having a regular healthcare provider, and having heard about HPV were significantly associated with adherence to Pap test screening guidelines. Those diagnosed with hypertension, this showed that they were significantly associated with non-adherence to Pap test screening guidelines. Based on this research, interventions on educating individuals about HPV should be increased. There should be further research on the exploration of trust in health information from charitable organizations on women's adherence to Pap test screening guidelines.
Yes, this was the presentation from Dr. Rachel Mehes from Ohio State University from USA. If you have any questions regarding this topic, just you can ask Dr. Rachel Mass will be sending after the completion of the conference. Any questions regarding this topic? Yes. Thank you very much, madam, for joining this event as a speaker for this conference. Thanks for sharing your tips with us. Looking forward to meet again next time. Next, we do have following talks, that is Dr. Yosra Mazina, Dr. Fatahimeh Rahim Khan, Dr. Sharahirin, Dr. Tracy, Dr. Gosa, Dr. Nevis, and the last speaker of the conference will be Dr. Aisha. If anybody of among these read the names, if you are anybody are ready with PPT, just you can start sharing your PPT and start presenting. If anybody among the hello, Dr. Sharaha Mohammadi, are you ready with your PPT so that you can go with presentation? You can go with your presentation.
Hello, I'm Sharada Zaygami Mohammadi. I'm start presentation.
Hello. Unmute చేయరామని ఆమెకు తెలియదు.
Hello.
Yes, madam. Just we have visible your PPT. You can start presenting.
Yes. Okay. In the name of God, greeting to participants and organizer in this conference. I'm Shara Zaygami Mohammadi from Iran. My presentation is about correlation between online learner readiness with psychological distress related to e-learning among nursing and midwifery students during COVID-19 pandemic. Following pandemic COVID-19, an important health strategy was to reduce social interaction and quarantine. Following the implementation of quarantine, the process of face-to-face training in university was found, and many universities, in a quick and sudden strategy, changed the face-to-face education to online or asynchronous learning approach. Staying at home and reduce social interaction for a long time, and sudden change to e-learning education was unusual experience and affected on students' mental health. The study showed that 83% of learners experienced poor e-learning conditions, and 26% do not have access to mental health support. The study of Hamaday showed that the prevalence of depression, anxiety, and stress in Jordanian students during quarantine period was 78.7%, 67.9%, and 48.7%. The most important reasons related to perception discrimination in providing learning opportunity, concern about academic status and fearing of academic losing, and concern about professional status and future education. Following the sudden change in face-to-face to e-learning, the students' readiness for e-learning has become an important challenge. The learner must have technical skills to work with computers, LMS, internet access, and digital literacy, self-directed learning, and actively involved in learning control and decision-making about speed process of directed learning and online learning motivation and positive attitude to e-learning. Online communication self-efficacy for ability communicate efficiently in discussed group, verbal and textual communication, able to use interactive tools in LMS such as chat, emojis, to interact, ask questions, and improve their learning. The result of a study of RAPID showed that the students were not completely successful in their online learning activity during COVID-19 pandemic. And a study showed that students' readiness for online learning was moderate, and students poor in learning control and self-efficacy in online communication. With sudden shift to e-learning during the COVID-19 pandemic, awareness of learning readiness for online learning and its impact on students' psychological distress is important for teachers, counselors, and educational planners. Therefore, this present study was conducted to investigate the correlation between readiness for online learning and psychological distress related to e-learning in nursing and midwifery students during the COVID-19 pandemic in 2021. This study was a descriptive correlational study conducted on 194 students and midwifery in nursing and midwifery students in Islamic Azad University in Karaj, Iran, in second semester of 2020 to 2021. Inclusion criteria was less one semester of online classroom experience, and students that are reluctant to participate in this study, lack of online class experience, An incomplete questionnaire filling excluded from this study. Sample selection was continuous sampling and data collection by demographic data form and 2 questionnaires. Psychological distress related to e-learning questionnaire consists 23 questions, include 3 subscales that scoring 5 from Likert scale range from 1 to 5. Total score range from 23 to 115 and based off cutoff point categorized to 3 level of mild, moderate, and severe. Validity and reliability of this questionnaire confirmed by Hassan and Bao, and in this study by alpha chrome 1 coefficient confirmed. Online learner readiness scale developed by Han in 2010 and consists 80 questionnaire, include 5 subscales and scoring with 5-point Likert scale ranging from 1 to 5. Total score range from 18 to 19 and categories level by cutoff point divided into low, moderate, and high. Validity and reliability in this questionnaire confirmed in this study. Ethical consideration considered in this study by approved by ethical committee and following the guideline of Helsinki and description of aim, usefulness, and announcing of anonymity and privacy and instruction for filling the scale. Data analysis by SPSS software version 22 and conclude normality distribution by KS and use of parametric tests such as t-test, ANOVA, and coefficient Pearson correlation. The findings show that the most students was female in 5 and 6 semester. The most students was single and no cigarette smoking. The mean and standard deviation of age is 21.9 and standard deviation is 2.6. The findings of this study show that the level of psychological distress related to e-learning is shown in this slide, and 61.7% of students have moderate psychological distress. Related to online learner readiness, 56.1% of students have moderate level of online learning, and this study showed that a significant negative correlation was found between online learning readiness and psychological distress in dimension of self-direct, learner control, motivation for learning, and online communication self-efficacy found a negative, mild to moderate correlation between this dimension and psychological distress related to e-learning. The results of this study show that students who were less readiness for online learning had more psychological distress in e-learning. And this result supported by a study of ACMA that showed that during COVID-19 epidemic, the academic stress perceived by students related to readiness for online learning. Borrowed studies show that anxiety have had a negative effect of perform learning activity. And a study showed that mild anxiety increased speed of reaction and alertness of the brain and increased learning, but Excessive anxiety reduces learners' interest in learning and hinder academic achievements. This study showed that students who had lower self-directed had more psychological distress in e-learning. This study is supported by Alemany that shows students with higher level of anxiety had lower academic self-efficacy. A sense of independency, responsibility, internal control in learning process is motivating factor to control learning conditions. The results of study of Harvard show that self-guided learning can help reduce perception academic stress by increased self-esteem. Seems that the support students during self-directed learning is important to reduce psychological distress in nursing and midwifery students. The results of this study show that students who had lower learner control had more psychological distress in e-learning. These findings supported by Jean that show students who have more control their management time have better academic performance and less stress. Ability to control learning allows the students to act independently in setting appropriate learning goals and methods, completing assignments, and generally manage various parts of their learning. This study showed that students who had lower motivation for learning had more psychological distress in learning. This study supported by a study of Tameli that showed that low motivation for online education was an important risk factor in increasing a student's psychological stress in online learning. The students who had low online communication certificacy had more psychological distress in e-learning. This finding supported by Baloto that show decrease in communication associated with an increased burnout, anxiety, and depression in online learning. But social networks such as Facebook and LinkedIn strengthen communication between students and faculty and promote collaboration learning. Support the student to communicate, help share knowledge, experience, and collaborating learning. And using collaborating learning method can improve interaction with learners that may initially raise fear of negative evaluation, anxiety about inactive students in this group, but gradually the students' anxiety decreases and leads to positive interaction between the group members. This finding things that show the support students for better communication may be reduce psychological distress in students. Overall, this study showed that students who were less ready for online learning had more psychological distress related to e-learning. The finding highlights needs to support and empower students to online learning, screening for psychological disorder, providing support and counseling resources to promote the students' mental health. Thank you for paying attention to this presentation. Thank you.
Yes, this was the presentation from Dr. Sharahere Mohammadi from Iran.
Sharahere Beghani Mohammadi.
Yes, madam. Any questions? Dr. Sharahere Mohammadi. If you have any questions, just ask through chat box. If possible, even after the completion of the conference, you can mail us officially. We'll be asking the concerned speaker.
Supported faculty of students in class for better communication, for use of elements and tools in LMS, and the counselor of students in during COVID-19. Many students was very anxiety, depression, and psychological disorder, and empower faculty member to support the students. It's many important.
Yes, ma'am. Any questions? Any further questions?
Thank you very much.
Yes. Yes. Thank you very much, madam, for participating in this event as speaker for the event. We want to thank you for instant presentation. Thanks for sharing your tips with us. Looking forward to meet again next time. Also, on behalf of organizing committee members of Nursing Education 2021, we want to thank you for instant presentation. Next, we ask Dr. Nivis Olhoch from Jarmoki Ogingo from Kenya, Referral Hospital from Kenya, to start the presentation. The topic will be management practice of cancer related pain in Shoe for Africa Children's Hospital.
Hello.
Yes, ma'am.
Thank you very much, Innovine, for giving me the opportunity to be able to present my research today. Good morning, everyone. Good evening, good afternoon. So my research today is on management practices of cancer-related pain in patients in Shoe for Africa Children's Hospital, Moi Teaching and Referral Hospital, which is located in my country, Kenya. My name is Nevi Solwach, and I'm a nursing officer intern at Jaramogi Oginga Odinga Teaching and Referral Hospital. So on the introduction, pain is an unpleasant sensory and emotional experience with actual or potential tissue damage. And cancer pain itself is a complex phenomenon, and there are various pathophysiological mechanisms that are responsible for it. And as reported by both the parents and their children, pain is a common distressing symptom of pediatric cancer. And parents have reported pain as one of the most problematic area for their children when receiving cancer treatment. And children often experience cancer pain from the disease itself, from the side effects of treatment, from the procedures, and from psychological distress. And although children with cancer experience the same type of pain as adult patients with cancer, children are, however, emotionally vulnerable, and therefore their early life experience can influence the trajectory of their lives. And over the past 10 years, insightful research into pediatric cancer pain has focused on pain management, and parents and healthcare providers report using both pharmacological and non-pharmacological pain management strategies. And the most frequently used physical or psychological strategies reported by parents include distraction, relaxation, deep breathing, and talking to their children. And acetaminophen was the most reported pharmacological pain management by the parents. Other pharmacological strategies that were used included brufen, naproxen, morphine, hydromorphone, gabapentin, and amitriptyline. So my research purpose was to evaluate the management practices of cancer-related pain in patients in Shoe for Africa Children's Hospital. And I came up with two research objectives, which were one, to describe the documented pain management practices for cancer-related pain in use in Shoe for Africa Children's Hospital, and to describe the caregivers' reported pain management practices of cancer pain in their children at Shoe for Africa. So the study was conducted in oncology unit, Shoe for Africa, and I used a quantitative descriptive study design. Sorry. And 121 pediatric patients and 70 caregivers in the oncology unit were purposively sampled. I included all the pediatric patients in the oncology unit during the study period who gave their consent to participate in the study and excluded the critically ill pediatric patients and those who appeared mentally disturbed. So I used the checklist to collect my data, and I administered the checklist to extract data on the pain management strategies. And consequently, I administered questionnaire to the caregivers of hospitalized patients to gather data on the undocumented pain management practices that were in use. So I used SPSS to analyze the data descriptively, and descriptive statistics, including mean and standard deviations, median and interquartile ranges were computed. On the findings, a brief on the demographic findings of the children. The mean age of the children was 7.28, and the oldest was about 14 years. Majority of them were male at 54.5%, and only 19% of the children lacked health insurance cover. Most of them were Christians and were at their primary level of education. So most of the children were diagnosed with leukemia at 23.1%, and non-Hodgkin's lymphoma came second at 14%. Nephroblastoma and Burkitt's lymphoma were at 10.7%, and the least medical diagnosis was retinoblastoma at 8.3%, and others included neuroblastoma and hepatoblastoma. So concerning documented pain management practices, paracetamol and pafalgan were the frequently documented pain management practices, and they were frequently administered during the entire hospital period. And morphine was averagely administered during the entire hospital stay. Tramadol and brufen were the least administered pain management practices during the hospital stay. On the reported pain management practices, the caregivers reported paracetamol as the frequently administered pain management at 80%, followed by morphine, which was administered at 38.6%, and aspirin, pafalgan, and Zulu were the least administered pain management practices as reported by the caregivers. So on the non-pharmacological pain management practices, the caregivers reported to have used distraction more often at 82.9%. They also prayed to their children in order to alleviate pain, and some of them listened to music in order to drive their attention away from pain. Other non-pharmacological pain management practices that were employed included walking, relaxation, use of imagery or visualization, use of massage, cold pack, heat, breastfeeding, and also talking to their children. So on my discussion, my findings show that paracetamol was the most frequently documented and reported pain management practice, which is consistent with what was reported in Germany and in India. The results also show that morphine was the second most reported pain management intervention. However, these findings are not in line with what was reported in the USA. And also distraction was the most utilized non-pharmacological cancer pain management strategies as reported by the caregivers. And studies among pediatric oncology patients in Canada and China reported a similar practice. And caregivers also reported using relaxation and music therapy to alleviate cancer pain in their children. These findings, they mirror what was reported in Canada. And lastly, caregivers reported using massage and heat to control cancer pain in their children. These findings are also consistent with what was reported in Brazil. So in conclusion, both pharmacological and non-pharmacological practices were explored, and paracetamol, morphine, and pafalgan were the most documented pain management interventions for cancer-related pain in children. Paracetamol, morphine, and brufen were reported as the most commonly administered medication. And on the non-pharmacological pain management practice, distraction and prayer were the most commonly used pain management strategies. So I would like to acknowledge God for bestowing good health upon me during the entire research period, and also my supervisor, Dr. Chololo, for his guidance during the entire research time, and all those who participated during the research process. So these are my references. Thank you.
Yes, ma'am. Any questions to Dr. Nevis? Any questions? So, yes, thank you very much, madam. I think there is no questions from our participants.
Thank you.
Yes, thank you so much for joining as speaker for this event. Looking forward to meet again next time.
Thank you.
Yes, thanks for sharing your tips with us. If we go to the speakers, list of speakers for day 2, we do have Dr. Aisha, Dr. Kavalar Inosia from Cameroon, Dr. Gossa Tifisia from Ethiopia, Dr. Tracy. We do have 4 more talks. So we are going around 40 minutes ahead of actual program. So just we'll take 10 minutes break and we'll join with Dr. Fatime. Just we'll have 10 minutes break. Yes. Yes, doctor. Yes, we asked Dr. Fatima Rahimikian from
Yes.
yes, from School of Nursing and Midwifery from Tehran University for Medical Science from Iran. The topic will be relationship between midwives, emotional intelligence, and mother satisfaction from midwifery cares. You can start sharing your slide, madam.
Hi everybody. I'm glad to participate in this conference. Thanks all the people involved in organizing this amazing event. I'm Fatima Rahimikian, instructor of midwifery, the co-founder and board member of Nursing and Midwifery Care Research Center of Tehran University of Medical Sciences. And today I'm going to share our latest findings regarding the relationship between midwives' emotional intelligence and mothers' satisfaction from midwifery care. First of all, in the introduction, emotional intelligence is a set of interconnected cognitive and emotional abilities that help a person become aware of the emotions that facilitate thoughts by receiving, evaluating, and accurately expressing emotions. In this way, a person can make logical and responsible decisions by balancing her thoughts and feelings. Amongst available human resources to provide pregnant women special services are known to be midwives as especially trained, cost-effective, community-based care. Previous studies and experiences show that improving midwifery skills results in the reduce of mortality and morbidity. Midwives are supposed to be able to establish a proper and empathic social relationship with pregnant mothers while managing their emotions and feelings. These abilities are considered to be the components of emotional intelligence. Extreme time pressure, critical situation of the patient or client, alongside personal factors related to manpower, makes the workplace intolerably stressful for midwives. The subcomponents of emotional intelligence are self-awareness, self-regulation, motivation, empathy, and social skills. There is an inverse relationship between mental health and the job stress. People with higher mental health experience also job stress. On the other hand, there is a direct link between high emotional intelligence, importance, and prominent role of human resources in any organization addressing issues that increase employee performance, resulting in increased productivity, draws the attention of experts. About study design and objective or goals, this cross-sectional study was conducted to investigate relationship between midwives' emotional intelligence and mother satisfaction from obstetric and midwifery care. According to the census, 101 midwives working in the maternity wards of the North Khorasan affiliated hospitals demographic statistics, and emotional intelligence questionnaire cyber completed. And in the sample size per midwife and a mother who had inclusion criteria means 101 mothers after delivery, both demographic and delivery MACI satisfaction questionnaire completed. To describe the findings, the following tests were used: Kolmogorov, Smirnov, Kaya-Square, and another. And in the findings, the majority of midwives, 83.2%, had a good level of emotional intelligence, and 8.90% excellent, and 7.90% were in a medium level. Another that the majority of mothers, 70.3%, were very satisfied midwifery care. As you see in the slide, 29.7% satisfied and 70.3% were very satisfied. The occupational factors such as type of employment, documentation, type of shift work, job experience, the courses completed, and income had a statistically relationship with emotional intelligence with p-value less than 0.05. Among the subcomponents of emotional intelligence, self-awareness had the highest score with 25.40, and social relationships had the lowest score with 14.78. And the results showed that there is a statistically significant relationship between emotional intelligence and maternal satisfaction from midwifery care with p-value less than 0.01. Conclusion, overall evaluation of emotional intelligence showed that the midwives have a high score. However, in other aspects such as social communication skills and empathy particularly need improvement to not only achieve higher score in them, but also enhance the emotional intelligence score generally. It is worth mentioning and recommending that holding midwifery training courses or workshops are required to enhance skills listed above. Thank you for your attention, and meet my school in Tehran, University of Medical Sciences and these pictures are about my clients after delivery in the lactation, the babies, and these pictures about my colleague in the labor, nursery, and postpartum wards. Thanks a lot. I would like to express my deepest appreciation of you. Thank you very much.
Yes. Any questions? Any questions to Dr. Fatime? Yes, thank you very much, madam, for joining this event.
Thanks a lot.
Thank you very much for nice speech. Thanks for sharing tips with us. Next, apart from Dr. Miss Aisha, we do have Dr. Tracy from CCRN College of Southern Nevada. So she'll be joining after 30 minutes. So we need to manage the program. So meanwhile, we ask Miss Aisha Abdul Khadi Ariana from Nemotonic from Nigeria to start the presentation. Start sharing your PPT. Yes, madam, you can start presenting your talk.
Hello.
Yes, start sharing your slide.
All right, all right.
Select a proper place. Just we are getting somewhat disturbance from your side. Go with the proper internet so that everyone can audible your voice clearly.
Is my screen visible?
No, not yet.
Okay.
Will you share to us so that we can play behalf of you?
All right, all right.
You
I'm
can,
trying to get it.
yes. If you are facing any problem from your, just you can share to him.
Hello. It's showing me unsupported file.
Or else do one thing. Just you can share your PPT to me. I'll be sharing from here. You can just yes, I mentioned you that two email IDs as well as one WhatsApp number. You can copy from anyone, either email ID or WhatsApp number. Send me immediately. I'll be playing from here.
Oh,
you can send me even through WhatsApp.
Should I share it to you via WhatsApp?
Yes, yes.
Oh, all right, all right. Let me quickly share it with you via WhatsApp.
Yes, yes.
I've shared it with you via WhatsApp.
Not yet received. Not yet received. Just resend it again.
Have you seen it now?
Resend it.
Have you seen it now?
Yeah. Yes, we got it.
Yes, check your WhatsApp.
Yes, we got it. Just.
All right.
Just be online. Just be online.
Hello.
And just be online.
My name is Aisha Abdulkader Haruna. I'm a freelance proofreader, health economics, and digital marketer who works remotely in Kano, Nigeria. I'm here to present a webinar on the topic Insights and Innovations in Public Health. Innovations continues to be critical to tackle diseases without known cures and to help increase uptake and adherence to interventions that work. The McKinsey Global Institute identified 10 promising innovations which are now in progress that could have a material impact on healthcare by 2040. That is in the next 2 decades, hopefully.
Excuse me, madam.
We determine the impact of these innovations.
Yes,
Hello.
I'm going to share your slide. Just as soon as I slide,
Hello.
just to mention the word slide change, because delegates will be confused. Just to mention the word slide change. Yes.
All right.
Yes, continue your talk. We are on second slide.
I'm making an explanation on the first slide.
Okay. Okay.
We determine the impact of these innovations by interviewing experts and evaluating the current biological understanding of each disease, as well as the effects and excitement surrounding the techniques and technologies that address the greatest unmet needs. These innovations we have identified are more digitally enabled than those of the past. For example, a new app, we can move to the next slide.
Yes,
there is a new app developed to help neonatal intensive care unit families through stressful situations of having premature babies, and the app can be downloaded on iPhones and Android phones of using it globally. We can now move to the second slide. Then the third slide as well. This app can be downloaded on iPhones and Android phones with the aim of using it globally. Going forward, the 10 promising inventions and innovations identified by McKinsey Global Institute of Health includes omics and molecular technologies. Let's move to the next slide. Some omics and molecular technologies engineer intracellular components or analyze them, such as the proteomics and transcriptomics. Example, the CRISPR and curbing malaria. The current treatment includes anti-malaria prophylactics and non-pharmaceutical measures such as the indoor residual spraying and insecticide-treated bed netting, especially in the evenings for pregnant women and the neonates. This may significantly reduce disease levels by propagating the modified genes across the mosquito populations. Let's move to the next slide, please. We also have the nutrigenomics, which is a combination of transcriptomics, proteomics, and metabolomics. These are analytical methods used in determining the metabolic effects of ingredients and food. which will designate nutrition program for sustaining health development status and preventing diseases. Our mixed approach may be considered in order to reach the possible interactions between dietary components and energy balance. The next slide, please. The next on my list is the next generation pharmaceuticals, which is identified by the McKinsey Global Institute of Health. These are newer iterations of traditional chemical compounds and classes of molecules which could be used as medicinal drugs, possibly with multiple on concurrent target structures. Example, we have the senolytics. Please, let's move to the next slide. Senolytics and cellular regulation of aging. Cellular aging is considered an unavoidable physiologic process, but senolytics is a class of small molecules which may be eliminated or decrease the aging cells that can cause cellular inflammation, dysfunction, and tissue damage. The next slide, please. We also have the sodium zirconium as an example of next generation pharmaceutical. Sodium zirconium silicate, which are available as powders. They can be mixed in water and administered orally to treat hyperkalemia. This results in lower serum potassium levels, rapidly dissolves after an hour of ingestion in the gastrointestinal tract. Let's move to the next slide, please. We also have protacs, which are two-headed molecules connected by a linker. They have potential to produce long-lasting biological effect. Then we now have the cellular therapy and regenerative medicine. Cellular therapy is a biological product derived from living cells that are used for therapeutic purpose to replace or repair damaged cells or tissues. Regenerative medicine has the power to restore diseases or injured tissues and organs. Example, we have the CAR-T cell therapy and the treatment of solid tumors. Let's move to the next slide. This reprograms a patient's T cells immune to target tumor cells. When infused into the patient, the T cells bind to an antigen on tumor cells, attacking and destroying them. We have the hematopoietic stem cells, also called the bone marrow transplant, which is used to frequently treat variety of blood cancers and hematologic conditions. Let's move to the next slide, please. We also have the tissue engineering and transplantation of laboratory-grown organs in tissues. Regenerative medicine is closely associated with repair or replacement of the whole tissue. That is the bone, the cartilage, the blood vessels, the bladder, the skin, etc. Hematopoietic progenitor cells, the HPCs, or the hematopoietic stem cells, the HSCs, they are used in the treatment of many malignant diseases like the leukemia and the lymphoma. So also in the treatment of non-malignant diseases like the sickle cell disease to replace or rebuild a patient's hematopoietic system. Let's move to the next slide, please. Then the next slide. The next on my list, identified by the McKinsey Global Institute, which hopefully will be used by 2040. Some of these innovations are in the market, while others are still in progress, is the innovative vaccines. Historically, vaccines have eradicated or controlled the spread of infectious diseases around the world. In future, vaccines may target non-communicable diseases such as cancer. Example, the AT4A vaccine and lowering of cholesterol. The AT04A vaccine is made up of molecules that bind to the blood cholesterol and degrade it. This vaccine could be required only once a year. Let's move to the next slide. Next slide, please. We also have recombinant DNA technique, which involves production of potential new hepatitis B vaccines. The DNA sequence coding for hepatitis B surface the antigen incorporated into the yeast and activate it to synthesize the antigen, which is then purified. All these recombinant DNA vaccines offer promise of effective product that has less reactive and less expensive. The next slide, please. We have the anti-idiotype antibodies, which are directed against the antibody to the hepatitis antigen, which induce protection against hepatitis. We also have the mRNA vaccines and DNA vaccines, which have been previously activated against. They can be more easily manufactured than the next slide. We move to the advanced surgical procedures. These include treating injuries or disorders of the bodies with minimally invasive incisions and small instruments, including robotic surgery.
Hello. Hello, Dr. Aisha. Continue your talk. Yeah, Doctor, I should just continue your talk. Huh? Huh? Call Jerome, call Jerome, I should. I think Dr. Aisha is having internet problem. Let's wait for 2 to 3 minutes. Let her join and deliver a talk. Hello, Doctor. Yes, continue with the talk.
I'm sorry, I'm having some technical issues. I'm sorry, please, I'm having some technical issues. Okay, now we move to the advanced surgical procedures. As with many aspects of our life, also extended the practice of medicine into telemedicine. Very soon, surgeon webcast, virtual and virtual wards are being operated everywhere from Australia to the United Kingdom and the Middle East. Another example is half of the cardiac surgeries are now catheter-based. Let's move to the next slide, please.
Yes, madam. Go ahead.
Another,
Go ahead.
another example, let's move to the next slide, please. We now move to the cognitive and cognitive devices. This is among the 10 promising interventions promised by McKinsey Healthcare, which could have impact by 2040. Connected and cognitive devices are portable, wearable, and ingestible implantable devices. This can monitor healthcare and fitness information, engaging patients and their communities of healthcare givers, delivering self-regulated therapies autonomously. Example, we have the e-tattoos for heart diagnostics. We have the ultra-thin e-tattoos, which can monitor hearts for longer period and make patients more comfortable in clinical decision-making. Next slide. Next slide. We also have the wearable biosensors, which are small, light-weighted, one on the body to monitor vital signs, such as the temperature, heart rate, breathing rate, hence providing professionals with critical insights into the progression and early onset of an illness. Like this device showing on my screen is an example of the device designed by Felix. It's designed to monitor COVID-19 patients in the hospital, detecting early signs to avoid deteriorism. This device VX100 was first installed in the Netherlands, where it has been used to remotely monitor patients in isolation rooms who are diagnosed or suspected of COVID-19 but don't need ventilation. Next slide, please. We also have the smart thermometers. Next slide. Next slide. These are connected inhalers. The next slide. Smartwatch monitoring. The next slide. Then the next slide. We have the electroceuticals. Electroceuticals are therapies that map circulatory organs and administered by implantable device delivered to specific targets. Example of the microchips to medicate chronic pains. This technique is now under development, stimulating the spinal cord, which can improve the patient's quality of life by increasing mobility, enhancing sleep, and reducing the need for pain medication. Next slide. Next slide, please. Example of the electroceuticals include the electrodes for biological interface. These are interactions that exist in implantable bioelectronic system exchanging electrical signals with human body, such as the implants restoring hearing for people who suffered from profound hearing loss, the deep brain simulation. The next slide. Next slide. We have the robotics and prosthetics. Many of us are familiar with this one because there are a wide range of variety of programmable self-control devices consisting of artificial substitutes or replacement for body parts which are now under development. Example is the next generation pharmaceuticals, electroexoskeletons, and mobility support, which are powered by small motors to mimic human muscles, which allowed older patients to recover their autonomy while reducing the likelihood of accidents and fall. Next slide. We also have the technicals, the robotic surgery. The next slide. Technological integration of artificial intelligence, machine, and machine learning in prosthetic and orthotic industry. Also in the field of assistive technology, which has become boon for persons with disabilities. The next slide. The next slide. Then we have the digital therapeutics. These are preventive therapeutic evidence-based interventions for broad spectrum of physical and mental behavioral conditions, which are controlled by software. Example, an AI-powered app to change behavior in the future. The digital therapeutic powered by AI patient data and behavior science can be used for gamification and other forms of engagement to help patients adopt and sustain healthy behaviors. The next slide. Next slide. We also have a mobile medical app like the one I mentioned earlier, used for neonatal delivery of premature babies, the IFCD app, intended to treat physiologic therapy and dysfunction caused by neurological, then there is intervention or cognition. Next slide. There is digital delivery of education for chronic and back pain patients. The sleep improvement program and the treatment of ADH delivered through engaging video experience, especially in the adults. Some of these apps are in the market while others are still under development. The next slide. Next slide. This is the example of the ADHD app, the video game app. The next slide. Next slide. The last on my list, identified by the McKinsey Global Institute of Health, which could have promising interventions by 2040, is the tech-enabled care delivery. These are ways to deliver care and help providers apply them to patients so as to improve outcome, experience, and efficiency of care. Example, the multi-channel care delivery, innovative multi-channel care delivery using online platforms, which may facilitate data sharing and make treatment more efficient. This is particularly relevant for chronic diseases such as diabetes. Next slide. Next slide. We have the automated insulin delivery system, AID, which monitors blood glucose levels of patients continuously, even while they are asleep. The next slide. This is an example of the COVID-19 watch, which carries remote patients multiple times a day by text message. Then creation of pregnancy watch based essentially on the clone of the COVID-19 watch system. Next slide. a pen digital utility that has power of dealing with hundreds or even thousands of patients simultaneously, monitoring their input, responding to clinically relevant changes, and triggering appropriate kinds of healthcare responses. This system is suited for managing enormous patient demand and anxiety like the COVID epidemic. The next slide. Is that the final slide?
Yes, almost completed your slides, madam. This is the first page.
All right, so I'm really thrilled to be part of this team. Thank you everyone for listening. I'm open to questions.
Yes, any questions? Yes, any questions? Any questions to Miss Aisha Abdul Khadi? On a topic, innovation continue to be critical on tactile diseases without knowing cures and help to increase uptake and adherence to innovative that work. Just if you have any questions regarding this topic, you can mail us officially. We'll be asking the concerned speaker to reply us within 3 to 4 days after the completion of the conference. Yes. Yes, thank you very much, madam, for joining this event, delivering your talk. However, some technical problem, sir, no problem. Thank you so much for participating in this event. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for its presentation. Looking forward to meet again next time.
It's my pleasure. Till then.
Yes, definitely. Yes. We do have 2 more talks for today's sessions. That is Dr. Tracy Long, CCRN College of Southern Nevada, USA. We asked Dr. Tracy to join the Zoom meeting and start your presentation. The topic will be using rooms escape gaming to improve critical thinking for nursing students. Yeah, Dr. Tracy, just you can start sharing your slide. This is your time to represent your talk. As we are 42 1 hour ahead of our actual program, that's why we request you within 4 to 5 minutes get ready with your PPT and start sharing your slides.
Hi, was that an introduction that I'm next?
Yes. How are you, madam?
Yes?
Yes, you can start sharing your slide.
Very good. All right, nice to be with you. It's fun to have a conference that's international around the world that's happening right now. So that's impressive. Now, I'm hoping you can see these slides. Tell me if you can.
Yes.
Perfect. So what I'm going to be talking about today was actually inspired by another speaker last year for this very conference. And she was talking about different nursing teaching strategies. And I'm always interested in that, as the dissertation was about different teaching strategies for teaching cultural competence for undergraduate nursing students. So my topic is using an escape room in nursing education to enhance critical thinking. So put in the chat box if you're familiar, yes or no, with an escape room concept. Put that in the chat box. I'm curious to see who has been exposed to that. Looks like my camera has frozen for a minute, so not sure why. Well, anyway, an escape room is a concept where participants go into a preset room. There's some type of a task and a mystery, and they cannot be unlocked out of that room until they solve all of the clues. And so a room similar to this would have a group of 4 to 5 different people. There would be pictures and clues and lock boxes all around the room, and they've got to figure out how to unlock all of the clues so that they can finally literally unlock themselves out of a room. It's been created as just a fun recreational activity, some activity for people to do in a community. I live in Las Vegas, Nevada, here in the United States of America, and escape rooms have been a really fun activity. During COVID, of course, that was a little different and that was shut down. But prior, instead of people going to play bowling or going to the movies, many people would go to an escape room because it's a fun group activity. Well, the concept is that the escape room concept is something that we can use for nursing students as they continue to learn to think. Yeah, okay, so I'm looking at the chat box. A couple of you are familiar, but not all. That's okay. Anyway, so the concept is applying this to nursing students, because in real life, nurses really do have patient clues and have to figure out what's going on. Now, they're not locked in a room or a patient's room, but they definitely have to figure out and collect clues in order to create appropriate nursing care plans and good treatments. So we developed this for students in the Nursing Fundamentals program at a college where I teach here in Las Vegas, Nevada. And so we gave them various different clues based on a patient scenario. And the bottom line is they did have to escape from this virtual room and make sure that the patient was going to be safe. So that was really what their task is. So I wanted to show with you what is it that new grad nurses have to know? That's what we as nurse educators always examine is, okay, what do they have to know? Well, the United States National Certification Licensing Exam, known as the NCLEX, outlines what is it that they really have to know? Well, we guide our curriculum based off of that and accreditation criteria. But a big concept is that nursing students, they have to know tons of information in order to become a safe new graduate nurse. And so nursing instructors are constantly having to look for what are new innovative ways to help them become critical thinkers and master the physical skills of IVs and NG tubes and all of those physical skills. So we've lumped that into a concept called critical thinking. So what is critical thinking? Critical thinking is, as defined here, a mental process of actively and skillfully perception, analysis, synthesis, evaluation of collected information by observing, experience, and communicating with other team members and with the patient that leads to a decision for action. Critical thinking is applied by nurses to help solve problems in patient care for a safe, efficient, and skillful nursing intervention. And it is the responsibility of the nurse educator to ensure that nursing graduates have developed critical thinking abilities necessary to practice the profession of nursing. What we don't want is robotic nurses. We need nurses that can be critical thinkers, think outside the proverbial box, be able to collect data from a patient that's not doing well, and be able to then move to interventions and action. So couple different techniques when we look at, well, how do we teach this? There's some passive strategies and very active strategies. Passive strategies that have been used as nurse educators for decades has been lecture, stand up and deliver a lecture. And that definitely has the advantage of being able to convey a lot of information in a short period of time in an organized manner, especially if you're using PowerPoints that can outline information. But the student sits passively, and we know that. Quizzes, well, they have to actively learn the information, but they have to take the quiz. Close-ended questions, meaning yes, no questions, doing readings, doing writing assignments. And even though writing is actively writing, it's still an isolated kind of an experience. The reality is that nurses work in teams. It's a very vibrant, dynamic environment. And so we look for what are active ways to enhance learning. So case studies have been used where students get a patient scenario. They have to explore it, discuss it, answer questions together, pull from each other's knowledge, and as a group come up with something, and that's actively involved. Doing other projects, for example, having students create pamphlets that they would give to a community group on HIV/AIDS awareness or vaccinations or something like that. So when they're kind of a group project is very active, it gets them involved, it gets them to be able to think in application terms, asking open-ended questions. Tell me how you would do the whatever. Explore the best solution for whatever. So those are more active teaching strategies. Playing games. Nursing students love that. And frankly, anyone does. Role playing, and then now we add to this list nursing escape room. So let me show you how that works. So nursing students have to collect clues from a patient chart. They have to be able to do a physical exam, and we had them use an advanced simulation mannequin. They have to identify what the problem is. They have to know what their resources are. They have to follow standards of care, all of that in order to solve the problem to achieve best safe patient outcomes. Now, there have been other studies that have been done looking at these escape rooms, and what the conclusions were is that students were engaged with learning. They collaborated with team members. It increased their focus to solve a problem. They had fun in the process. And then they talked about their experience with their own peers, because that was a fun experience. So in a study that I did with our nursing students, we found exactly the same findings, which were very positive. So here was a group of fundamental nursing students. It's their very first semester in nursing school. They've already completed anatomy, physiology, the chemistry, biology, all of those core classes, and now they've entered into the actual nursing program. This was an accelerated baccalaureate of nursing program here in Las Vegas, Nevada. In these fundamental students, we had 62 of them. 9 male, 53 female, and then the demographics by ethnicity were as follows. So we had a good mix of a very diverse population, which we have here in Las Vegas, Nevada. And you'll notice that whites are actually a minority in this particular city, which is very true. We offered, it was a convenient sample study because we were using all of the students in their very first semester. And so they were not graded, they were not forced, but once they heard the experiences of one group, everybody wanted to do it. Now we divided them into groups 5 or less, or rather here, less than 5 ever did a room escape before in Las Vegas, but we also did divide the groups into small groups of 5. Too much people in a group, too many would mean that not everybody was actively doing something. There would be some that were sitting back. So our method was, this was a qualitative phenomenological study with an anonymous post-intervention survey. We didn't do a pre-survey because they didn't have anything to base it by, because only 5 of them had done an escape room before. Participation was not required, but 100% wanted to be involved. They knew that it was a novel teaching strategy. They were excited to try something new and different. So one instructor was needed. I had an assistant who helped me because we had so many students in each of these different classes that one of them was running the actual escape room. The other one was keeping all the other students engaged. We did this during a regular nursing lab. So our experimental group, eventually everybody got a chance to do that. So our room setup was, we used one of our regular typical lab rooms with one high fidelity mannequin in a bed. We had 14 different clues that they had to solve. We had a 4-hour lab, but the average time was about 45 minutes that it took them. And that's pretty standard for even the recreational escape rooms, that they'll max it out in an hour time. And if you don't solve it, then, oh, well, you lose if you don't solve it in an hour. They were allowed up to 3 clues by an instructor. If they completely got stuck, then the instructor was allowed to give them a hint, but only 3. And that's true in other recreational escape rooms as well. Now, we did have some distractors in the room because they didn't know what was a clue, what was purposeful, and what was not. We had crutches, a gait belt, glucometer, a hemocult that were not involved with really any of the clues, but it could throw them off, and that was just part of the setting. The essentials is we had to have an NG tube, a Foley catheter, a syringe, a 10 ml syringe, because that was going to be used to DC a Foley catheter, sterile packaging, and then regular exam gloves. We had boxes with locks. We had envelopes that had numbers on the outside, and they could only open it if they knew why they were opening it. So here was kind of an example. We had just miscellaneous things. This is just one little view of one room. Here was another one. Ideally, the main clues were on the patient, because we wanted these new nursing students to be able to, as in real life, take information from a doctor's chart and then immediately go in and begin to assess the patient. And so there was a clue, for example, a piece of paper on the back of the mannequin that they would only identify if they checked for respiratory lung sounds on the back. Now, the bottom line was this patient had a Foley catheter, and the final clue was actually wrapped around that Foley catheter balloon, and they would only have found it if they correctly answered all the other clues and then correctly discontinued that Foley catheter and deflated that 10 ml balloon. So this was kind of at the part where they were figuring out they needed to get rid of the balloon. So this is what that typical kind of classroom looks like. So again, here was the scenario that they had to answer. We had an 85-year-old white male with a past medical history of CAD, COPD, hypertension, who is a current smoker and is in your med-surg unit. He presents with complaint of nausea, some vomiting, dysuria for the last 72 hours. He lives in a nursing home who sent him to the ED due to a change in orientation and dysuria. In the ED, the vital signs were as follows. Blood pressure was 90/55, heart rate was 110, respiratory rate 28, temperature 101.2 Fahrenheit. Now, they had to be able to already identify what the normals and the recognition of the abnormal vital signs were. So to enter a room, the student had to first identify 5 symptoms that the patient was presenting that was problematic in that little scenario. When the team was correct, then they were given another envelope that said to look at that emergency department vital signs and then identify what the priority intervention was. The answer would lead them to the next clue. The process continued that they could only advance to find the next clue if they followed a correct nursing procedure and acted in a safe manner. So the students had to calculate a medication order correctly, insert an NG correctly, do sterile wound care correctly, calculate intake and output, follow universal precautions, and finally recognize CAUTI recommendations for Foley catheter use and recognize it was time to take that catheter out. An incident report would have to be completed if they calculated the medication incorrectly. So a couple groups did, and so that was a good experience. So the incident report didn't give them a clue, but it was a consequence for a medication error. So here they were trying to figure out different clues and figure out what was the next step they needed to do. So they've got 4 of them, and what I loved is how actively involved they were. Everybody was a participant, everybody wanted to answer, and everybody had a lot of fun. So here was just one example. We've got some of the nurses trying to figure out something. The others are racing to find the other clue. And there was a really great energy. There was nothing passive about it. This was their celebratory excitement after they had finished. They figured it out. They answered the last clue. They discontinued the Foley catheter, and that opened up a lockbox, which then said that they had solved the problem and the patient was going to avoid a CAUTI infection. So here was just another group, and every group was told not to share anything about it with the previous group so that it would be completely brand new. And they were really good about it because they wanted everybody else to have that similar experience. So that was really good. Now, what were the results of our study? 62 out of 62, 100% rated the learning activity as highly effective in helping with critical thinking, team communication, problem solving, creative thinking, and active learning. And that is an outstanding finding. So because it was an anonymous post-intervention survey and they were not graded, we knew that they did not have a please the teacher reply, meaning I'm going to just write what I think the teacher wants to hear because we said it was anonymous. We had no way of tracking who was rating what on the survey. So we were really pleased with that. 100% wanted to do another room escape. This was the most fun activity we've done in nursing school, reported one enthusiastic student. So overall, it was a very outstanding method to teach. So what are the implications for nurses and nursing instructors? Well, we felt that using a room escape is a very interactive learning experience to develop, test, and practice critical thinking in a simulation scenario. As I always say, the more neurons that fire together, wire together. So with changing times comes the need for changing methods of instruction and more active learning, especially in COVID times. The nursing students for pretty much all nursing schools were basically kicked out of the hospitals. The hospitals had too much to deal with during COVID and still do. However, during at least a year time frame, the hospitals disinvited students to come, and they just because they couldn't deal with having more students in an actual room and in the hospital. So we had to look at other novel teaching experiences like using our simulation. And so simulation in its own teaching strategy is outstanding. I had the privilege to be a part of the hallmark national study done here in the United States for simulation. And this was about, 6-7 years ago. The National Council State Boards of Nursing invited only 10 schools in the United States. 5 of them were BSN programs, 5 were ADN, associate degree programs. And what the study looked at was how much can we do simulation instead of putting students in a hospital? The concern was many schools were concerned about student safety, specifically in mental health facilities, and they also were competing against other nursing schools for the same hospital placements. And so essentially, there in many cities, they didn't have enough hospitals for all the nursing schools to be in the hospitals for their clinical. So they divided the each nursing school of these 10 schools divided the test cohort into 3 groups. They had the status quo, less than 10% of the learning clinical experience would be in simulation. And so normally 95% was in the hospital. The next group was 25% was going to alternate. Instead of being in the hospital, they were going to do clinical. The last group was 50-50. That meant that if you were supposed to be in a clinical experience in the hospital for, let's say, 100 hours in one semester, you would only have been in the hospital for 50 hours. The other 50 hours would have been in a simulation scenario in your particular school, your facility, or a simulation center. So the big question was, how much was that going to affect nursing students based on these different cohorts? So put your answer in the chat box. Tell me two things. Was there a difference in NCLEX pass rates between any of the cohorts? Because that was the bottom line. If one group was not going to be able to pass the NCLEX because of that change in clinical experience, then we couldn't exchange simulation. The second question I want you to put in the chat box is, which group, if any, did better on the NCLEX? And did the simulation make a difference? So I'm really curious because we were kind of surprised with the results ourselves. So let me see what you guys have put. I don't see anybody posting anything. Let's see, one person said number 1, meaning okay, so somebody else said the sim group did better. The first research question was there a difference in NCLEX pass rates between any of these 3 groups? The conclusion was no difference. So that was great. So if we substituted up to 50% of a hospital clinical experience for simulation, it did not affect their pass rates, meaning they all passed. And they chose these 10 schools based on very high NCLEX pass rates, which is really the marker. So our school had as high as a 98% pass rate. So that meant, okay, they've got their curriculum figured out. Let's see now if we just modify this one intervention, if it will make a difference. The good news is it did not. The second research question was there a difference, though, in the success of those pass rates and those scores between those 3 groups, the 10%, 25, and 50% group? So now put in the chat box, which group do you think did better? 10, 25, or 50% alternate with a clinical simulation? The conclusion was the 50% clinical simulation group actually developed more critical thinking than even the 10% group. And the reason why, you're right, Catherine, the reason why, as we projected with the study, was it was very active learning. They were given the opportunity to fail and make mistakes, where that would never happen in clinical. We will not allow a student to make a medication error. But in clinical simulation or in the escape room, sure, go ahead and make the errors. And then we're going to talk about it in a safe situation. So the conclusion with this escape room is that it was very similar to using a simulation, because it was a variation of a simulation experience, that the students thrived. They loved it. They loved being able to make mistakes that were not high stakes mistakes, like a med error, you're kicked out of the program, right? And in a simulation or in a room escape, it was all okay. It was all in good fun, and they learned from it. So that was my research on escape rooms that now can contribute to the growing body of groups that are beginning to offer those as part of the curriculum strategies in trying to teach critical thinking. So it was a super fun experience, and I'll definitely do it again. And I wrote an article for our Nevada Nursing Association about room escapes, and then offered that if somebody wants to know more information, I'm happy to share with you the logistics of exactly step-by-step how we did it. And then I have other room escapes that you can actually purchase, because it takes a lot of work to figure one out. There are a couple on the internet. Some of them require internet access for the students to actually go through an escape room, others don't. And there's a huge variety between using escape rooms for specific topics, like just for OB, just for pediatrics, just for geriatrics, just for whatever, adult health, post-op. So you can customize it based on whatever it is that you're trying to reinforce in a learning setting. So that was basically my summary of this research. And now I'm happy to open up for any questions. If you've got any if you've got any questions. Looks like my face froze again, so I'll try and reset that. And yes, I'm going to put my email in the chat box right now. And this is Dr. Tracy Long. And it starts with my last name, long4home@gmail.com. Now, let's see if I can do this quickly. And that is, if I can show you a video of, let's see if I can find it. Well, if you're thinking of any questions, I'll look for just a little short video on some of the students. And it was fun to watch them and their energy with the escape room. Does anybody have any particular questions about how to run an escape room or anything?
Yes, we have a question from Dr. Edil Matops. Tracy, can we have access to your research?
Yes, so I can, let's see. In fact, I can attach it right now. Okay, I'm going to attach, this was my write-up that as far as just how to do this particular one that we did. And then I will see if I can attach the actual article that was published. And thanks for your patience while I attach this. So you are welcome to have a copy of it. And then what I do is I Xerox it off, and you'll see there are numbers, and the numbers represented the clues that you would actually cut out and print out and put on the various items. And so it will tell you what to put that particular clue on. All right, so right there you can see the, okay, here we go. So that should have been, you should be able to see that. Now I'm going to try and do a share screen again, and I'll show you a video about a group. Let's see. Let's see. While I look for one, I want to show you another silly one because this isn't it. But while I'm looking, this is called a mannequin challenge, just for fun. We had like thunder, crashing so loud, the way that we shine like lightning strike the sky now. Feeling brand new, doing what we wanna do. No better time when me on the side, come coming alive. Oh, my friends and me, we glow so bright, we glow. Whoa, we glow. Oh, my friends and me, we glow so bright, we glow. Whoa, we glow. Shining so bright, we glow. Shining so bright, we glow. Shining so bright, we Now that was just a silly thing. So we do a lot with mannequins and the simulation. And so let me, that wasn't the one I was looking for, but I just wanted to show that to you just for fun. Let's see. And sorry, I don't have it right at my fingertips. And if we've got another speaker, then I can just forego showing you that, but I thought I had it in one of my files. Let's see. Sorry. Ugh. All right. I don't know if you're scanning through all of this. Sorry. But I wanted to show you a video. You can see lots of these nursing students. That last little video was just a fun little thing we call the Mannequin Challenge. Mannequin Challenge was something popular here in the United States where they do just that. People are standing still and they're looking for doing some object, and then that's all that was. So that was just kind of a fun little thing. The students love creative and active things like that. All right, and I think that's probably all showing you that. So let me do the stop share and see if I can find it. Anyway, while I continue to look, does anybody have any other questions on how to do that? I posted that, and then we'll post in just a minute the article that was published. And it's just a fun, novel way to have students be engaged in active learning. So that's it.
Any questions? Any questions to Dr. Tracy? We would like to inform that Dr. Tracy is joining our event since last 2 years. Yes, this was a great presentation, madam. Thank you for joining us, sharing your tips with us.
My privilege. Thank you.
Yes, yes. So we got a just 1 minute. Just I shared through chat box that simulation video from Dr. This is you can share. You can watch through from YouTube. So we do have 2 to 3 talks. I think they are not joining this event. So if you go to the vote of thanks,
I'm still trying to find that video. Where did it go?
yes, any questions to Dr. Tracy?
I'm curious in where everybody is, put in the chat box how much, for those of you who are nursing educators, how much are you using simulation in your nursing schools? And are you familiar with nurse simulation? %, UK, yeah. It's a very big teaching strategy here in the United States. And what we do is we spend as much time in the actual simulation room as we do the debriefing. The debriefing, I think, is where students also make very big connections with what they just did in the room. And we establish it as a safe place, a safe space to talk about what were you thinking when you did this action, or what were you considering, or what were you nervous about, and all of that. And that gives them a chance to really process their thinking. And often in the hospital setting, they don't even get that opportunity. They move on to the next task, and they don't get an opportunity to really process through, why did they just do that? Or what would they do differently? The classic questions that we will always ask is, what did you do that you felt really good about? And that gives them an opportunity to really feel good about, hey, I did this. I was able to walk in, introduce myself strongly, tell them what I was there for. I did a really good head-to-toe assessment, and they felt really good about that. Then we talk about, what would you do differently if you could do it again? And that gives them a great opportunity for them to go, yeah, well, I kind of messed up on this or that, which we don't allow them to do in the hospital, right? Somebody will elbow them out of the room so they don't make the errors. And so that's why often the nurse that is their preceptor for the day often won't let students do everything because they don't want them to do it wrong. Now, just for fun of it, because I found one thing, are we waiting for another speaker, or is it okay if I show another little video?
So just you are getting compliments from chat box, madam. Feedback is the lifeblood of learning. Wonderful presentation from Sipini.
Oh, interesting. And New York doesn't allow simulation to be substitutes. New York schools. Pam Jeffries, she is the guru of simulation. Yeah, that's fantastic. That's great. Do I have time to show another tiny little video of another little strategy?
Yes, go ahead, go ahead.
Unless we've got another speaker who's ready.
Yes, this is the last speaker for this session. We are going to conclude the day 2 of the conference. You can share your.
Okay, let's see if I can pull this one up. This was another opportunity where, oh, I think, I hope it's the right one. Oh, all right, maybe not. That was another, I thought this was sorry. I thought that was another one of my things. We did a relay race when we were talking about safety, movement, and sorry, I thought I had looked that one up. Never mind. We'll just keep going. Go ahead, take it away.
Yes, madam. Shall we close the program or any content to deliver from your side? Hello. Yes, doctor. You have a question from Dr. Adil. How you found your research, please?
Yes, I'll attach my research article in the chat box.
Yes. Yes. Any questions?
All right, I'm going to show another teaching strategy. This was the one I mentioned. This was a relay race for them to learn about mobility. They had to go around and learn correctly, and then they had fun doing a relay race. Oh.
Yes, we are unable to see your video, madam. Just. Hello, Dr. Tracy.
Thirty-five seconds.
Are you going to share any further PPT from your side, or shall we close your presentation?
The team is a serious lead.
Can you see the video?
No, not yet.
Oh, you can't? So you're not seeing anything?
No.
Huh.
Just we are seeing only your face. No, we are not unable to see.
Oh, all right. Well, then we'll just stop that. I don't know why you're not able to see that. Okay.
Yes. Are you going to share any video from your side?
Well, I was trying to, so I don't know why it didn't play.
Yes.
So
take your own time. You take your own time. You can start sharing.
Want me to try again?
Yes, yes.
you see it now?
Yes, yes. The video is played.
Okay, so this was another active learning experience. They learned about mobility, and now they're doing a relay race. You could see we're still wearing full masks in classrooms because of COVID.
35 seconds.
So each group had to do different tasks, but as they get more competitive, the energy increases in the room, which was fun.
One team has a serious lead. You're allowed to go faster. Oh, those long legs are gonna help.
She was doing crutches
Okay,
correctly.
one team's already on round 2. Whoa. We have a serious lead. Whoa. All right. All right, that team wins.
So that's just an example of using a different active learning. We could have stood there and lectured about body mechanics, but doing something like that made it a whole lot more fun. Of course, you might still be able to see this. We use nursing students here in Las Vegas to do COVID clinic. Here is the one I wanted to show you about the room escape. So here they go.
No.
Maybe.
And that's what we want nursing students to look like when we are teaching nursing school. All right, so that's the end of that presentation. Thank you so much for letting me share those ideas for any of those of you who are nursing instructors looking for creative ways to engage the students more, to become critical thinkers, which we need so much more of today. So thank you so much.
Thank you so much, madam, for showing all your videos, what you're having experience in your clinical side. Yes, any questions? Any further questions to Dr. Tracy? Thank you very much, madam, for joining us. Meeting you again next time. Thanking you for taking your busy schedule. Thank you for such informatives. This was a great video. Thanks for sharing your tips with us. If you have any questions or comments, you can text here so that we can ask behalf of the participants. I would like to inform Dr. Tracy Long is the last speaker of this today's session. If anyone are willing to deliver your talk, just you can raise your hand, you can start presenting, so that we are going to conclude our speakers talk today. Anyone are interested to deliver your talk? Yes. Yes. Thank you so much, madam, for participating in this event. On behalf of organizing committee members of Virtual Nursing Education 2021, we want to thank you for joining in this. Looking forward to meet again next time. If you go to the vote of thanks, thank you very much to all the participants, those who joined this webinar on virtual conference on nursing education healthcare that is happened yesterday, September 24th as well as 25th. During this period, having different time zones. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, general collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank the speakers who have responded so well to our invitation to participate in this conference. We have researched several papers which will inform the basis of our discussion in these various sessions. Let us thank you all those associated in this conference by your presence. And once more, we especially thanks to Program Manager Mr. Renald Thomas, as well as Ms. Shilpa, who is one of the Asia Pacific caretaker as a program coordinator for this Innovant conferences, for his as well as her continuous effort putting us together in one platform. If you go to the keynote speakers of the day 2, that is Dr. Nashad, Dr. Mary Estelle Bester, Dr. Rajni Chaudhary, Dr. Tracy Long, as well as plenary speakers of the day 2 will be Mr. Kem Jacob Matai, Dr. Vandana Bhagat, Dr. Louis Shu Fang, Dr. Sarah Phillips, Dr. Emdan Ramdan, as well as Dr. Muhammad Nazir, Professor Shakuntala Devi, yes, Professor Shahima, Professor Gunar, Professor Fabina, as well as Dr. Frida, Professor Rachel, Professor Lina, Dr. Sepini, Mr. Shaban, Professor Fatima, Professor Sharira, and Miss Nivis, as well as Aisha from Nigeria. If you go to the delegates from all over, Dr. Jakuma Govinder, Miss Carmen Govinder, Miss Chin, Miss Joanne Ferendas, Dr. Sharun Hovin, Dr. Somia, Dr. Annie Rose, Dr. Deebrus, Dr. Miss Erika. If everything goes well in 2022, hope we will join in physical event on same topic will be that will be nursing education as well as healthcare. I am especially thankful to Dr. Catherine Grisfield who managing a whole day for the conference by managing this event. I would also like to thank all the participants who we collaborate in future in physical event or as well as in virtual event. Electron booklet as well as a handbook will be sent through within 3 to 4 working days after the completion of the conference. Finally, we extend our appreciation to each of you for your participating in this online conference, having with great patience. If anything goes wrong within these 2 days, please apologize from our Innovan Meetings LLC. If you have yes, any questions, any further questions, comments, just you can text us. We'll be within 2 to 3 minutes. We are closing our event. Any question or comments you can text into through chat box. Will be closing within 2 to 3 minutes. I'm also especially thankful to Dr. Edil Mathox, Dr. Sipini, Dr. Pamela, who have stayed listening to the speakers since morning. So shall we close the program? So we are going to close the program. Just you can raise your hand if you have any questions or comments. Yes. Finally, I extend our appreciation to each of you by your participation in this online conference. Thank you. Thanks again. Have a nice day, as well as good night some parts of the world, as well as good evening some parts of the world, as well as good afternoon some parts of the world. This is signing off, Mr. Bhupati. Yes, we are going to close the program, madam. Yes. If you want access to listen to your video, I'll be sending the link here in chat box. You can copy from here immediately if you want. Just I send you the link. It will be played through in YouTube. Just you can copy today's as well as yesterday's also YouTube. Just you can type. Just type nursing education conference, that is September 24th as well as 25th. You can find both links in YouTube. Yes, you can subscribe Innovan Meetings LLC from YouTube. You will be getting updated conferences as well. So once again, I request all the participants. We are planning physical event in 2022, either in Europe or in Dubai. Just you can send your testimonials along with your ideas officially through email. You'll be getting your participation certificate after the completion of the conference within 3 to 4 days. Yes, thank you so much, madam, for your patience having whole day. Since we have run for 24 hours. Yesterday we have run from morning 3 to evening 11 o'clock. Today even we have started the program according to US New York timings from morning 4 o'clock to evening 2 o'clock. Thank you for your patience. Actually, the physical event will be having only 7 to 8 hours. As we are having virtual event, we are running more than 12 hours. Hope you understand. If anything goes wrong or error on technical issue, please apologize behalf of Innovine Meetings LLC. Thank you so much. Have a nice day. Bye.